friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us.
requesting all to please mute themselves, and whosoever is asked can only just switch on the mic.
We should all mute ourselves.
Yes, and whenever asked they can unmute.
Recording has started.
Technical team, we are ready to go.
Yes, sir.
We are live.
Yes.
Okay. Good morning, all of you. I, Dr. Rohit Batra, the organizing secretary for DAS 7th DAS E-Summit this time, welcome you all on this Sunday morning. And as you know that we are passing through COVID era where it is very difficult for us to move out of our houses, and conferences are things of the past and webinars are the new normal. So taking it from there, we thought this time round to start DAS E-Summit and to make use of your Sundays, to make use that you don't miss out on your practice. We have kept on 2 consecutive Sundays, that's today and next 12th of July. The program has been handcrafted by Dr. Shyam Verma sir and Dr. Archana Singhal ma'am, along with Dr. Ajit Tarkan, Dr. Sanjeev Gupta, Dr. Resham Vasani, Dr. Biju Vasudevan, the team DAS, and under the guidance of Dr. R.P. Gupta sir, we are here with the 7th E-DAS Summit. I will now request Dr. R.P. Gupta sir to please welcome you all and to say few words of wisdom. Sir.
Good morning, everyone, and on behalf of Team DAS, I welcome you all to this first of its kind E-DAS Summit, which is 7th in consecutive years. During these distressing times of pandemic and social distancing, it was the efforts of the Team DAS to organize this with the help of electronic media. And before even the start of DAS Summit, we have seen more than 1,000. Around 1,300 logins already there, which is very heartening to know, and which shows that the people all over the country are more interested in multidisciplinary approach, in multidisciplinary perspective in diagnosing the clinical problems being faced by us. So without wasting time, and we are all eagerly waiting for new learnings and updates during these 2 Sundays, as Dr. Rohit said, on 5th and 12th. The program has been very nicely conceptualized by our scientific team led by Dr. Shyam Verma and Dr. Archana Singhal, and of course other names which Dr. Rohit mentioned. I welcome you all once again and declare this DAS Summit open. Thank you very much.
Thank you, Dr. R.P. Gupta sir. And as with any conference or webinar, the backbone is the scientific team led by the scientific chairpersons. Now I'll request Dr. Shyam Verma sir to please tell us what all went in making this new 7th DAS E-Summit. Sir, please.
A very good morning to all of you. I think I don't know whether I should be saying welcome everyone, because this was certainly not the way we would have wanted to meet one another. It would have been so much better had we met physically, as we have done in the past 6 editions of DAS. However, with the present limitations of the scenario that we are all sharing all over the globe, this was the best option that was available. The question that Dr. Rohit wants me to answer probably can be answered best by Dr. Archana Singhal, who has, true to her surname, has been the single guiding force for crafting the scientific program, along with Dr. Resham Vasani, Dr. Sumit Gupta, Dr. Biju, Dr. Ajit, and Dr. Sanjeev Gupta. So over to her. Please, it's good to see everyone here, and good to hear that there are so many people already logged in. Over to Dr. Archana.
I guess, Dr. Archana ma'am, you are there? I guess there is some problem with Dr. Archana ma'am's end. Before we start, I would like Dr. Sumit to tell our audience what all we have got new this time in DAS, the DAS quiz that we are talking about, and how to, if anyone wants to answer the question, how to answer, and how we will be deciding the winner. Over to you, Dr. Sumit.
A very warm good morning to all of you. It is indeed a great pleasure to be doing this first sort of DAS e-summit. So because of this webinar platform, we have tried to maximize our audience participation. So there are two ways where audience can participate, and I'll just share my screen so that our audience can understand what I wish to tell. Okay, so the first is the audience quiz. So questions will be asked during the program in between sessions. First correct entry for each answer will get a gift, which is a pulse oximeter, which has become such a important tool in these times. And the fastest correct finger will get the oximeter to wear. So I'll just lay down how one can answer. So this is the home screen which our delegates are logged into. There are two parts of it. One is the live broadcast part, and the other part is the response panel. So in case you've maximized the the live broadcast, if you are watching it on full screen, you can minimize and then you can access the response panel. So I would suggest that please enter your name and location from beforehand, so that whenever the question which comes, you can directly put the answer and press the submit button, so that there is no waste of time. Also, you can see there is a field which says questions to faculty. Anytime during the presentation, you can send us your questions through this field, and we'll be happy to forward them to the panelists and the moderator. So, for instance, this is the question: how many test centuries did Sachin Tendulkar make? Some of us would know it's 51. So, correct answer is A. We just need to put the answer A in the live quiz answer. It may be a multiple choice question. It may be a one-word answer. It may be a phrase which would be an answer for the question that we put. And then press the submit button. As soon as you press the submit button, it will come as thanks for submitting. So this is how you can answer the quiz. And the first correct entry. Each question is a timed question. There are around 10, 15 or 20 seconds questions. So only the entries that come during that particular timer, only those will be considered. So the first correct answer would be given this prize. So over to you, sir. Back.
Thank you, Dr. Sumit. So as we grow with technology and we want participation from all our delegates, so we have come up with this novel idea of the quiz, and hope all of you will participate in it. And it's not about winning, it's about participation. And I guess we were not able to have Dr. Archana Singhal. There is some technical problem, technical glitch at her end.
I'm here, Dr.
Okay, sorry, ma'am. So, ma'am, please, we would
I
like
just
to...
forgot to unmute myself.
Yeah,
Good morning
please.
and welcome to all. And Shyam, as usual, at his best modesty. But as a scientific team, it's a privilege to be associated with DAS. And we know that the pandemic has had limitations of reducing our conference attendance and all. But the learning never stops. And that's why we are here with eDAS Summit, and I welcome you all. Thank you very much. I hope you enjoy the scientific program, because it's only hardcore dermatology this time, with no aesthetics or cosmetic dermatology.
Thank you, ma'am. And we are not able to have conference in person, but as far as the attendance goes, we have already got more than 1,500 registrations at this point. And before we start, I would also like to thank Lupin, our technical partner for the both the Sundays for DAS, and also our led by Mr. Jitin Batra, who has given us this platform to make sure that the relay, the quiz, and everything else, the backup team for all the participants, and not only the participant but also the faculty is taken care of. And hope you would love the educational extravaganza that we are going to have in next 2 Sundays, that's today, 5th and 12th of July. So, starting off with our first panel for the day, I would now request Dr. Biju to please take over.
Yes. Starting off the proceedings, I would first like to invite the chairpersons for the first session. Chairperson for the first session are Dr. Jekar Thomas. He is a senior consultant dermatologist practicing at JT Skin Center, Chennai. He has been the past president of the National IADVL. And Dr. Shamanta Barua, sir, who is the associate professor and head of the department, Assam Medical College, Dibrugarh. And he's been the past secretary of National IADVL. Over to you, sir.
Thank you very much, Sumit. Hello, Shamanta.
Yeah, good morning, sir.
Good morning to you. So let's start off, Shamanta. Shall I just, first of all, call upon the moderator and thank him for being here and for giving us a chance to chair these sessions. Dr. Colonel Biju Vasudevan, Professor of Dermatology of AFMC. And we have with us 4 panelists. Dr. Sujay Kanpur, Professor of Dermatology, All India Institute of Medical Sciences, New Delhi. Dr. Sanjeev Gupta, Professor and Head of Department of Dermatology, Maharishi Markandeshwar University of Ambala. Dr. Deepika Pandey, Professor of Dermatology, University College of Medical Sciences, Delhi. And then the 4th person is the Lieutenant General Retired Ved Chaturvedi, Senior Consultant Rheumatologist at Sir Gangaram Hospital, Delhi. If you are ready, Shumanta, I am also ready.
Right. I think let's hand it over to Dr. Biju Vasudevan to take over the session.
Yeah, Biju,
Thank you.
please.
Dr. Biju, you have to unmute yourself.
Unmute your microphone, Biju.
Audible now, sir?
Yeah.
Yes.
Good morning, everybody. Welcome to the DAS Summit 7th version. And this is going to be an E-version because of the COVID. Yes, so I'd begin proceedings with the first panel discussion. Do I have the nephrologist too? Dr. Manish? Not visible.
Actually, I wasn't given the name of the nephrologist. To change.
Yeah, yes, there's a nephrologist on the panel, Dr. Manish Malik.
He had some difficulty in logging in.
Okay, I'm just sending the faculty link.
He's joining in 30 seconds. Please continue. He's joining.
Okay, so I'll begin.
Please do.
Yes.
Okay. Yeah, welcome Dr. Manish. Welcome Dr. Manish.
Good morning. Good morning. How are you? Hi Biju. Good morning. How are you?
Good morning. Good morning. Yeah, so we'll begin today's proceedings with the first panel. This is going to be connective tissue disorders and we are going to discuss challenging cases. So we've already introduced the panel. Dr. Sujay Kanpur, Dr. Sanjeev Gupta, Dr. Deepika Pandey, Ved Chaturvedi sir and Dr. Manish Malik. So we have 3 dermatologists, a rheumatologist and a nephrologist on the panel. So we'll go to our... So this is the first case. This is a lady who presented with mild to moderate grade fever of 2 months duration. Just a minute. My screen has something there. Yeah.
Your screen is
So this is a
visible.
52-year-old female who presented with mild to moderate grade fever, weight loss, and loss of appetite of 2 months duration. For these complaints, she had taken some Ayurvedic medications in the last 1 month. She also developed generalized erythema and peeling of skin for the last 2 weeks. So these are the images. You can make out the peeling of the skin, some background erythema, and these are the lesions on the entire body. So can I have Dr. Deepika ma'am, what do you think could be the differential for such a patient?
This is something that we see very often. So there are 2 or 3 things. One is that the fever and other complaints are for 2 months. And the cutaneous lesions are for 2 weeks, and for which she was on Ayurvedic medication. And all dermatologists, I mean, the moment we hear of the Ayurvedic medicines, you think of erythema multiforme and, Steven Johnson and that spectrum, because these are one of the very common incriminating drugs that we come across in our practice. But here, even though the peeling is only for 15 days, the severity of the involvement, and there is nail polish, so nails I cannot comment in any way. It's not very, the focus is not there. But the oral involvement, if you see, is not very severe. Right? So the oral involvement that you will expect. So I would like to rule out acute cutaneous LE because they appear to be targetoid lesions.
Okay.
So that can be one of the non-specific signs. Vasculitis, also something I would like to rule out. I'd like to see the palms and soles and other sides too. And other mucosae.
Fine. So we go ahead with the presentation. So the patient went to a civil hospital, was put a query of erythroderma due to these causes and a drug-induced 10. And patient was given injection dexamethasone, with which the rash started resolving, but the fever persisted. Patient progressively also developed raised liver enzymes and pancytopenia, along with progressively pleural effusion, ascites, transaminitis kept increasing, and despite injectable antibiotics and also doxycycline, probably thinking of a rickettsial, the fever did not respond and the patient deteriorated. So, Dr. Vedsa, with these systemic complaints, what can you add on to the diagnosis?
Unmute.
You need to unmute yourself. Dr. Vedsa, you need to unmute yourself. You need to unmute yourself.
Yeah, good morning. Moment you have a patient who has fever, prolonged fever, weight loss, pancytopenia, and other systems involvement. So as a physician, I think what system is involved? So his bone marrow is involved because of pancytopenia. He has pleural effusion, pericardial effusion, and other hepatosplenomegaly. So first thing comes in my mind is infection. Whenever the infection so all infections, whatever we deals with, that is number one, and causing ultimately 2 months and septicemia. And number two comes, of course, since I am a rheumatologist, is the connective tissue disorders. So two things comes in my mind. The prototype disease which we deal with in rheumatology, which presents with pancytopenia, fever, and significant proteinuria, and pleural effusion and ascites is systemic lupus. So that always comes in our mind. Of course, similar findings can be there in other connective tissue, especially vasculitis and other things has to be considered. We have already discussed the differential diagnosis, so I don't want to go in this. So basically, what it comes to mind.
Infections and connective tissue disorders, yes. So we go ahead. So, however, once the injection dexamethasone was given, patient was given antibiotics, the skin rash, actually the exfoliation reduced, and now when we saw the face, as you can see, the central area, now you can see that the malar area, there is some redness which has become visible. And when the history was taken regarding this, the patient did say that she had recurrent oral ulcers for the past 3 months, though however presently she did not have any ulcers. So yes, ma'am. Now, Sujay sir, now can you give an overall view of the patient clinically?
Yeah, so it's as the history and the examination of the patient and the earlier generalized desquamation and the necrolysis of the patient is responding to the dexamethasone. The picture is becoming clear, and as my preceding panelists had mentioned, now it's becoming clear towards a connective tissue disease with SLE, because we are seeing the classic rash in photodistributed areas. The butterfly area is involved. Even the V area of the chest is involved, and it is being associated with chronic fever, with serositis, with visceromegaly. So all these features are now pointing towards a diagnosis of this generalized skin involvement in the form of an epidermolysis or a necrolysis as a manifestation of systemic lupus erythematosus.
Thank you, sir. Okay, so now the investigations were done, and this is the ANA profile. You can see it is 1:1280, speckled pattern on IF. Also, the dsDNA, SSA, and SM were positive, and C3 was low, C4-2 was low. So with this, the diagnosis, of course, point towards systemic lupus erythematosus, with the criteria for systemic lupus erythematosus being met in this patient. So, can somebody take on this? Yes, Sanjeev Gupta sir. What is about the new classification criteria for SLE? So, 2019 we've seen that a new change has again come in. Can you comment on it?
Yeah, there is a new criteria for SLE. Like we have a new UDAR criteria. So, in the major criteria, in the one most important criteria, they have given that ANA positivity should be there in a significant titer, and that too on the HAP2 cells method. And
so you have an entry criteria of ANA, yes?
Yeah, and apart from that, the general criteria which were there, now they have graded each criteria like neurological criteria, mucocutaneous criteria, immunological criteria. They have given each number to that, and the score of each category should be near about 10. So, and you have to take the maximum number of that criteria. Not you have to sum up all the criteria in each category. So you can take the maximum number of that criteria. Like hematology, if patient is having autoimmune hemolysis, so we will give only 4 numbers. Not we will take the leukopenia, which is having 3 categories.
You will take the maximum number which is present in each group. Like you can see the clinical domains here. So you can see that even if a patient has oral ulcers and alopecia, and lupus also, but if the patient has single acute lupus, till the maximum the patient can get is 6 in that group.
Yes, that is, and it should be at least 10. So I think there is now more structured as compared to the previous criteria.
More
so
structured. Okay, sir.
Each criteria has been given a
Yeah, Dr. Manish Malik, your comments on the renal criteria here, is that fine enough when compared to the previous SLIC criteria?
Yeah, if you look at the criteria in this latest edition, the renal is the heaviest criteria. Just having a single biopsy class will give you 10 points. So an ANA positive and a biopsy gets you into SLE. And that is what has been mentioned, that once the kidney is involved, then the kidney becomes the epicenter of the entire trouble. So I think this criteria is good enough from the solvent's point of view So it defines treatment and also defines vigilance from the treating physician's point of view, whether it's the dermatologist or the rheumatologist, that keeping a watch on the kidney is probably of prime importance from SLE point of view.
Totally right, sir. Okay. So when the specificity and specificity of these criteria are checked, so you find that the 2019 criteria, you can see sensitivity and specificity combined, it's definitely better when compared to the SLIC or the ACR criteria. So how do you manage such a patient? So you have now this patient, no biopsy was done in which hospital she went, but then you have a picture of SLE and you have a picture of 10. So Dr. Pandey ma'am, how will you manage this patient? The investigation shows no other cause for the fever.
Right, but you have already done the immunological profile. You showed the immunological profile. Yeah, so that we've already done. We could have added a few, if available, we could have added some of the other immunological markers that are there, and complement was also low. So as dermatologist, we would naturally do a biopsy, and we would do a DIF, and as well as lupus band. I mean, we are in an academic institute, so we like to do the lupus band test also. So it's more of a documentation, even though the diagnosis, like you said, the criteria have already been met. And now a very interesting thing, what we usually have an issue with the nephrologist, and I would like to, bring in Dr. Manish here, that somehow, the nephrologists are a little bit more hesitant in doing a kidney biopsy. Now, with these criteria, probably that hesitation will be a little lesser, because the spot urine, I don't think, was mentioned in your list of investigations. So spot urine, I mean, I would like to have Dr. Manish's comment with this change in the criteria. Would the threshold for doing kidney biopsy change?
Yes, Dr. Manish. So one is, what are the investigations for the renal, and what is the basically how will you take it on from there? Will you do a kidney biopsy? Yes.
Yeah, Dr. Deepika, hi. How are you? I
Hi.
was waiting for this.
Right.
So, which ways? So if this patient has proteinuria, which is more than 0.5 grams per day, and we discussed over the years, every year, sitting on the stage and today on this forum, that a 24-hour urine is not required. So a protein ratio, which is available in most is good enough for us to make a diagnosis. Along with
हाँ तो बाहर कर दो कर दिया ना बाहर भी कर दो
RBC cast and WBC cast would push you to do a kidney biopsy ASAP. Because as you see those criteria, these criteria are not exactly clinical from the nephrologist point of view. They are invasive diagnostic criteria. So if you have a biopsy which shows you class 3 or class 4, then the treatment aggressiveness is defined.
The treatment aggressiveness will differ.
So I think a urine protein creatinine ratio, a urine routine examination, and jump to the biopsy. If in such a patient the local skin allows biopsy. If you see this patient that she has lesion on the back also, so I would have to request my dermatologist to allow me to do a biopsy if I can.
We'll come to that, sir. We'll come to that. Yeah, thank you for that input. So we go ahead. So this patient, in addition, was given IVIG at the civil hospital. Patient improved considerably in a week. Fever resolved. Most of the systemic symptoms resolved. She was shifted to oral steroids and given mycophenolate mofetil as maintenance. However, what happened is, a month later, somehow these steroids were tapered faster than expected. The patient again went into a fresh flare. She had generalized bullous lesions and an epidermal detachment. And now you can see this is how the patient came to us. So now you have frank 10-like features of the acute LE. And of course, the diagnosis now becomes quite clear that it is 10-like LE. So, Dr. Sujay sir, what are the challenges in distinguishing this condition from a 10 in LE due to drugs from other bullous disorders like, in LE like the bullous LE or just ACLE or CCLE going into bullous lesions?
Right, and it's a very important question, and it's very important to understand whether this is a 10-like rash of SLE or is it a 10 which is occurring in the background of SLE. And as has been mentioned previously by Dr. Deepika also, we can distinguish to a large extent, obviously one, based upon the skin biopsies and the direct immunofluorescence that we do, and of course the other immunological tests that in this particular patient have come positive. So the common histopathological features between 10-like SLE and 10 would be presence of necrolysis not only in the basal layer but in the upper layers of the epidermis. In fact, the entire epidermis would be completely necrosed. The amount of inflammatory infiltrate would be significantly less than what we see in erythema multiforme. There will be a basal cell damage. But in addition, there would be thickening of the basement membrane. There would be increased amount of mucin. And it's very important for me to suggest that mucin, whenever we look for mucin in SLE, we must look for it in the reticular dermis and not in the papillary dermis, because in normal skin also, and especially around the appendages, the amount of mucin in the papillary dermis can be physiologically high. So it's important to do that. and then substantiate that with direct immunofluorescence and other immunological tests. Now having, so what actually is a TED-like SLE? It's just basically an exaggerated acute LE, or what we can say a hyperacute. Yeah, it's a hyperacute LE which comes into the realm of LE, and it's a rare manifestation of SLE. It's not that we see very commonly. It's the acute LE that we see more commonly as a feature. And another clue towards
features actually, toxic epidermal necrosis in LE would still be a predominant diagnosis because the other one is rare.
Yeah. When the patient comes with full-blown toxic epidermal necrolysis like picture with more than 30% of the body surface area, and that's the time that he's presenting, it's difficult to differentiate initially. But if the patient gives a history that the lesion started from photoexposed sites rather than from the trunk in the background of an SLE, then it's a clue that we are dealing probably with 10-like SLE. In fact, even in bullous LE, the lesions predominantly start on photoexposed sites. And bullous LE is also a kind of an exaggerated LE. Now, it occurs because of two reasons. One is that there is exaggerated basal cell damage, and therefore there is formation of a subepidermal cleft leading to bullous lesions. And of course, the other is the presence of the antibodies against collagen 7, which therefore gives an epidermolysis bullosa equisita-like picture, which is also responsible.
And you have
for
TENS bullae in this condition. You have TENS bullae.
You have TENS bullae because of the presence of the subepidermal cleft.
And of course, the infiltrate would be neutrophilic.
Neutrophilic, yes. Now, neutrophilic infiltrate is not a sacrosanct for just bullous LE. Neutrophilic infiltrate can be seen in SLE, in acute LEs, subacute cutaneous LEs. So, right, but bullous LE shows a large amount of neutrophilic infiltrate.
Fine.
Biju, I'd just like to add one thing. Biju. The terminology of ASAP, acute syndrome of apoptotic panepidermolysis, has been suggested. So
I'll come to that. I'll just ask you the same question. So basically the challenges are here that the difference is difficult both histopathologically and clinically. And of course, because SLE patients are on so many drugs, of course, drug-induced TEN is also more likely. And also LE itself can lead to TEN. So these are the challenges when you face such patients. So, Gupta sir, can you add on any more pointers towards TEN-like LE? Kanpur sir has mentioned most of them.
He has mentioned most of them. The only thing is that in a TEN-like SLE, the patient will not have a fast onset of action, like there is a gradual onset. Patient was having
it's usually subacute onset,
Subacute onset. The mucosal involvement will be a little bit more severe if it is only 10 or 10.
Only 10. So in 10-like LE, it is much lesser. Yes.
Infiltrate.
So here you can see that. Lack of evidence of ingestion of drugs, photo distribution initially, recent exacerbations, mild mucosal involvement compared to 10, and as Dr. Sujay has mentioned, the features of LE on histopath 2 and within IF profile. So yes, ma'am. Pandi ma'am, you are talking about the acute syndrome of apoptotic panepidermolysis.
What they're saying is whatever the cause, ultimately it is the same thing, that the predominant thing is that there is a severe apoptosis which causes sheets-like skin denuding. So whether the cause is 10 or it is 10-like SLE, or it is acute graft versus host disease, or it is pseudoporphyria. So the end result is the same. And if it is widespread, then these fine differential points may not be visible. Like for example, in LE, you may have, if you have normal skin, you may, even if photo distributed is not there, you may see something like a livedoid pattern a little bit, which indicates that this is LE rather than something else. And one of the other things in histopathology, Sujay is the expert in dermatopathology, so I'm adding to just one thing which has been reported, that the necrosis and the apoptosis go periappendigeal, which is classical of LE. So in addition to being on the basement, they even drop down. So that is another point. So this also is like a degree thing, and that is why they're saying it's something where it ultimately lands up into the same pathogenic process. So they are
basically it's a unifying concept of panepidermolysis. Yes.
And this concept, just to add that this necrolysis that extends into the adnexae is seen in most of the causes of ASAP, which means acute GVHD, which means the ASAP form of pseudoporphyrias, which means 10 like this SLE, all would show adnexal necrosis. I haven't seen much of adnexal necrosis in biopsies of 10 per se.
Exactly. That is the differential.
Yeah.
That could be the difference. And we've already seen these vesicular-bullous lesions in SLE and how to distinguish between them. Yes, we've seen most of this and it's been explained. As you see in 10, basically the immunofluorescence would be negative. There would be only epidermal necrosis, whereas when you come to LE like 10, you have both features of LE as well as 10 on the biopsy. You get the positive immunofluorescence. And bullous LE, it could be basically a Terns blister with the IF findings and ANA positivity. So this is how we usually differentiate. So final diagnosis of 10 like LE. Any difference in management do you find, Gandhi ma'am, between 10 just and 10 like LE?
See, one of the things is naturally it is very severe. So because it's a very acute exacerbation, so you would need to be more, aggressive in your treatment. So even though the standard treatment is pulse steroids like methylprednisolone pulse or IVIG, we use a lot of IVIG. You would need to be, and another interesting thing which I think is not very clear and we need to actually look out more is that there are also patients of this presentation who have a prothrombotic kind of a picture. So that it may not be classical APLA, but that is something you need to look out. So you must investigate for APLA in these patients. And another interesting thing is interleukin 1 and 6 are also elevated in these patients. So like COVID now, we might be talking about use of tocilizumab and anakinra. These are drugs that may be used in the future. I have personally no. This is just a theoretical possibility.
Steroids with IVIG, with of course the sunscreen and HCQS, that would be...
That is continuing. The patient was already on those things because HCQS is the backbone of any LE therapy. Yes. That should never be withdrawn no matter what other therapies added.
Understood. Can we bring in Dr. Manish Malik here? Yes. What about the renal complications in LE? We were talking about it. So what are the common complications and how do we manage them?
Well, lupus nephritis can vary from asymptomatic abnormalities like proteinuria and microscopic hematuria to the extent of patient requiring dialysis. So this is a very huge and wide spectrum. But the message to be given across is that vigilance is very important for proteinuria, RBC class, RBCs, as well as renal function. I think.
Yes. Understood. And what if there are renal complications? What is a drug you would go to medications? Dr. Vedsa, will you want to take on that too? What would you go on if there are renal complications as a rheumatologist and in consultation with the nephrologist?
Look, basically with the kidney involvement, gradually we realized the mortality was very high. So initially came from NIH trial. Now basically NIH trial and the European, which is recently, the difference is that you are using less dose of cyclophosphamide. So basically there are two drugs which has been used from NIH trial, that is a cyclophosphamide and the pulse steroid or oral steroid. Now, basically, people realize there are a lot of toxicity of the cyclophosphamide and steroid. So the whole difference between these two, European and the NIH trial, is less dose of the cyclophosphamide, that is every 15 days, about 6 doses. So that is how the change is. Of course, now probably people are using more of the mycophenolate, MMF. That is the
also
change.
Coming as an induction drug. Yes. Okay, sir. Okay, with that we come to the end of this case. We go on to the next case now. Now, this is a patient of systemic sclerosis since the last 2 years with tightening of skin, salt and pepper pigmentation, restriction of mouth opening, Raynaud's. So the classical systemic sclerosis. And this patient then developed discoid plaques on the face, trunk and limbs with generalized itching, photosensitivity and also oral ulcers since the last 6 months. So you can see this patient here. She has features of scleroderma and then she has these lesions which have come on. You can see the skin lesions. Yes, you can see the ear lesions, the lower back. You can see the features of sclerosis. You can see the palatal ulcer. Yes, Dr. Pandey ma'am? With this,
systemic sclerosis, obviously, I mean, that is one of the things that is there. I think that there was also calcinosis. and the lesions are discoid. So you have discoid looking lesions which are disseminated. They're even there on the trunk. So I would like to investigate her for an overlap.
For an overlap. Yes, and what's the
So I
overlap you
believe,
generally be thinking of, yeah, ma'am?
I mean, actually systemic sclerosis and LE, which can be a spectral. I mean, so it will depend on the criteria being fulfilled. So we would need to do a proper lab workup and a systemic screen.
Yeah, so I've put up the lab workup here. It showed ANA positivity 1:160, SCL 70 positivity, UNRNP was negative. There was ILD on HRCT chest. The histopathology showed DLE of the discoid lesions, and rest was normal. So, Gupta sir, what would you want now with the diagnosis?
We can go for a more specific test for to rule out, because scleroderma is visible clinically and also SCL
Yes,
positive.
scleroderma is clinically very visible, yes.
And we can go for further evaluation of LE, like ANA positivity is there, though it is very significant.
Yeah, no, rest everything is negative, sir. Rest everything is negative.
Okay.
Rest of the workup is negative, yes.
We can go for the.
So actually, she doesn't fit into a criteria for LE because she doesn't have the entire criteria. Yes, she definitely falls below 5 points with an entry criteria. Yes, Sujay sir. So what?
Yeah, so I think
right.
I think it's right now an overlap between systemic sclerosis and disseminated DLE. Since your other immunological tests like dsDNA is negative, and you're saying that anti-Schmidt antibody and investigations towards systemic involvement all are negative, so that means this patient has not yet extended onto the SLE spectrum, and it's still limited to the disseminated DLE overlapping with systemic sclerosis.
Yeah, so that's a rare condition actually. If you see, there is a lot of cases with LE scleroderma overlap. But DLE developing after a scleroderma is not very common. Usually, even if it occurs, the DLE precedes the scleroderma. So that's the rarity in this condition. So I would now ask.
And therefore, the importance of continuing to perform tests over a period of time rather than make a decision. Right? Yeah.
Correct. So now we come to the facts of undifferentiated connective tissue disease versus MCTD versus an overlap. Yes, Pandi ma'am, would you like to take that on?
So I'll start from the last one, the overlap. So the overlap is when you have two defined CTT and both the criteria for both are being fulfilled. So the only thing we have to remember here in any CTT is that it can be cumulative. So each of the criteria doesn't have to be present at the period of time that you are examining, but if it is documented even in the past, so you have to give credence to that. So here is a patient who is fulfilling. It need not be concurrent. So it is even a cumulative criteria. Now MCTD is a very interesting entity, and I'm sure the rheumatologist and the nephrologist will have more to say about it.
Take that on the last, ma'am. Yeah.
Right.
Yeah. What about UCTD? Say if this patient had only the DLE lesions, if this patient had only the DLE lesions, no scleroderma, would you put it as UCTD?
Well, I'm a dermatologist. I would like to use the terminology chronic cutaneous LE, disseminated chronic cutaneous LE, and I would leave it to the rheumatologist to call it an undifferentiated cutaneous.
Yeah, because it doesn't meet the criteria as of now.
Yeah. So, but I am purist, so I would like to use my dermatological term.
Yeah, so we would give a diagnosis of disseminated DLE to this. So UCTD, as we've all said, and basically patients who have symptoms and lab findings consistent with a systemic CTD but not meeting the criteria. So this could be it. And Sujay sir, you were commenting something about the monitoring.
Yeah, that's right. So you have already discussed this now that you don't have to see these criteria met at one point of time. It's cumulative. It is over a period of 6 months to 1 year, and therefore periodic assessment of the patient is necessary to assess whether this patient is having only skin limited disease or is it going into a systemic involvement.
Yeah. So basically you keep monitoring the patient, especially when there are conditions which may lead to an aggravation of autoimmune diseases like infection in pregnancy, and also the first 2 years they say that's the most important. So we go on to Ved sir, we come to MCTD. So how do you want to define MCTD? Mixed connective tissue disease.
Mike.
Ved sir?
Mute.
Okay,
Mute.
unmute, sir.
Yeah. Once the sharp criteria. No,
Yes, sir.
what happens? SLE was an old disease. People understood about SLE, but a new disease was defined by sharp. And a lot of criticism in 1972, exactly when I joined medical college, whether it's a new entity or not. So new entity differed from other connective tissue disease is a very high titer of U1 RNP. So the basically to remember this is a diagnosis of the immunological diagnosis where the U1 RNP is very high. So you have a patient whose ANA is positive, but your U1 RNP is very high, maybe 1 in 1,000, 1 in 2,000. Every time, every year, a new criteria will come. But for a clinician, you must remember these patients will have two things. They will always have Raynaud's. So you have a patient who is a Raynaud's, so that is a vasculitis. You have a synovitis. You have a muscle involvement in the form of some muscle disease, and then you have the U1 RNP very high and hand edema. So classical patient will come that doctor साहब मेरे हाथ नीले हो जाते हैं. I have a edema and puffy fingers. You can describe in many ways. But Raynaud's will remain always, and sensitivity of this sharp criteria or the Kahn criteria or Kasukawa criteria or Elecon-Sego criteria, by and large say the same thing, that even your U1 RNP either 1,000, 1,600 or 2,000. The latest criteria says that U1 RNP should be more than 2,000. So basically a patient who has Raynaud's and U1 RNP and hand edema.
So this is the most well accepted criteria, the Alarcon-Segovia criteria, and this is, as Sir said, these are the 5 points which should be present in it, and if UN RNP is positive, then it goes towards MCTD. Okay, Dr. Manish, what is the renal involvement in MCTD when you compare it with the other connective tissues?
The renal involvement ends up being probably the most deadly in MCTD because your track is getting very clear by now. And another issue has, as we were seeing this patient probably, that if you have an overlap of SLE and scleroderma, I'm sorry, coming into overlap, then this is the most dreaded of all renal complications might encounter.
So basically, renal involvement can be, though in MCTD per se the incidence is less, but it can be severe. Yes. Now we come to scleroderma renal crisis, sir. Can you tell us something about that?
Well, scleroderma renal crisis is quite a common complication. And it presents with very, very high failure. But the point to be remembered is that people who have been on steroids are much more prone to renal crisis. So again, emphasis of monitoring.
Request all of the panelists to mute now, sir. Dr. Manish is speaking. Yes.
Yeah. So as I was saying, steroids are a major risk factor for scleroderma renal crisis. So in that scenario, a monitoring of the blood pressure and the renal function. But we also have other complications like the normotensive renal crisis where the blood pressure may actually be low.
Instead of a hypertensive, you can have a normotensive renal crisis. Yes.
Which has a poorer prognosis, so to say. And then even the associated renal syndromes may be there. From if I may mention one line in the management point of view also, that the steroids are a big no-no and the ACE inhibitors are a big yes in this.
ACE inhibitors are the drug of choice. Yes. Okay. Coming to Dr. Sanjay Gupta, sir, what are the recent advances in scleroderma management? Anything new?
Yeah, there are few drugs being added in the management. Few drugs were earlier, like we have a bosentan drug is one drug. We have a ilioprost which helps in the ulcer healing. We have phosphodiesterase inhibitor, tadalafil, sildenafil, and because I will prefer these two drugs because they have a multiple actions. Like they have a effect on the pulmonary hypertension. They have a effect on the Raynaud's. They have a better healing property in the case of tropical ulcers. Now we have received interleukin 6 inhibitors now, which we are talking recently.
The tocilizumab. Yeah.
And we have
Basically, yes. For the antifibrotic, now we have tocilizumab coming in nintedanib. Also, rituximab is being tried. Yes, sir.
cyclophosphamide, high dose, and other drugs like azathioprine, MMF, they were already there. So these are the new drugs. Tocilizumab,
Yeah. So the endothelin.
is another CD20 inhibitors.
Yeah. So the endothelin receptor antagonists like bosentan probably are more to basically prevent new ulcers, whereas the healing probably is also taken care of by the PDE5. That's why they're also coming in a big way. And of course, you have also in the interstitial lung disease probably that you have a stabilizer azathioprine coming in after the cyclophosphamide. So these are some of the new things which are there in scleroderma management.
That you mentioned, the nintedanib is specifically being used in interstitial lung disease.
Yeah. Yes, ma'am. Yes, agreed. Yeah, so now with that we come to the third case now. Now this is a 42-year-old lady, a hypothyroid, who presented with muscle weakness, itchy skin rash around the eyes with swelling, a right breast lump and difficulty in swallowing. So the muscle weakness was initially followed by the skin lesions and the breast lump and then difficulty in swallowing. So there was also photosensitivity, joint pain, weight gain and heavy bleeding. She was on L-Troxin and pantoprazole. So with the provisional diagnosis, obviously with the muscle weakness, there was dermatomyositis, hypothyroidism, and of course investigation of the breast lump. Investigation showed a pedal edema and a right axillary lymph node enlargement. BMI was high. So you can see the, yes, Ved sir, how do you assess the musculoskeletal system in such a case where you have a patient presenting with muscle weakness? Wait, sir, I think you need to unmute, sir.
Thyroid and the rheumatological disorders are very common, especially the shoulder involvement. So, can you hear me? Sometimes muscle weakness can be taken for the shoulder involvement and vice versa. So, shoulder involvement because shoulder has a lot of ligaments and hypothyroidism causes a lot of enthesopathy. So you must rule out whether shoulder joint involvement, that is a rotator cuff. Then of course the muscle. Traditional in neurology teaching, we have learned from 0 to 5 that grading. Now new grading has come. Basically it has not changed much. Basically we always test from 0 to 5. The 5 is basically which grade 5 is the muscle contracts normally. So I don't want to go into those details. But by and large, what I do in the OPD, I always tell patient to sit down on the floor and try to get up. So that tests the proximal muscles that is involved in the polymyositis or dermatomyositis. I am not a neurophysician, but that is how I quickly test in an OPD of 100 people. When I was in Army Hospital, now in Gangaram Hospital also, I always take, the moment I suspect a dermatomyositis or polymyositis, I always tell patient to sit down or raise the hands above. So probably these two things are good for clinician. Yes, if you want, I can go through all this. Probably that time you don't have.
Basically, want to just show the steps where we are checking the muscles of the patient. So the dermatological examination in this patient, you can see that the violaceous discoloration around the eyes is not really standing out, but a bit subtle. And they say actually just a subtle violaceous rim around the eyelid margin or scaling is also a clue. And of course, she has some periorbital swelling. You can see that here. She has some lesions on the V of the chest. You can see some lesions on the upper back. Of course, periorbital swelling is definitely there. She has some spots on her scalp too, some alopecia. Pandi ma'am, yes, the nail, you want to comment something on the cuticles and the nail? Dr. Pandi ma'am, Dr. Sujay sir?
To unmute myself. So there is some cuticular hypertrophy here. I see some cuticular hypertrophy here. So that is one of the signs, and rest I would like to do an icoscopy. So I would be able to comment further
what
on
will
that.
you get on icoscopy ma'am? On icoscopy findings for say dermatomyositis?
So you would have some capillary, kind of hyper convoluted capillaries would be seen, bushy capillaries can be seen. And this cuticular hypertrophy is one of the very characteristic thing which is not seen in other CTTs. And it's actually been, I think it's a marker of, if I remember correctly, it's a marker of anti-MI2 or one of the things. So yeah. So this is one of the things, but the alopecia is also there, and here I think the two things that were marker in the history that you gave was once dysphagia. So we need to be clear whether it's a proximal dysphagia which can be due to DM or it's a distal dysphagia that can be overlap. And she also had arthritis and the alopecia. So again, one of the, I think the basic thing in CTD is that what I always, it's one of my favorites. So I was not talking about MCTD. CTDs do not follow the textbook, so you would, if you have an open mind, overlaps are much more common than we realize.
Yes, you should look for overlaps definitely in this case too, and in all cases of CTD. Yes, ma'am. Yeah, so with the right breast lump, the mammography FNAC biopsy showed basically a breast carcinoma. She also had, of course, Hashimoto's thyroiditis. So now we have a composite diagnosis of dermatomyositis with breast carcinoma and Hashimoto's thyroiditis. So yes, sir. Sujay sir, what are the associations of dermatomyositis?
Yeah, the most common in adult dermatomyositis is obviously underlying malignancy, but we also should make a diagnosis of paraneoplastic dermatomyositis in the background of a malignancy, although it would come purely as the first, with caution. Differentiating between that whether the malignancy is just a coincidence occurring in a patient with a background dermatomyositis, or is it a real paraneoplastic dermatomyositis?
And there what are the usual carcinomas, sir?
So they are basically solid tumors. So when I investigate, it's the easiest way to remember is going from head to toe. So you can start with say a bronchus, the respiratory, the breast, bronchus, GI, urogenital, nasopharyngeal.
Ovarian carcinomas in ladies, yes.
So urogenital, urinary bladder amongst that, or ovarian carcinomas in women.
So about 25% cases of dermatomyositis may have association with malignancy. So it is one thing which we need to strongly look for.
That's right.
Yes, sir. So
and another clue, cutaneous clue that I saw this to more comfortably live. So there are important clues that I use to make a diagnosis of paraneoplastic dermatomyositis in patients who have a background malignancy, because we don't have all the sophisticated immunological tests that are very specific for that in our country. But if you go back quickly to the clinical manifestation, especially on the upper back and on the abdomen, I saw areas of skin necrosis, and that's an important clue that helps you to make a diagnosis of probably the patient having a true paraneoplastic dermatomyositis. Sometimes a very intense periungual erythema, besides the ragged cuticle, is another soft clue towards that.
Another one. Okay.
Another soft clinical clue towards. And of course, the third is patient not responding to conventional medical treatment in the background of a malignancy suggests that it's a true paraneoplastic dermatomyositis.
Yeah. So you can see here that the NA was positive, the thyroid test you can see, the muscle enzymes were raised, the breast carcinoma I've already mentioned. So just a brief, Gupta sir, what are the investigations of choice for diagnosis of dermatomyositis?
Like clinically, it seems to have little bit cutaneous signs of dermatomyositis. We can go for some immunological, like anti-synthetase. We can go for some enzymes. You have already mentioned.
Yeah.
Anti-MI2.
Enzymes, antibodies, yes.
Anti-MI2.
Yeah. So we basically go with muscle enzymes, ANA, biopsy, muscle biopsy, and so basically MRI is the investigation of choice there.
Anything related to muscle damage. The point is that we have to get clue that something is to give a clue that muscle is being damaged. Maybe on a MRI, EMG, biopsy, or the clinical signs of muscle weakness, and the enzymes, and last the immunological one.
Yeah, aldolase is the creatine kinase is the most sensitive enzyme of the lot. And of course, you rule out all the other systemic involvement. You also rule out malignancies with CT and the transvaginal ultrasound and mammography. Myositis specific antibodies, Pandi ma'am?
Well, actually, this is one area which is the most fascinating, and more work is being done. And this is yeah, but this is also the one area where in India we do not have access, because here it can in fact give a better prognostication as compared to anyone. We know the classical antibodies like ME2 and that are associated with dermatomyositis, and even the overlap. So whether it's anti-2, which has a good prognosis, and the bad prognosis one like anti-Jo1, anti-synthetase associated, or anti-PM7, PL7 and 12, OJ and EG. So they actually give a good prognostication. For example, if you have Jo1, you have to be very, you have to give your immunosuppressive and steroid for a long time because they have recurrent ILD. ILD is more and they have recurrences too. Then there is what Sujay was talking about, P140, 155, it has an association with malignancy associated. Then you have antibodies associated with amyopathic dermatomyositis, which have a poorer prognosis. Then you have the signal recognition particle antibody, which has a very poor prognosis because it is steroid resistant. So even primarily you will start the patient on IVIG. So in fact, this is one disorder where the array of antibodies should be available. Ideally, because you can only effectively prognosticate the patients if you have them. And the issue probably is that these dermatomyositis is not very, very common. So probably that is why the availability of these antibodies is not there, but this is one area where it could really help.
Yeah, okay, ma'am. Treatment,
And even
just in one line,
the
sir.
NXP2 also is associated with malignancy. But again, there is a considerable overlap. I just wanted to add, for example, TIF1
It's not
and
sacrosanct, yes.
and NXP, which is the nuclear matrix protein 2, can also be seen in juvenile dermatomyositis, which is
Juvenile
usually not
dermatomyositis,
associated with malignancy.
Correct. Treatment in one line, sir. What's the treatment of choice, Ved, sir, for dermatomyositis?
Unmute.
Unmute, sir.
Now, basically, nothing has changed from the Bowen-Peters criteria when came for the polymyositis,
Much has
dermatomyositis.
not changed. Yes, sir.
The only thing
What
which
is
is
the
probably
first line?
changed is what
First line
Madam was talking about, the myositis specific antibodies. That is the only change. My only message to the dermatologist, as a rheumatologist, I must tell you that whenever you have a patient, you must exclude the ovarian malignancy. Every time we have burned our finger is because of ovarian malignancy. As the treatment is concerned, this is one disease which you require a mega dose of steroid. Not 1 day, not for 2 days, you require for 3 months. The first case when I saw, I realized you explain to the patient that you will develop the side effects of steroid. So that is the first thing you have to explain, because you have to give steroid 1 milligram per kg or 1.5 milligram per kg for 3 months. If you reduce early, then what is going to happen? They will have a relapse. And after relapse, you require more dose. So you continue for 3 months and be vigilant on the side effects. Of course, other drugs like methotrexate or azathioprine there are a lot of studies available, especially about the azoran can be added.
An adjuvant, sir.
Yeah. And of course, other things you can add, as you are all dermatologists, you can as a local treatment for other thing. But basic drugs remains a high dose steroid, plus steroid sparing, methotrexate or azoran, and now rituximab and IVIG.
Okay, sir. So now we've come to the end of the 3 cases. We have some questions from the audience. Dr. Sujay, sir, what's the role of sunscreens in preventing a flare of LE? This is from Dr. Shahana from Hyderabad.
So we recognize that photosensitivity and acute LE is a very important manifestation that can be to a large extent taken care of by use of an appropriate sunscreen. Number one. In fact, in about 1/3 of cases of SLE, even systemic flares, about 40%, systemic flares can also occur as a result of excessive sun exposure. Now, in my personal prescription and in my teaching on sun protection, and we recognize that the action spectrum is in the UVA, but in my prescription, the order of my prescription is always number 1, shade, number 2, proper clothing, and number 3, sunscreen. recognizing the limitations of the appropriate use of a broad spectrum sunscreen.
Definitely helps in prevents LE flares.
It does, because we recognize that in
Yeah,
about
because
one
that's the
third of
main
the
trigger.
cases,
That's
even
the main
systemic
trigger.
flares, systemic flares
Yes.
can also occur because of UV exposure.
Dr. Manish, there's a question. Immunosuppressives in order of safety in COVID times for connective tissue disorders. Can you take it on? Since you're managing a lot of COVID patients.
Yeah, well, steroids we all know are safe. They are rather being used for treatment of COVID also. But other than that, if a patient is doing stable on a system of treatment, which would definitely include the anti-metabolites, which could either be MMA or cyclophosphamide or azathioprine, then probably you might want to monitor this patient for infections. But incidentally, if a patient turns up to have COVID positive, then immediately the anti-metabolites have to be stopped. Whether it is
So once you have COVID, you stop it. But if it's not COVID, you continue. That's the message?
But the problem is new patients. Non-COVID disease is not stopped. The difficulty is in the new patient who presents to you and who is diagnosed to have SLE or lupus nephritis or one of the other diseases which require aggressive treatment. The treatment cannot be postponed. There, the decision becomes very, very difficult. Very,
you have to weigh the risks and benefits. They maybe comorbidities, age.
And a high risk consent is required, plus isolation, all the precautions. So it's a very difficult thing to answer, frankly speaking.
Correct.
But again,
So
steroids
this,
are
this question, steroids are safe, of course. HCQS is safe, we know. So this question was from Siddharth Oswal from Jabalpur. We have another question, methotrexate in ILD. Of course, Sujay Kanpur sir, that's a no-no?
No, I don't.
So there are very elegant paper now that methotrexate does not cause ILD. So one should be very, very clear that methotrexate never causes ILD. We already knew all along. So that message should go along.
But once ILD is there, sir, then will you give methotrexate?
Definitely. Methotrexate has no relationship with the ILD. Earlier, people thought because the methotrexate we have taken from the oncology. So we were always little dermatologists and rheumatologists. We always were worried about methotrexate side effects. It has been proved whether ILD has no relation with the methotrexate. In fact, methotrexate should be used for ILD. And these are very well documented papers.
Okay, now we, this is a follow-up of the patient, and since we have, now we have shortage of time, we actually come home to the take-home messages. So basically 10 like LE to be kept in mind when seeing cases of 10, of course. Overlap disorders, as Dr. Pandey said, to be considered in all cases of CTD, to be differentiated from MCTD. In dermatomyositis, always rule out malignancy association. Of course, multi-specialty team-based approach, important. And with a message from the entire team to stay safe and healthy in COVID, we conclude this panel. Thank you all panelists.
Thank you very
much. Thank you. Thanks.
Thank you, Dr. Biju, and all the panelists for a most insightful and enriching panel discussion on connective tissue disorders. I thank my co-chairperson, Dr. Jaikar, and sir, would you like to say a few concluding words?
Nothing much to add. I was wondering why Sujay did not talk about your other cutaneous manifestations, particularly when it's associated with dermatomyositis and malignancy. What about, how often have you seen poikiloderma? DMV malignancy.
Poikiloderma is a feature that we often see in dermatomyositis in the absence of malignancy too. We see the photodistributed sites, we see that even on the trunk. So, poikiloderma acquired causes being dermatomyositis of the connective tissue diseases, mycosis fungoides.
It's not really rare, sir. Though we find the other features more, poikiloderma is not really rare.
Not rare. It's not rare. Okay, anyway, thank you very much. Thanks, Shamanta, for being with me. Thanks.
Thank you. Over to the host.
Thank you, Dr. Jaikar Thomas. Thank you, Dr. Shamanto. Thank you.
Thank you.
Many thanks to our esteemed chairpersons, moderators, and esteemed panelists. So, with this, we would like to start the first question for our quiz. Just to reiterate again, please look for the response panel. It may be towards the right side of your screen in case you are seeing it. Can I please request all the participants to mute their mics? So, towards the right side of their screens, or if they are accessing on a phone or a tablet, it would be under the screen, under the live broadcast area. So please fill in your name and location from beforehand, and as soon as the question is displayed, because the question will be timed, there will be limited time, just put in the question in the live question answer field and then submit. So this is an example. Just press submit, and so the quiz time. The first question, in fact, was covered in the preceding panel. It was one of the questions in the panel. It is on the new criteria, which is the ULR ACR classification criteria. So I'm going to read out the question. Which of the following is false about ULR ACR classification criteria for systemic lupus erythematosus? Positive ANA is an obligatory entry criterion. A score of more than equal to 10 is required for classifying as SLE. Criteria need not occur simultaneously. Lupus nephritis as sole clinical criteria in the presence of ANA is enough for classifying as SLE. So your time starts now. Yeah. So there are 20 seconds. You have to identify the false statement among these four. Just put the option and press submit. Yeah, we've got plethora of answers now. Yes, so the time is over. So the answer is D. Lupus nephritis as a sole criterion is in presence of ANA is enough for classifying as SLE. This was in fact true for the previous classification or the SLICC classification as it was discussed with Dr. Manish. And these are the entry criterion. Just going over it again. So if you see the renal criteria, it's only the biopsy class 3 or 4, which is the focal and the diffuse lupus nephritis, which is enough to classify as, along with ANA, as a case of SLE, but not the other kinds of lupus nephritis. So the winner for, so the first answer correct was sent in by Dr. Sonali Bhatt, Chandigarh. Congratulations, Dr. Sonali Bhatt. Congratulations. Over to you, Dr. Khushbu, for the next session.
Thank you, Dr. Gupta. And after this quiz, let's move on to our next session, which is on hormones and acne. We would now like to invite Dr. R.P. Gupta, President of DAS, past Vice President of National IADVL, and a Senior Consultant Dermatologist from Delhi, along with Dr. Dinesh Mathur, Senior Consultant at CK Birla Hospital, Jaipur, to chair the session. I also request them to introduce the moderator and the panelists. Over to you, sir.
Dr. Dinesh Mathur has joined. Yeah, please.
Yes, good morning. Am I audible?
Yes.
All
Yes,
right.
Dr. Mathur.
Yes. So, good morning all, and it's a very auspicious day. I was thinking that today is a Guru Purnima. So, let me wish all academic gurus.
Dr. Dinesh, you have to unmute yourself. You've been muted for.
Dr. Manas, can you unmute yourself? Can you mute yourself?
You have to mute all people.
Yes. Yes, sir. We can hear you, sir. Dr. Mathur, sir, please go ahead.
All right, sir. So it's a very I'm very lucky to have this chairing this session, and we have got moderator none else than Dr. Sanjeev Kandari, who is on the screen. And Dr. Kandari is a senior consultant dermatologist from Delhi, over 40 years of experience, and past president of IADVL Delhi State Branch. So, Dr. Kandari, all is to you, and you have got panelists Dr. Rajita Damashetty, Dr. Shaili Kapoor, Dr. Manas Chatterjee, Dr. Maya Vedmurthy, and Dr. Sudhir Tripathi. Shall I introduce them, or Dr. Gupta?
I don't think so. They need any introduction. They are well known. And Dr. Sudhir Tripathi is, of course, an endocrinologist from Gangaram Hospital.
Fine.
Good morning.
What are you doing?
कौन सा कैलेंडर
Sanjeev,
Hello, can you hear me?
Yes, Dr. Kandhari sir, please move ahead.
Well, I welcome you all, the panelists, and I thank the organizers for having given me this privilege to host these sessions on hormones in acne.
Requesting all the panelists to please be
Manas,
on
please
mute button
mute
till Dr.
yourself.
Kandhari asks you.
Okay.
I think I'm having a little problem.
Hey, Dr. Kandhari, you are audible. You can start.
I'm on slide again.
Can you see the slide?
Yes.
Okay. When will you suspect a patient will need hormonal therapy? Dr. Mayaved Murthy?
Good morning, everyone. Thank you, sir, for including me in the panel. I would suspect a patient would need hormonal therapy if it is a patient with adult onset acne, persistent acne, difficult acne which has not responded to the conventional therapy, or the distribution of acne based on the face and the tongue, and if there's any signs of hyperandrogenism or if there are signs of hyperinsulinemia.
Well, you've said most of the things which I pointed out, and late onset acne also would be one of the things that one can have. It's not moving. I don't know. Hello?
Jitin, to help, please.
It's not moving this slide.
Can the technical team
Kandhari sir, use the, there are 4 buttons for the forward, back. Just use the forward one. Don't use the up and down.
I say resume share.
On your laptop, the forward slide. So don't use the up or down slide.
It's coming, your screen is paused.
Sir, resume.
Resume.
And forward.
Not moving here. I don't know, it's not moving. Not moving, I don't know why. Okay, recommendations for giving a therapy. What patients with hyperandrogenism will you choose for therapy? Dr. Rajita?
Ma'am, please unmute yourself.
The moderator muted me. Patient, what Maya ma'am said, I would want to add extensive acne. When you have truncal involvement, or when you have mild acne which is recalcitrant, or just severe acne, that also would be hormonal acne, I would think. And hyperandrogenism, when would I choose to treat these people with therapy? Number one, When I think the hormone playing a role in acne, so all the criteria that you had mentioned earlier, when there's a severe premenstrual flare, when a lady comes with menstrual irregularity, which is significant, so or when somebody doesn't have too much of hyperandrogenism, but you need contraception, like when you're giving isotretinoin, there also I would want to add hormonal therapy. And one important point I want to make is hormonal acne itself is hyperandrogenism. So that means all the people that you had mentioned actually would qualify for therapy with hormonal modalities. I hope that was audible.
Dr. Kandari, unmute yourself first.
You know, I'm putting resume share. It's not coming.
Yeah.
I don't know. Not happening. Okay. What are the common disorders which you come across in your practice that would give rise to hyperandrogenism? Manas?
Of course, is polycystic ovarian disease. That's
Dr. Manas?
Yeah, can you hear me?
Yeah, a little better.
Okay. So the commonest cause of
Having a little problem with hearing and everything. Manas, can you hear me? Anyway, it's the ovarian source, the adrenal source, the pituitary and the iatrogenic source. And of course, there is idiopathic Dr. Sudhir Tripathi, is he there?
Good morning. Yeah.
So, what is there a proper definition of PCOS that we have? And what are the diagnostic criteria do you follow while diagnosing PCOS?
So of course we use the modified Rotterdam criteria. That is the criteria that we most commonly use. The modified Rotterdam criteria, of course, has got we have 3 criteria, out of which 2 have to be positive, and of course the criteria that we use, of course, the 3 criteria are hyperandrogenism, ovarian, there is ovulation dysfunction, and of course a polycystic ovaries by ultrasound. But here, if the polycystic ovary, if you have the other 2 criteria, then of course the ultrasound is not necessary. The hyperandrogenism, of course, could be clinical or hyperandrogenism. The clinical, of course, is acne, hirsutism, androgenetic alopecia. Of course, the biochemical, of course, the raised testosterone, or of course DHEAS. So these are your criteria as far as the hyperandrogenism is concerned. It would be clinical or biochemical. As far as ovulation dysfunction is concerned, we have basically oligomenorrhea or amenorrhea. Oligomenorrhea defined in terms of the fact that the cycles should be more than 35 days apart. Amenorrhea, of course.
We'll come to that later, Manas. What I wanted was that when you are doing a diagnostic criteria between NICHD, Rotterdam, and AES criteria, what is the basic difference?
So we follow, of course, the Rotterdam criteria. That is the criteria that we are following on a regular basis, and we follow the criteria where we use 2 out of 3. So that is the criteria that we are following. Do you want to know the difference in the various criteria?
Yeah.
Okay, the NIH criteria, of course, talks in terms of menstrual irregularity, hyperandrogenism, and exclusion of other etiologies. I mentioned the Rotterdam, which is 2 out of 3, and then, of course, the AES criteria, which is hyperandrogenism in the prime, menstrual irregularities, plus or minus ultrasound evidence of polycystic ovaries, and, of course, exclusion of other etiologies. But as I said, out of these criteria, the modified Rotterdam is the most popular, currently the most popular, and that is a criteria that we follow.
But in Rotterdam, basically, you can have women, who are having neither hyperandrogenism nor hirsutism, but only polycystic ovaries. Is that enough for you?
So you have to have 2 out of 3, and remember the polycystic ovarian criteria is only taken if you are not having a choice, by which we mean that in case you have a situation where you are not able to get the 2 out of 3, because the polycystic ovary criteria is prone to fallacious results. We know we require a transvaginal ultrasound for doing that particular criteria. And of course, so if the clinical criteria, that is the evidence of hyperandrogenism, either clinically or biochemically, and the evidence of oligomenorrhea or amenorrhea are present, that would be sufficient. That is, if present, that would be sufficient for a diagnosis of hyperandrogenism.
Dr. Sudhir Tripathi, I'd like your take on this.
You are absolutely correct. The criteria are several, and over a period of time, the criteria changed from the Rotterdam criteria. You have the NIH criteria, now you have the American Endocrine Society and PCOS Society criteria. But I think essentially what needs to be done is to have a clinical diagnosis, and the clinical diagnosis is based on whether you need to treat the patient. Whatever criteria you may have, it depends on the clinical condition of the patient. If the patient has acne or has hirsutism or has irregular periods, then it depends on the age of the patient, whether it's a teenager or it's a pregnant woman, a lady who's married and plans pregnancy. So you have all these clinical functions which are important. So you treat the patient based on the clinical judgment, whether there's acne which is predominant or hirsutism and acne. So what do you want to treat? If you have to treat, then you treat those symptoms irrespective of the criteria. So I think criteria are important, but the individual patient is more important. So the criteria is changing, and we don't depend too much on the criteria. We just diagnose it clinically and treat according to that.
What tests should we do in order to evaluate hyperandrogenism?
Well, we start.
There are lots of tests which are there. So which one would you say, in the most minimalistic form, to cut down the cost, what should be done?
I think there are several. We can club the tests into different categories. One is the general category of tests, which you do in any patient who comes with, let's say, obesity or acanthosis nigricans and hyperinsulinemia like picture, clinical. Then you like to do a blood sugar, you like to do a cholesterol, and these are the general biochemical tests regarding the obesity. But as far as the actual condition of polycystic ovaries is concerned,
no, I'm talking about evaluate hyperandrogenism only.
Okay. So if you have hyperandrogenism, you like to do in a female patient with hyperandrogenism, you like to do the testosterone, total testosterone and free testosterone. It's important in a woman to do the free testosterone, because if you have the SHBG levels which are altered by the obesity, then the free testosterone is more important. You have more free testosterone, the total testosterone may be normal. And then you can do a test like DHEAS. If you're suspecting other conditions of responsible for like 17-hydroxyprogesterone, congenital adrenal hyperplasia, you do a 17-OHP. You can do a DHEAS, but the minimalistic tests are a testosterone and a free testosterone.
Would you do a free testosterone, or would you prefer to do a free androgen index?
We can do, basically I would say that if a patient has clinical evidence of hyperandrogenism, there is no need to do a testosterone level either. If you have a hirsutism, if you have acne and you're going to treat that, then there's no need to do a testosterone level. However, if you have a patient who does not have overt features of hyperandrogenism, then you'd like to do the testosterone levels and a free testosterone level, or you can also do a free androgen index.
Dr. Rajita, I'd like your views on this.
Thank you, sir. So, we dermatologists are going to see patients only if they have hyperandrogenism. So, I'm not going to go out of my way to establish hyperandrogenemia, which might or might not be there. So, I'm going to concentrate on the last line that you had projected, which is ruling out other mimicking disorders. So, I'm going to ask for 2 tests mainly. One is TSH, the second is prolactin. Because if you have a significant hyperprolactinemia or a significant hypothyroidism also, you can have a secondary PCOS. So if it's a minimalistic, absolute, low budget, then these are the 2 things that I would test. And the free testosterone.
In addition to testosterone?
In addition to the ultrasound. Now, we are assuming that we are seeing hyperandrogenic people. So if there is extra money, then I would do a total testosterone. under FII, but I would not do a free testosterone for the reason that you mentioned. The equilibrium dialysis method is not accessible to any of us. It is not even available in research labs in the country.
How will you establish the ovulatory dysfunction, Dr. Shelley?
Yeah,
What
good
would you
morning.
say that the patient is having an ovulatory dysfunction? What is the normal intramenstrual interval? How can the ovulatory dysfunction be defined?
Okay, sir. Sir, audible?
Yes, you're audible.
Okay. So, ovulatory dysfunction, if the normal cycles are exceeding more than 35, if the intermenstrual duration is more than 35 days, then we will ovulatory dysfunction, amenorrhea cycles. If the interval is 30 to 35 days, then this. We can do ovulatory studies. Usually, there is a test which is done in the mid phase of the first or 22nd day of the cycle. Measurement of serum progesterone levels. So that can be and the value per deciliter. That is the value. That means ovulation is there.
What is the progesterone level that you are looking for?
Sir, it should be, I think, around more than 10 nanograms per deciliter.
And if it is less than that, it is oligoanovulatory?
It should be, we have to take 3 successive ones, and if it is total of 15, then we say that it's a normal luteal function. A successive 3 cycles, it should be a total of 5, and less than, I think, 2.7 or 3, that says that the cycle is 10 of.
Okay.
Yeah.
If you have to establish PCOM, that is ultrasound as the sole criteria, are you agreeable with that or not?
The polycystic ovarian morphology, yes, we have to check with ultrasound only. But then, according to Androgen Test Society American 2006 criteria, they don't take this ultrasonic evidence as one of those criteria.
Why is this so?
Sir, because this is not a very reliable indicator of diagnosing PCOS, especially in younger females, especially in adolescent age group, where this can be polycystic ovarian morphology can be a normal occurring in prepubertal girls. So that's why.
So let us say you are unable to do an ultrasound or get information from the ultrasound. What is the other test that you would want to do?
So we can do an anti-Mullerian AMH hormonal assays that can, if ultrasound is not possible or ultrasound is not giving a proper picture, then AMH levels can be done.
Yeah,
and the levels.
Thank you.
Yeah.
Dr. Rajita, would you prefer to do a transvaginal or a transabdominal?
Transvaginal, sir. Basically, Rotterdam criteria talks only about transvaginal because abdominal fat
is that if you get a virgin with PCOS,
unmarried girls, you can't really do that.
And would you prefer to do unilateral or bilateral?
Bilateral, always bilateral. But even if one of the ovaries is showing the changes, that is good enough for diagnosis.
And what is the threshold count of the small ovarian follicles by the new AES guidelines? And do you follow them or you follow the old guidelines?
No, sir. No, the newer ones talk about 25 follicles. The older ones used to speak about 12. Now, the problem is I don't know what kind of a machine my radiologist is using.
Correct.
And not all radiologists use the same high-frequency probes. So I would still go by the 12 because most of the machines that I have access to are old.
Is the size important to you, the 10 ml size?
Yes, it is important. And so we would look at a volume of 10 cc. But the problem is that as women age, the volume shrinks. So there is a new thought that after the age of 35, you should be looking at 8 cc and not 10 cc. And the other thing is what I frequently do, I look at the stromal to total ovarian volume ratio and the stromal to total ovarian area ratio. These are extremely specific even after treatment. Because with treatment, the number of follicles reduces, the volume shrinks, but the ratios do not come back to normal.
Is the day of the ultrasound important when checking for PCOM?
So basically, you don't want a maturing follicle in there. You don't want any follicle which is more than 10 millimeters. So I would prefer the early follicular phase in somebody who's menstruating regularly. That would be day 4 or day 5 for the transvaginal.
Why is it that this day is preferred?
Now, beyond that, basically you have maturing follicles which will alter the volumes itself.
Yeah, thank you. Ultrasound is also not considered the first line investigation under what age group and why?
So in adolescence, you have something known as multicystic ovaries. And it is not very easy to distinguish between polycystic ovaries and multicystic ovaries. For this reason, it is not really encouraged in adolescents. Also, the reason that you can't really do a transvaginal ultrasound.
Yeah. And also, there are lots of normal women with normal cycles who also have PCOD morphology. So therefore, polycystic ovaries by themselves as the sole criteria do not fit in with the diagnosis of PCOS as a sole criteria. Now, this I want to ask you, Dr. Tripathi. AMH values have marked changes in reproductive span. Thus, the threshold values can change. Yet, it is considered as one of the basic tests in AES guidelines for diagnosing PCOS. What are your views on this? And also, the AMH assay values may change with age and assay technique. So, why are we still keeping this as the main test?
I think this has come up in the American Endocrine Society guidelines and the Androgen Society guidelines, but we generally do not use AMH as a marker for PCOD because it is, firstly, it is not very well validated and it doesn't help very much in assessing the patient. So we don't use AMH in general, but in a specific case we could use AMH. So these criteria have just come up in the recent couple of years. And we do not really rely on AMH to diagnose PCOD.
Manas, what are your views on this?
So my thoughts are that the AMH, we know this value of approximately about 10 nanograms per ml, but this, it is probably more beneficial in older women rather than younger women, where we talk in terms of, more than 3 times of that particular value as being significant. I think in the younger woman, its value is probably less.
If ultrasound data is unreliable or the patient is obese, wouldn't it become an advantage to do this test?
It would be a supportive evaluation in a younger woman. It would not be diagnostic in any way.
What is the sensitivity and specificity of this test?
I wouldn't know the answer to that question. If you ask me exact values of sensitivity, specificity, I wouldn't know.
Specificity is about 90 plus and sensitivity is about 70, 75.
These values change with age. That's what I'm trying to tell you. It changes with age.
That's the negative. That's the disadvantage.
Specific in the older woman. So I wouldn't know exact values, but these changes with age.
Yeah, the other day, somebody was talking about this and they said that as the woman ages, the AMH values go down. So that's the disadvantage. But it does correlate with severity, the individual features of PCOS. It also increases in obese or lean women. It helps to differentiate classical from non-classical and increases in non-obese adolescents also. And we can also measure the therapeutic response to the drug being given with this. So I would say that it's a fairly good test to use. I use it in my practice.
I just have one.
Sir, may I make a point, please?
Yes.
Dr. Kandari, now they said it's supposed to change between women of various ethnicities. So in Korean women, the standard is supposed to be 10. And in a very good Indian study last year, they said it was 5.03. And even there, the sensitivity and specificity both were in the early 70s. So I would think that if you're not able to get a good ultrasound, this is at best a surrogate marker for PCOM rather than anything else.
Right.
Kandari, just one more point. The advantage of AMH is that it can be done at any part of the cycle and it is not altered by OCPs. So we have a great advantage, but the only disadvantage is that is more expensive. So I was just wondering whether we can ask Tripathi how about looking at PSA, because PSA is supposed to be equal to AMH when it comes to PCOS.
Dr. Tripathi, would you like to comment?
You asked P. What did you ask? What was the
PSA,
question?
prostate specific antigen.
Well, actually, most of these tests we practice clinical endocrinology, and most of the tests are redundant. I feel in a clinical practice, because you just base your diagnosis on the clinical aspects of the patient and what you have to treat. So if you go around doing too many tests, then you get stuck. So PSA and AMH we generally do not perform in clinical practice. We just base our diagnosis on the clinical criteria, and that helps a lot in the treatment of the patient. So I personally not done PSA.
Dr. Padia, shortage of time now. I'd like to ask you another question. Most dermatologists are taught that the DHEAS has got lack of sensitivity and specificity, and therefore it should not be much used in PCOS, but still useful in tumors. What's your comment on this?
That's true, because in tumors the levels go up very high. So if you have an adrenal tumor or even indeed an ovarian tumor, then the levels are extremely high, like testosterone levels could be high. So these are two tests which are indicative of the tumor, like a tumor marker, and they would suggest a tumor of the adrenal or the ovaries. So DHS is useful from that point of view.
There's another test, serum alpha-3-diol, 3-alpha-diol, as a marker for idiopathic hirsutism and PCOS with hirsutism. Your views on this? Should we do this test really, or is it not useful?
I think, as I said earlier, we generally do not tend to do too many tests, and we have not used alpha-diol or PSA or AMH very much in clinical practice. I think the role is very remote and very less. So we do not use these tests very often. We just base our diagnosis on clinical grounds.
Yeah. Thank you. Actually, the elevated levels simply reflect the presence of hirsutism rather than the cause or excess production of DHEAS from any source. Because this is it's a precursor of DHEAS. So therefore, I think it's not a recommended test in the evaluation of idiopathic hirsutism or any form of hirsutism for that matter. Other features of PCOS which are not included in the diagnostic criteria. We follow the diagnostic criteria. There are many which are not included in the diagnostic. Abnormal pattern of gonadotrophic secretion, for instance, insulin resistance, metabolic abnormalities, and cardiovascular risk and dyslipidemias. We all see this in PCOS patients, but they are not included in the diagnostic criteria.
Hypertension as well.
Dr. Tripathi, your views on this?
You're absolutely right. Some of these other tests which are part of the metabolic syndrome or part of the insulin resistance syndrome, they're not diagnostic for the PCOS diagnosis, but they are important tests to be done by themselves because they help in treating the patient. So the patient who is being treated for dyslipidemia, for metabolic syndrome, preventing cardiovascular disease, diabetes.
Thanks. Dr. Rajita, how important is it for you to measure LH-FSH ratios in PCOS in your practice?
Not at all, so I never do that.
Why
Basically,
do
if
you
somebody
not
is
do them?
because it is very specific, but it is not a sensitive marker, and it's not going to add value to how I treat.
So there are differences in the data supplied by different tests. BMI affects the levels, day of the cycle effects, and relationship of LH-FSH ratio in the pathogenesis is unclear. So these are not a diagnostic criteria. They neither make nor exclude the diagnosis. I think that's the message that we should give to the people today, that LH-FSH, there are lots of people still doing it, but I think the message should be that it should not be done. Dr. Manas, when do you call a person obese, and how often do you see obesity in PCOS patients coming to you?
So obesity is quite common, though we have lean PCOS patients as well, patients with a BMI of 25 plus. So in these cases, so this is actually quite common, and these are the patients where we actually look for, do a fasting and a postprandial insulin. This is one additional investigation.
Why is obesity important to treat in PCOS patients?
So because treatment of obesity actually improves PCOS, so that is important. It corrects menstrual irregularities. It corrects the insulin resistance. That the insulin resistance is linked to obesity. And if you correct the insulin resistance, your features of PCOS improves because insulin is responsible for a lot of the pathogenic mechanisms of PCOS.
So there are lots of people who tell the obese ladies with PCOS, improve your diet and improve the exercise. So it's a lifestyle disease in a way. Is that what you're wanting to say?
Absolutely.
Tandari sir, the BMI
Yes,
cutoff for Indians is not 25, it is 23.
Yeah, that's right. The BMI for Indians is 23, not 25.
Dr. Tripathi, I'd like you to take this exclusion of other androgen excess disorders in brief. How would you exclude NCCAH, androgen secreting tumors, Cushing's, severe IR, and idiopathic hirsutism?
For CH, one would like to do a 17-hydroxyprogesterone. 17-hydroxyprogesterone generally done in the first, second to 50 of the cycle, and it should be done in the morning, early morning fasting. If you find the levels high or borderline, then you may like to do an ACTH stimulation test, which will establish the diagnosis. If the levels go up above a certain cutoff, then you have a definite CH. This is late onset CH. And the second thing is Cushing's. Yes, sir.
Androgen secreting tumor?
Androgen secreting tumors by testosterone levels as well as DHES levels. And you can do this is cutoffs written here, testosterone above 200 nanograms per deciliter. Then you have the insulin resistance syndrome is of course a clinical diagnosis with acanthosis, obesity and the other features. You may have lean patients also with insulin resistance, so that leanness doesn't exclude insulin resistance. And if you have Cushing's syndrome, that's of course a rare syndrome, but you like to establish the diagnosis. You often have these days one talks about subclinical Cushing's disease. So if you have subclinical Cushing, the patient may not have any overt features. So you do a midnight cortisol, or you can do a 1 milligram DEXA suppression test. That is a screening test, 1 milligram DEXA. So you give 1 milligram DEXA in the night at 11 p.m. and do a cortisol in the morning at 8. If it is less than 1.8 micrograms in the morning at 8 a.m., then you rule out Cushing's. If it is more than 1.8, it is Cushing's. Then you do the other test for Cushing's. And idiopathic.
How about idiopathic hirsutism? Which is the most important test for idiopathic hirsutism, or there is no test?
There is no real test, it's just a diagnosis of exclusion. If you have excluded most of the other disorders, then it's likely to be idiopathic hirsutism. I don't think there's any.
Do you believe that SHBG is usually low in these patients?
SHBG is low generally in obese patients, but not so. I'm not sure if it is particularly important for idiopathic hirsutism.
Okay. So I just wanted to get an endocrinological view, because dermatologists read and we believe from whatever we read in the, journals. But you are an endocrinologist, you are seeing these patients and actually practicing it. So I wanted your opinion on this at all. Now, here is a lady, Dr. Shelley, I'd like you to take this. 20 years old female with mild acne and hirsutism. Ultrasound positive, only DHES positive. Any further tests, and how will you manage this patient? Dr. Shelley, are you with us? Can you take this, please?
Yeah, sure, sir. So this is a young female showing features of like nodular acne are there with hirsutism is there. I think ultrasound is also done. So we would not actually want to go for more tests. And, management would be targeted at treating the symptoms, treating acne, treating hirsutism. Treating acne first, we would just go with the conventional treatment. Along with, we can add up oral contraceptive pills. Which would include a combination of estrogen plus a low androgenic potential progesterone.
Would you like to give a low dose steroid in this?
So personally, I would not.
Rajita, how about you?
Kandaris, I'd like to do a TSH under prolactin in case they have not been done. And I might consider doing a 17-hydroxyprogesterone, considering the fact that she's rather thin. I would take a good family history. So if that is positive, now if that is more than 10 then low dose night steroid. But actually I would be sending her to
What's
my
the kind of dosage of low dose steroid that you would normally give in these NCCH patients?
So actually I don't manage this, but my endocrinologist and I manage them together. Typically it would be something like 5 mg at night of prednisolone equivalent.
Yeah, we can give that.
Would you like to comment on that?
We can give steroids, generally given in the night so that it suppresses the ACTH secretion in the early morning. And we can give 5 milligrams of prednisolone, or you can use 0.5 mg of dexamethasone. That also suppresses and it's a long-acting drug.
How long should we give this, and what's the criteria to give it, when to stop, and so on?
Generally, we use it for about 6 months. That is the clinical period for which it is used. And in that period of time, you see a good response. And after you stop it, generally the patients tend to remain asymptomatic. In case it persists, then you could repeat the course. Then you use it for 6 months.
Now, Manas, I'd like you to take this. 25 years, obese patient with Hayran syndrome, irregular cycles, ultrasound positive, only insulin is high, oral GTT is abnormal. How will you treat this patient?
So this patient, of course, I would like to use metformin, of course, in addition to whatever is going to be used for the other part of the treatment. But I would like to use, so an insulin sensitizer would be a good drug to use. Metformin, I would start at about 500 milligrams per day. What is her body weight?
Well, she's obese, obviously. I mean, you can see it.
So of course, so definitely we would like to, as I had mentioned before, we would like to have a look at the fasting and the postprandial insulin levels. So that is one thing which we would like to do. And having
what tests do you do for insulin resistance in your clinical practice?
So we do a fasting and a postprandial serum insulin level. So that is the test which we most commonly do. So fasting
With
insulin
food
level.
or with glucose? Do you do the PP with food or glucose?
So with glucose, but then again here now you can do it at half an hour post glucose or 1 hour. So normally I do a half and a 1 hour, either a half and a 1 hour. So the fasting insulin about 3 to 8 microunits per ml, and at half an hour I expect anything below about 150 to 160 micro international units per ml. So that is of course with glucose, not food. And so that is, of course, an assessment of insulin resistance. So in this kind
Bhatti, I'd like to ask you, are these tests for insulin resistance really necessary?
So in this, that's what I was going to say. Now, in this particular patient, seeing the patient's morphology, so actually speaking, it may not be necessary. With this particular patient, so that is what I was going to say when you mentioned. So in this particular patient, it may not be necessary. So that because, I would probably start insulin either ways because, metformin either ways, because in this kind of a patient, probably doing an insulin may just be increasing the patient's cost.
Rajita, do you do a HOMA-IR in your practice?
So I do it because I am a dermatologist. If I was an endocrinologist, I would not do it. Basically, I have to justify the fact that I am giving metformin, a sugar ka dawa, to my patient who is not diabetic.
Correct. Dr. Tripathi, your views on this, please?
Kind of a patient, that's what I wanted to know, Rajita. Obese patient, all these, this kind of a morphology. Do we really need to sort of, do a HOMA-IR and justify? That's
not really. See, acanthosis nigricans is equivalent to insulin resistance. But
Dr. Tripathi, your views on this, please. Dr. Tripathi, your final views on this as an endocrinologist.
I think that, as I've already mentioned all through the course of this discussion, that diagnosis is clinical and we'll not resort to a test which will not help treat the patient. As Dr. Rajita said that we'd like to add metformin. Metformin is a very commonly used drug. It's a safe and harmless drug. So you don't have to justify its use. The justification is the acanthosis and the obesity. And another thing I'd like to add here, recently there's the role of another drug, it's called liraglutide, which is a GLP-1 receptor agonist, which is used in the treatment of obesity and, of course, bariatric surgery in an extremely obese, morbidly obese patient. Because treating the obesity...
Oral GTT is also recommended in many of the books and journals. What's your comment on this?
Oral GTT
Should we do
is
it in obese patients or in these patients who are suspected?
What we'll do in this patient is to do a fasting sugar. If the fasting sugar and the postprandial sugar are high, then he has diabetes or he or she has diabetes. If the values are borderline, then there's a role for GTT. GTT is generally done in pregnant women for gestational diabetes, or if you are at the borderline, you cannot conclude that the patient has diabetes. Otherwise, the simple diagnosis of diabetes is fasting sugar more than 126 and a PP sugar more than 200. If that is true, then you don't need to do a GTT. Because GTT is not a reproducible test. You do it today, you do it tomorrow, you'll not find the same results. And it has to be done with a lot of, like 75 gram glucose has to be measured, to drink it in 250 ml water.
What's the rationale of using metformin in your practice?
Metformin is used for the treatment of insulin resistance because that is also the cause for the polycystic ovarian disease, one of the causes. And if you treat the insulin resistant, then you can, of course, it's not a weight reducing drug, it's just an insulin sensitizer. And therefore, it should be used for treatment of insulin resistance, not for obesity treatment, because obesity doesn't get treated with metformin, just reduces your appetite to a certain extent and is not an anti-obesity drug. So just for treatment of insulin resistance.
would you say that routine use of metformin without insulin resistance is not recommended?
Yes, I would guess so because it has problems. It can cause GI disturbances. It can cause vitamin B12 deficiency. So if you don't justify its use, you don't need to use it. If you have a lean patient who has no evidence of insulin resistance, you may not use metformin.
And also it has no impact on anovulation or hyperandrogenism without insulin resistance because it is acting through the insulin itself and therefore that is producing the hyperandrogenism.
But as I
If
mentioned
that is not the
earlier,
case, there is no point. So only for regularity. You see, lots of people, lots of dermatologists, lots of gynecologists are just giving metformin without even evidence of insulin resistance at all.
But sir,
You
if there
find
is
in so many prescriptions.
But Dr. Sanjeev, if there's clinical evidence, like for example, in this particular patient, you have acanthosis. If there is clinical evidence of insulin resistance, it may not be biochemical.
Yeah, that's right. But the fact is, insulin resistance must be there for us to give it. But there are lots of people, they say, okay, you have this, take metformin. You have PCOS, take metformin. You see, in metformin without insulin resistance is basically to control the cycle or regulate the cycle. And therefore, this has to be combined often with OCPs, which control the hyperandrogenism if insulin resistance is not present.
Kandari sir, I've seen endocrinologists advising metformin to idiopathic hirsutism patients, and this has happened on a big stage in our own conferences.
Yeah, that's what I'm saying. That lots of people are giving metformin just like that. So I think we have to be sure about one thing, that IR has to be present for us to have the benefit effects. There is another patient with irregular menstrual cycle, hyperandrogenism, ultrasound is positive, LH-FSH ratios, no other tests are positive. Treatment recommendations, Rajita?
So again, I would want to look at the TSH prolactin, and I would want to put her on a oral contraceptive pill. My preferred one would be the drosperinone with the ethinyl estradiol 30 microgram combination.
What is
along
the
with
aim of giving an OCP?
So basically,
What does an OCP do in these patients?
It does multiple things. One, it increases the SHBG so that the amount of testosterone available is reduced. It acts on the pituitary, and by a negative feedback to the ovary, it reduces the amount of testosterone that is being produced. And
Okay.
next
What
thing I would
OCP
want
would
to
you
add
like to
would
give?
be
You've already
spironolactone.
said the drosperinone.
Yes, drosperinone.
What's the
ethinyl
advantage of
estradiol.
drosperinone over, let's say, Diane?
So two things are: one, drosperinone encourages weight loss. That alone can reduce weight by 1 to 2 kgs, and it has a less unfavorable effect on the metabolic profile, including the lipids and the sugars, compared to cyproterone 2 mg.
Yeah, so you prefer to use something like Yaz?
Yasmin, sir, Yasmin, because Yaz has only 20 micrograms,
Yeah.
and 20 micrograms is not going to have enough of a negative feedback on the pituitary to reduce the testosterone production.
Dr. Tripathi?
Drosperinone is anti-androgenic as well.
Dr. Tripathi, could you comment on this?
Yeah, we generally tend to use Yasmin or Yamini as it's available in India, and Yaz is less frequently used. And we use OCPs with this combination very often, and it helps in many ways, as Dr. Rajita has just described, and it's a good drug. And can be
Which
used
day of the cycle should we give this?
Yasmin, or we start on the first day. There are different views. Some of the gynecologists start on the 5th day, but what we tend to use as endocrinologists, we start on the first day of the cycle, give it for 21 days, then you give a 7-day break, and the 29th day you start the next cycle.
Why do you start on the first day? What is the why do dermatologists start on the 5th day? Or a gynecologist start on the 5th day?
The gynecologist
What's the
starts on the
difference?
5th day. I think
What's
the
the
difference-
advantage of the first day or the 5th day?
The
To
advantage
my
that
mind,
is-
why dermatologists do it is from the 5th day you maintain the regularity of the cycle. You don't change that. That's why we use it or I use it.
I think from the point of view of the overall impact of the drug, it's better to start from the first day because you have the effect of the drug starting early in the cycle and it continues for the 21-day period. And when you give a break of 7 days, you have your menstrual cycle like you would have normally. And from the 29th day, you restart the pill. So you don't wait for the cycle to end or start. So a lot of patients, they don't start the drug the next cycle till the periods have come. So we don't do that. We just give it for 21 days, 7-day break, 29 days you start the next cycle of treatment.
And how long should we continue the OCP?
That generally is tend to be used for 6 to 9 months. That's the general duration of treatment. Of course, it depends on whether it's being used in addition to spironolactone and other things. So it depends on the clinical outcomes as well as the other drugs which are used. But we tend to use it for 6 to 9 months.
Is weight gain, hypertension, cardiovascular is an issue in giving an OCP?
I think the major issue is venous thromboembolism. That is an important thing to be ruled out. But the other factors are not very important.
How about breast and cervical cancer?
I think the patient should be evaluated for that if the patient is in that age group. But in a young girl or a lady who is being treated for polycystic ovaries, we're not taking that into major consideration. But yes, it is an important issue. The more important issue is the venous thromboembolism.
Okay, but there are lots of people who believe, like for instance, there's a Professor Thibaut. She's lectured on this tremendously, that the risk-benefit ratio in acne, we should give versus not give an OCP when treating in a patient with severe acne. Rajita, what's your comment on this?
On breast carcinoma and
No, thromboembolism.
Thromboembolism. Now, in general population, the risk is 3 in 10,000 women years, and OCPs would double it. So when you hear that, it's very scary for patients. But when you're looking at it, it is only 6 per 10,000 women years, and the most thrombotic episode a woman goes through is pregnancy and postpartum period. So there, the risk is 30. So if a woman has survived a pregnancy and postpartum period, it is highly unlikely that if you tick off your WHO checklist, she's going to be at risk. So smokers, age beyond 35.
May I say something?
Yes, Manas.
Okay, the thing is that this risk definitely is more in the older. So if you're dealing with women below 35, it's not that big an issue, as Dr. Tripathi mentioned. Second thing, of course, these girls are usually non-smokers, so that is not a problem. And a lot of times, if you're using spironolactone, there is an advantage when you're combining these two, because spironolactone itself is anti-thrombotic. So it's sort of, in women where you have a bit of an issue, you have some risk factors in terms of age, etc. So this use of spironolactone sort of counters it to an extent.
Yeah, in fact, that was my next question. It inhibits androgen receptors. It's an excellent drug, and it's still underused by most dermatologists.
Yeah. So,
where would you use spironolactone, Manas?
So spironolactone is a drug which basically, it has got again various mechanisms of action. It is anti-androgenic. It is anti-aldosterone as well because of a metabolite that is carinone, and of course it's weak progestin. And because of the fact that is a weak progestin, that is why it's one of the reasons why this is one drug which reduces cycle. That is why this is one drug which you need to use with an oral contraceptive at all times. Of course, it acts against the receptor. It decreases.
Yeah, okay. Now I'm going to go a little faster, Manas. Spironolactone or finasteride? Which would you prefer?
Spironolactone, not finasteride. Finasteride is not recommended in the reproductive active years. So if you're using finasteride, you don't have any backup in terms of labeling. So it is not a recommended drug in this age group. So
what's your experience about dutasteride in treating hirsutism?
Okay, dutasteride, I have used dutasteride actually. Again, the dutasteride I've used actually in patients with androgenetic alopecia. Hirsutism in women, no, I don't have any experience. Again, no labeling indication of using dutasteride in hirsutism in women for the same reason as we don't use finasteride. So here, spironolactone is a much better drug. Excuse me?
How do you prevent premenstrual flares?
So the premenstrual flares, of course, the use of OC pills and along with spironolactone would sort of take care of it. Spironolactone is one drug which I give if there's an additional hirsutism. Hello, can you hear me?
Yeah.
So spironolactone is one drug which I give if there is any additional hirsutism or if there is any additional female pattern hair loss. This is one drug which works very well in these two additional, features.
What dose and how long do you give it?
Okay, so spironolactone, normally what I do is I start at 50 milligrams. Then I gradually go up. This is a drug which we go up gradually. We gradually go up to about 150. But in a patient of PCOS, a low dose works quite well. So we go up from 50 to gradually go up to about 150 milligrams. The only thing is, as I said, here we need to be a little careful about certain things. The fact, of course, that, there is sometimes these patients do have a little bit of gynecomastia. and hyperkalemia, but hyperkalemia is something which is probably more hyped than true, because if the kidney function is normal, hyperkalemia is not a problem.
Thank you. Dr. Tripathi, I'd like you to take this one. 23 years old female with hirsutism, ultrasound positive for PCOM, only prolactin is high. What level of prolactin should we consider as high?
If you have a pathological
Sanjeev, can you wind up?
Yeah.
If your prolactin is pathologically high, then it should be generally more than 100. Above 200 is definitely high. Less than 50 or 60 is generally not considered significant. That may be for various reasons like stress or even needle prick when you take the blood sample that causes. Or you must rule out the most common cause for hyperprolactinemia is drug-induced hyperprolactinemia. A lot of these patients may.
Why do we order a pooled sample?
Pooled sample we do because of the fluctuant nature of the secretion of prolactin. It has a fluctuant secretion. Every 2 hours it goes up and down. So you tend to average out the values by taking a pool sample. You take it at 20 minutes or 15 minutes apart, 3 samples, and pool it together and do a sample. When you do it in the mornings, fasting.
Okay. With that, I'm going to end this session. There were 2 or 3 more case discussions which I could have taken up, but Dr. Gupta is keen that I wind up in respect of time of others. Well, the last slide I'd like to show you is that we must all bid for Dermocon International for Delhi. I stand for Delhi, and I'm sure you all will stand for Delhi as well with me. With this, I thank the panelists and my chairpersons for having given me this opportunity.
Thank you, sir. Thank you.
Chennai also. In Chennai also. Dr. Maya is there from Chennai.
Thank you.
Thank you, Dr. Sanjeev,
No
for
Mumbai
conducting
people.
this session.
At this time. Dr. Ganju here. Dr. Maya is with us this time.
Yes.
My Chennai people will disown me.
You have to pitch a tent outside Chennai.
Thank you. Let me wind up this session. I must thank Dr. Sanjeev Kandari for conducting this session very nicely, as this is his favorite topic and he conducts it very. And I thank all the panelists for their very wise inputs on all the questions. And again, as a organizing co-chair, I am also requesting you to please vote for Delhi bidding for Dermacon 2023, requesting Dr. Maya also to vote for Delhi. And I can promise you that we are going to give you a grand conference at a very grand venue. Thank you very much.
You have to give alternative accommodation to Dr. Maya.
Yeah, sure.
She has
I
to
thank
see
the chair
Chennai.
for this interactive session, and I request Dr. Sumit Gupta for a second audience quiz.
Thank you. Was correctly given by Dr. Sonali Bhatt. She was the first one to send the correct answer from Chandigarh. Someone from Lupin, from their field force, would contact you at your clinic and deliver the pulse oximeter to you. Now, going on to the next question, since the panel was on acne, so the question is related to acne, although not so much on hormones. Just to reiterate, for those who joined us a little late, this is the response column. Put in your answer in the live question answer field and then press the submit button. Make sure a name and location are already entered. So here is the question. Acleef is a topical medication approved by US FDA in 2019. Name the site of action. So your time starts now. It's 10 seconds. Only in these 10 seconds, whatever answer that we receive, it should be complete answer, mind you. And whatever answer we receive, it's only going to be from these 10 seconds. Time is up. And answer to this question is RAR gamma. Retinoic acid receptor gamma. Okay, so yes, so we did get a correct answer from Dr. Ria Ahuja from AIIMS New Delhi. She was the first one to send in the right answer, although we have got so many correct answers after her. Dr. Ria Ahuja, again, you would be contacted by someone from Lupin and they will be delivering your pulse oximeter to you. Over to Dr. Khushbu again.
Congratulations, Doctor. After an exhilarating panel discussion, let's now invite Dr. Jayadev Betkarur, Professor and Head, Department of Dermatology, JSS Medical College, Mysore. He is also the President-elect of IADVL 2020-21, and Dr. O.P. Gangwani, past President, IADVL Delhi State Branch and Senior Consultant Dermatologist, to chair the session for short talks.
You're not audible, Dr. Betkarur. You unmute yourself.
क्या उम्र है?
Now? Yeah, are you audible? Am I audible? Yeah?
Yes, sir.
Okay. Good morning, everyone. And I think I'll ask Dr. Gangwani to take over the session to begin with. He will be introducing the speaker, my friend Ganju.
Dr. Gangwani, unmute yourself. You are not audible.
I think Dr. Betkarur can take over for the time being. Am I audible, sir? Dr. RP?
Yes, sir, you're audible. You can begin the presentation, sir.
I think Dr. Betkarur can make an introduction.
You are audible, Anil. You can start your talk.
Should I start, Dr. Betkarur?
Yes, sir, please.
Okay, friends, good morning all on this beautiful session on DAS. We have had very engrossing sessions since morning. And although I miss the glamour of being at a physical DAS where I usually used to flaunt my dresses, I miss that, and I missed meeting and hugging friends. But nevertheless, God has been kind. At least we are able to connect through this web virtually. Thank you, DAS. Thank you, the organizing committee, Dr. R.P. Gupta, Dr. Rohit, Dr. Archana, and Dr. Shyam Verma for giving me this opportunity. I shall be talking about hyperhidrosis, primarily palmoplantar hyperhidrosis and also axillary hyperhidrosis. So, friends, palmoplantar hyperhidrosis is quite a common disorder. It's quite disabling, is associated with chronic sweating of palms and soles beyond the normal thermoregulatory needs. It can be primary, where there's no cause, and usually this kind of the condition sets in early in life. And it can be secondary, where there is an underlying cause. The primary one, as I said, sets in early in life and usually stays and persists for all the duration of the life. And it has been attributed to a localized overactivity of the sympathetic nervous system that induces the sweat glands to produce excessive sweat, more than what is required for normal thermoregulatory mechanisms. The secondary one, of course, has a underlying pathology, or, for example, there could be a use of some kind of medication. The condition, although benign, can be a cause of huge social, emotional, and occupational distress to the people who are affected, and it can interfere with the daily day-to-day activities of the patient. As I said, it happens because of an overdrive of the cholinergic system and the input to the eccrine glands, which are rather normal. Histopathology and the pathophysiology, physiological studies of the eccrine glands in these patients have shown that the glands are absolutely normal, and it's overactivity of the nervous system that is inducing sweating. And it happens because of a dysfunction of the sympathetic nervous system. Also, inputs coming from the hypothalamus. This is coupled with an input from the anterior cortex of the limbic system. And this is probably the reason that these patients have excessive sweating due to stimuli like emotional outbursts, like anxiety, etc., where sweating can happen in these patients. And we try to control anxiety, we try to control emotions while we counsel these patients. The condition can be assessed and diagnosed by a simple OPD test, the starch iodine or the Miner's test, where we use an alcoholic solution of iodine 2%, which is applied to the hyperhidrotic area, and then we sprinkle a little bit of starch on the area. The sweat in the hyperhidrotic area dissolves the iodine from the solution, and then this iodine complexes with starch. Basically, the iodine atoms get trapped in the helices of the amylose chains in the starch, and this is shown as a dark blue staining in the area of hyperhidrosis. This is a scale of assessment of the severity of the disease, score 1 to score 4, depending upon the severity of the disease. So now let's come to the main aspect, how I manage this condition. Now, as far as our OPD practice is concerned, we mainly depend on antiperspirants and to some extent oral anticholinergic agents, and less often to more invasive modalities. Antiperspirants usually contain aluminium salts, and these are the first line in most of the patients of primary focal hyperhidrosis, whatever the severity. The exact mechanism could be these aluminium salts causing a blockage of the eccrine sweat glands, leading to functional and structural denervation of the ductal epithelia and glandular secretory cells, and this reduces the sweating. We usually start with an aluminium chloride hexahydrate solution applied twice a day over the hyperhidrotic area, and then slowly taper it off to maybe once in 2 days, once in a week, up to once in a week application, which gives reasonably good response in a good number of patients. Optimally, however, it should be applied just once at night on a thoroughly dried skin, which I'll tell you why. It should be kept on the skin for at least 6 to 8 hours before it's washed off. And once you have achieved the good results, then you can reduce the frequency slowly and make it maybe once or twice a week. Most of the prescription products contain aluminium chloride hexahydrate, 10 to 35%. Some of the newer developments in antiperspirants, a thermophobic foam has been developed with a 20% solution of aluminium salt and has been found to penetrate the thicker skins like palms and soles better and be associated with lesser side effects. My major problem with antiperspirants is that it can produce a lot of irritation, burning, numbing, tingling sensation, etc. Sometimes vesiculation also on the treated area. This happens because this aluminium chloride, when it reacts with water, it can produce hydrochloric acid, which can induce this kind of symptoms. And this you can limit, one, by applying the compound on a completely dry and intact skin. So that makes it important that you dry the skin completely and apply it. Also, you can use a mild corticosteroid in the morning, and then in the night you apply this agent. A pre-application of some petrolatum jelly, etc., in the surrounding areas also reduces irritation. The other problem with antiperspirants, particularly in axillary hyperhidrosis, is that it can stain the clothing, because the hydrochloric acid produced can induce staining of the clothing. The third thing is that the effect is transient. So as soon as you discontinue using them, the perspiration comes back. So you have to keep on using, although at a lesser frequency. So these are the shortcomings. Then before I go to other modalities, the other thing that I do in these patients is use of systemics. And Anticholinergic agents like glycopyrrolate is a very good agent that I have found useful in my practice. The good thing about this quaternary amide is that it does not cross the blood-brain barrier to a large extent, and so central nervous system side effects are very, very minimal. We usually start with a low dose of 1 to 2 milligrams once or twice a day and slowly escalate the dose. Lots of side effects have been mentioned, like the anticholinergic effects like dry mouth, dry eyes, orthostatic hypotension, GI side effects, urination, etc. But I do not come across many of these in my practice if I have used up to maybe 4 or even 6 milligrams a day. Although I don't go up to 10 milligrams. It is contraindicated in people who have gastric and gastrointestinal motility defects, who have myasthenia gravis, who have glaucoma, who have urinary retention, etc. In all these, the conditions can get aggravated. So you need to remember these side effects, remember these comorbidities where it is not to be used if you are using a anticholinergic agent. The other thing that can be used locally is iontophoresis. I have used it in some of my patients, but because it is messy, patients do not generally continue using it. So what we do here is we use ionized substance to pass into the skin and cause blockage of the sweat glands or the effluent glands. Sometimes, most of the times, we use just plain tap water, but you can add an anticholinergic agent to the iontophoresis solution. Sometimes even botulinum toxin is added. I'll come to that later on. So you submerge hands and feet into shallow trays of water and then apply a low dose current of about 15 to 20 milliamperes over a period of 15 to 40 minutes. And this is done once or twice a week. Slowly you bring it down to once every week or once every 4 weeks. Many of the patients become normal with this. Mechanism of action is not very well. Mechanism of action is not very well.
Can you please mute your computer and phone, please? Yes. Yes, sir.
I think our technical team should mute everybody. That will be better. Okay, iontophoresis seems to be working by deposition of the ions within the sweat gland ducts, probably by blocking the transmission of the sympathetic nerves locally, also by decreasing the pH locally. So these are the plausible theories by which the iontophoresis works. The problems can produce erythema, vesiculation, burning sensation, pins and needles sensation, but this is usually mild and can be managed by moisturizers. Not to be used in pregnancy, not to be used in people who are on electrical devices like pacemakers, not to be used in people who have electrophysiological disturbances like cardiac arrhythmias and epilepsy. Now, the other thing that can be used locally is the botulinum toxin injection. Again, it has its shortcomings, although it's quite effective. The two major shortcomings are the cost involved and the pain involved in the injection. So I have not been using it very extensively. In some of my patients, I have used it, but the problem of pain locally is what limits its use. So it works by reversibly blocking acetylcholine release from the presynaptic receptors at the nerve terminals, so somewhat causing what is known as chemical denervation. It's a simple OPD procedure though, but it's associated with pain. You have to determine what are the hyperhidrotic areas with a proper Minor-Star test before you inject this, and a dose of 0.1 to 0.2 ml per square centimeter in a grid fashion is injected, and the solution contains 1 to 2.5 units every 0.1 ml. So 1 unit per 0.1 ml is what we have generally also for normal Botox injection. So that is the solution you have to inject, and 0.1 ml every square centimeter in a grid pattern. The effect comes in within 3 days and lasts for about 6 to 9 months. So again, the effect is transitory. You have to repeat injection. So that makes it a difficult proposition because of the cost involved, because of the pain involved. Although studies have shown that as you give repeated injections, the requirement for injections may decrease and the duration between the injections may increase. So if you give it repeatedly by this, as shown by this study by Likoff-Flett et al., they showed that as you give repeated injections, the requirement for injections decreases. I said pain is the major limiting factor. Sometimes there may be transient weakness of the hand and foot muscles because of the diffusion of the toxin down into the muscles. So this can be reduced by avoiding massaging in the area for 1 or 2 days after the injection. Again, contraindicated in pregnancy, contraindicated in muscular weakness defects or paralytic defects, has drug interactions, so these are to be kept in mind. Botulinum toxin to reduce the shortcomings of pain have been used in other delivery systems. For example, a combination of botulinum toxin and lidocaine with the help of a jet nebulization has been given. This reduces pain as well as the requirement for the amount used, so that reduces the cost also. So this could be a good, way to deliver botulinum toxin. And even in iontophoresis solutions, botulinum toxin is added to aid the absorption of botulinum toxin. But again, this would be very, very, erratic. We don't know how much of it is absorbed through the thick palmar and plantar skins. Now, people who have failed all kinds of local treatments and systemic treatments can go on to surgical treatment. So surgical treatment is very major and is invasive and has its problems. So you have to very carefully select your patients who are really debilitated by the disease and are not responding to other treatments. Then you go to surgical treatment. And surgical treatment is sympathectomy, which has been done for a long time. Endoscopic thoracic sympathectomy is done to cause the destruction of second and third thoracic sympathetic ganglia. We avoid doing sympathectomy for plantar hyperhidrosis because the lumbar sympathectomy can be associated with sexual dysfunction, can cause bladder abnormalities, so that limits its use. So it's primarily reserved for those difficult cases who have not responded to other agents, only for palmar or axillary hyperhidrosis. So the problems associated are one, compensatory hyperhidrosis happening on the rest of the body. So these people will keep on sweating all over the place except for the area that you have treated. And then there are other serious side effects like gustatory sweating, people salivating and sweating all over the body. Disturbances of taste. There are lots of lung dysfunction that can happen, like pneumothorax, hemothorax, emphysema, infections in the lung because of lesser movement of the chest muscles, etc. So these are the problems associated with surgical treatment. Emerging therapies, topical anticholinergics are being tried, particularly oxybutynin in a 10% gel in this study by Art Z et al. Gave considerably good results both in palmoplantar and in axillary hyperhidrosis in 61 patients when applied twice a day over 4 weeks. Also, glycopyrrolate, available as a concentration of 0.5 to 4%, has been tried in the form of gels, solutions, creams, etc., particularly for axillary hyperhidrosis. These agents work more for axillary hyperhidrosis where the skin is thin, absorption is easy, but not very much for the palmoplantar hyperhidrosis where the thickness of the skin is a problem as far as absorption is concerned. HIFU has been tried and is supposed to cause local denervation, is supposed to cause damage to the eccrine sweat glands and work considerably well, both for axillary and palmoplantar hyperhidrosis, as was shown by the study by Hennig et al. Lasers and microtherapy, again, quite effective in axillary hyperhidrosis. We have lasers like 1064 Nd:YAG, 800 nanometer diode, and microwave therapy. All of them have been used to cause local denervation and decrease in secretion by the sweat glands. So the take home is that this is quite a debilitating condition for people who suffer from it, because it can greatly limit the psychosocial functioning and day-to-day activity of the being that who is affected. There can be a huge effect on the quality of life. You need to follow a stepwise treatment, starting from more conservative modalities and then going on to more invasive modalities. A proper algorithm would be start with topical antiperspirants with or without oral anticholinergic agents. If the antiperspirants fail, go to iontophoresis or botulinum toxin. Finally, if the patients have failed all these agents, then you can resort to surgical sympathectomy only if the patient has a very debilitating disease, because that is associated with a lot of side effects. Before I close, again, I'm sorry you people are being bombarded with this, but I have to say my bit. We at Delhi are bidding for Dermacon International 2023. I promise you the best of academics, best of infrastructure, best of culture, best of culinary delights, best of architecture, everything in Delhi. Be with us. Vote for Delhi for Dermacon International 2023. Thank you very much for your kind attention. Over to the chairpersons.
Thank you, Anil. And I'm sure we are going to miss the night songs by you. Probably we can hear you in the night singing some songs. Okay. Now I have, you know that hidradenitis suppurativa is one of the most frustrating disease to both of us, the dermatologist and to the patient suffering from that. And any treatment that we have are often are not satisfactory to all of us. So we have a very eminent speaker with us, Dr. Jasek. Sorry, I cannot pronounce the correct name, the second name of doctor, so I'm extremely sorry for that. He is at present the professor and director of dermatology department, okay. Yes, of allergology and in Poland, and he is also presently is a candidate for the position of EADB president-elect in the upcoming elections of EADB, as Delhi are also fighting for the same thing. Sir, I request you to go ahead with your talk on the treatment of hidradenitis suppurativa. Thank you.
Dear Chairman, ladies and gentlemen, first of all, I would like to thank the organizers for a very kind invitation to participate in this virtual Congress. It's always nice to be in person in India, in Delhi, but due to the pandemic, we had the current situation. And I'm pleased also to discuss with you some issues on the management of hidradenitis suppurativa. This is the conflict of interest.
No, Rohit, what is it?
And I, of course, work with several farm companies, including those running
okay.
some clinical trials.
Somebody else muted me in the...
For hidradenitis suppurativa. However, I do not have a particular conflict of interest to the current topic. The hidradenitis suppurativa is a recurrent debilitating suppurative skin disease which is manifested by abscesses, blisters, and
I'll join you with the double black.
Okay, no problem. Of intraspinous areas. Right. Concerning the epidemiology, there is no really good study. However, when we were working on the European guideline, we concluded that about 1% of the general population may suffer from hidradenitis suppurativa. And I would like just to underline the diagnostic delay in this disorder. And it was calculated based on the international study that is about 7 years to diagnose the hidradenitis suppurativa. So it's not surprising that the disease has a vast burden in the whole population.
I'm waiting actually.
Measured by the DLQI and averages questionnaires, and all the domains of the quality of life are heavily affected by hidradenitis suppurativa. So it's not surprising that the disease is described by patients as miserable, as horrible, as painful, and it is frequently compared to evil. Concerning the management of patients suffering from hidradenitis suppurativa, I would like to invite you to a kind of patient journey. And of course, the early and accurate diagnosis is crucial for the patients. As I already mentioned, there is a huge delay in the proper diagnosis. And definitely, it's necessary to put the patient on an effective treatment. However, this is a chronic and recurrent disease. That's why the long-term management is really crucial for the patient. So it's not necessary to think only on the elimination of the inflammation at the beginning of the treatment, but you should consider the whole course of the disease. Dermatologists and also the other doctors, they have several possibilities of different drugs and treatment modalities in HS patients. One can use antibiotics, both topical and systemic, also the surgery has a place in any stage of the disease, immunosuppressive therapy and biologics, and definitely the psychosocial support is important for those patients. Looking at this survey, it was clearly documented that the systemic antibiotics, they are the most commonly used treatment agents for hidradenitis suppurativa. There is also the place for intralesional steroid injections, and I'd like just to mention that the surgery is quite common, and based on this study, more than 40% of patients had surgery performed for HS. A few years ago, as a group of European experts, we created this European guideline for the treatment of hidradenitis suppurativa, which is also called acne inversa. And you can see here that the treatment modality which is recommended depends on the disease severity. As I already mentioned, there is a place for the surgery, but there are different surgical modalities for the milder cases and for more severe ones. For example, for the mild case, one can use a deroofing or even the local excision, and the wide surgical excisions are recommended for the very severe patients. Concerning the regular treatment, there is a possibility to use topicals with the topical clindamycin, mainly for the mild cases. Then, with the disease severity increasing, we are using the antibiotics and retinoids. And finally, there is also the place for the new treatment, which is a biologic agent. However, one should also remember about the adjustment therapy with the pain management, treatment of superinfection, and also the control of the weight is really crucial for our patients. I like this diagram, which was proposed by the friend of mine, Dr. Wyan Gulliver, and it's clear that for the really just mild cases, for example, with the Harley 1 stage, one can use only topical treatment or the tetracycline orally. For the moderate or more severe patients, we are using the combination of antibiotics orally and also the anti-inflammatory biologics. And please pay attention that we have several treatments which were proposed as a second or third line therapy, but the scientific value of those treatments is very, very limited. Let me start with the lifestyle modifications. Please keep in mind that the weight reduction is very important. There is a correlation between the weight of the patient and the disease severity. That's the same for smoking. That's why the smoking cessation is recommended, local hygiene, loose-fitting clothes, warm compresses. These are the important issues and very easy to perform. The disease is very painful, so we should pay attention to the pain control that can be done with the topicals and oral medications. And among topicals, lidocaine or even the diclofenac gel, 1% can be recommended, and many patients are using the ice packs. Concerning the oral medications, non-steroidal anti-inflammatory drugs are important. However, I really do think that the opioids are the really last line option, so we try to do our best to avoid opiates in hidradenitis suppurativa. However, there is a subgroup of patients, and we should use even the opiates to eliminate or to diminish the intensity of pain. The topical treatment, definitely only for the mild cases, and unfortunately, looking at the literature, we do not have a lot of data on it. There is one study on clindamycin, and you can see that definitely there is a possibility to achieve the improvement. However, personally, I like Resorcinol as a topical treatment. And based on this study performed by the group from Denmark, we are using a high percentage Resorcinol, 15% Resorcinol, for the Harley 1 and Harley 2 stages. And really, it works in my hands. Concerning the intralesional steroids, I do personally think that they are not curative agents. Usually we are using triamcinolone acetonide, of course, diluted to 5 to 10 milligram per milliliter. However, we can receive only the temporal improvement. If the inflammation is very enhanced, we can use the intralesional steroids just to diminish the inflammation. And also, you can see the improvement in the pain assessment. The antibiotics, I already mentioned about the clindamycin, and there is a study on tetracycline, and the results are more or less similar to topical clindamycin. That's why nowadays we really recommend the combination of oral clindamycin with the oral rifampicin. And this is what we are doing in our routine daily practice for patients with at least Hartley 2 stage of hidradenitis suppurativa. So rifampicin 600 milligram per day combined with clindamycin, again 600 milligram per day, is a treatment of choice. And there are nowadays quite a few studies demonstrating that there is an improvement looking at a different scoring system for hidradenitis suppurativa. But that's important that also the subjective phenomena are decreased, like a pain intensity, and the quality of life, which is heavily diminished in those patients, is increased. However, the long-term antibiotic therapy, I'm talking about at least 10 to 12 weeks of those treatment, can result in some adverse events, and the gastrointestinal symptoms are quite common and then may occur in about 6 to 7% of patients. There are a lot of controversies concerning the retinoids, of course, the oral retinoids. And we are not using at all isotretinoin. Of course, I can agree that some patients can benefit, but this is a huge study based on more than 300 patients. And you can see here that in 77% of those patients on isotretinoin, there was no improvement. And even 7% of the subjects, they reported the worsening. That's why we switched to the different agent, and probably the low success rate of isotretinoin may reflect the differences from acne, particularly lack of increased sebum production in patients suffering from hidradenitis suppurativa. I mentioned that we switched to isotretinoin, and unfortunately there are not so many studies. I'm showing you our study published in the British Journal of Dermatology a few years ago, and that was a case study, serious study based on 17 patients, and we observed that quite a significant number of subjects may really just benefit from acitretin. And that's why in the European guideline we put acitretin as a possible treatment for slightly more advanced stages of hidradenitis suppurativa, and definitely we do not recommend nowadays isotretinoin. This is just the treatment with acitretin and the results after 3 months of the treatment. I think that we have more agents in this group which can be used in hidradenitis suppurativa, and this is a study on alitretinoin, and the results are very promising because the authors suggested that about 80% of patients, they received a clinical significant improvement, and I'm looking forward to see more data on this interesting agent, which is of course registered mainly for the eczema hand eczema, especially of the hyperkeratotic type. Nowadays, we are living in the area of biologics therapy, and of course, we are using them for different patients, for psoriatics, for atopic dermatitis, for patients suffering from pemphigus. There is a place also for the biologic therapy for hidradenitis suppurativa. Recently, we reviewed the topic of biologics in HS, and you can see here that there are several agents that can be used, and definitely the adalimumab and infliximab are probably the best. And these are the TNF alpha inhibitors, and they were found to be effective in patients with hidradenitis suppurativa. And I'd like just to underline that the adalimumab still remains the only FDA and also EMA approved biologic drug for hidradenitis suppurativa. I have a personal opinion on adalimumab and biologics in hidradenitis suppurativa. They are effective. And that was clearly demonstrated in adalimumab a registration study. There were two studies, Pioneer 1 and Pioneer 2, and you can see that there are some differences because in Pioneer 2 study, the oral antibiotics were allowed for the patients. That's why the results are slightly better. However, they are effective if we have just inflammation enhanced, if we have a damage to the skin, if we have fissures, if we have just scarring process enhanced. Definitely we cannot escape from surgery, but the biologics can help us to prepare the patient, and also they can minimize the surgical procedure. It's important to notice that the biologics can improve the quality of life of the patients. And nowadays, we have not only the short-term data, but we have a long-term data. That means 3 years observations with adalimumab. And you can see that the obtained results can be maintained if you keep your patient on adalimumab for 3 years, and definitely you can see the clinical improvement. We recently also just documented that there is an increased interleukin-17 serum concentration in patients with HS, and there is a correlation with the clinical staging of the disease. And based on those observations, based on the studies in the tissues, the interleukin-17 drugs are currently investigated in hidradenitis suppurativa, and there are few companies working on this topic. And here I am presenting you the patients which we finally controlled with secukinumab, and you can see here that there was a long-term history of this patient, and we tried several different treatment modalities, including the topicals, including the oral antibiotics, including also the acitretin for 6 months, and immunosuppressive agents. And we managed to control it with secukinumab, and you can see here on this slide and different scorings which were performed. That means we scored the pain, we scored the quality of life, and we used the different scoring systems to assess the intensity of hidradenitis suppurativa. So definitely there is a place for the biologics in this disease, and the improvement, the clinical improvement, can be achieved. However, in some cases, you definitely need to consider the surgery, and it's quite important to have a plan in the management, the long-term plan. So I personally do recommend to start with anti-inflammatory treatment, and then, if it's necessary, to perform the surgery. This is the list of the clinical trials which are ongoing with anti-IL-17 agents, and I do hope that in the nearest future we may have some agents approved for hidradenitis suppurativa, and that will be not only the adalimumab, which is the only approved agent. I would like also to comment on the surgery. I already mentioned at the beginning of the talk that the incision of the abscesses, evacuation of the pus, the drainage can be used. However, the management of each individual lesion is mainly done with the deroofing. And I like the deroofing procedure because it's simple. It's an office-based procedure. You do not need just to keep the patient in a hospital, and it's very, very helpful. However, the incision can be tried, and the simple deroofing is really like laying open techniques is recommended. You can also excise the individual lesion. However, the excision of the lesion can result in the recurrence, and sometimes the recurrences rates are very high, even 60 or 70% in some studies. So depending on the treatment possibility, I will really not recommend the excision. I will go for the deroofing if it's needed. You may use the CO2 laser, and you may use electrosurgery for some patients. But anyway, the idea is more or less the same, just to eliminate the individual lesion. You can do that easily with a simple excision. It's very important to think about the wide excisions. Wide excisions are important for the patients with the advanced disease, and definitely that must be performed by the experienced surgeon or dermatologist or dermatosurgeon, I will call. We're doing these surgeries in our department, and we really just have patients from all over the country coming just to us for those procedures, so you need to have the experienced staff for it. I'd like just to summarize my talk saying that fortunately there is a huge improvement in the management of hidradenitis suppurativa. There is a hope for the new agents, especially the biologics. However, we should really just think of the combination of the treatment with the anti-inflammatory agents and finally the surgery to help the patients in the best way we can. There was a study combining the adalimumab with the surgical procedures. Hopefully it will be published soon, and I think that this is a current future, very close future on the management of our patients suffering from this debilitating disease as hidradenitis suppurativa is. I'd like just to thank my co-workers who contributed also to the data I presented to you today, and I again thank you very, very much for your very kind invitation and attention during this session. Thank you very much.
Very thanks. We are full of gratitude to Professor Jacek, who joined us from all the way from Wrocław, Poland. I would like to invite, before the next talk, I would like to invite Dr. Shyam Verma to tell us more about Professor Jacek and also felicitate him.
Rohit Patra.
Yes, Dr. Shyam. Sir, Dr. Shyam, you're on. Please unmute yourself.
Can you hear me now?
Yes, please go ahead.
Okay. Thank you, Professor Jacek Zapitovsky. First of all, I apologize on behalf of the entire team for this little goof up on the chairman's inability to pronounce your name and the place that you come from. Probably it would have been the same if you had come to India and had to pronounce his name. It's just a cultural thing.
Definitely.
Well, it was a very enjoyable talk, and sorry, I got cut off in the middle. So let me just, for the benefit of the audience, Professor Jacek Zapitovsky is a full professor and chair at the Department of Dermatology, Venereology and Allergology at the famous Wrocław Medical University in Poland. This is, by the way, a very famous couple of 100 years old university, which was known previously as the German University of Breslau, if I'm not mistaken. And his department has seen people like Jadason, people like Albert Neisser in the department. So he's heading that department, and he's currently the president of the European Society for Dermatology and Psychiatry, and is also, importantly, a member of the executive committee of the European Academy of Dermatology and Venereology, the EADV, and he is our incoming president introduced him. He's also he's running for the president of EADV upcoming election of the EADV. Now, Jacek, this is for information for you, just a few seconds more. This is called Guru Purnima. today is called Guru Purnima. It's a day where teachers and gurus are felicitated out of respect. Now, though you are,
Yes, sir, you are audible.
Am I audible?
Yes, sir, please go ahead.
No, because I got cut off in the middle.
Yes, we can hear you.
Okay. Anyway, so I think I am having some connectivity issues. So let's move ahead with the program. Thank you, Yachek, for joining us. You were supposed to be here as the plenary speaker or you were supposed to deliver the keynote address. It's sad that you had to give it sitting at home, but we'll hopefully see you next time. Bye-bye.
Thank you very much. I will come with my just whole heart to India again. Thank you very much, and have a good meeting. Yeah, thank you. Bye.
Thank you, Dr. Actually, sorry, I mispronounced your name, and I'm very sorry about that. Thank you very much for the talk. So now we will move on to, is Dr. Gangwani available?
Sir, he has some problem. You please go ahead.
Okay. So let's go ahead with the next one. We know that management of atopy is just to wait and wait and wait. We have Dr. Sriram Guturu practicing in Dubai the last 20 years. He's got a basic interest in inflammatory diseases, immune-mediated inflammatory. Yeah? Yeah, go ahead. I'll stop. What is it, Shah?
Yeah, his name is Dr. Sri Kumar Gotru.
No, but they have given me a Sriram Gutru here in my this one. I'm very sorry, sir.
Okay.
I'm extremely sorry. The Sri Kumar Gutru, sorry for that. I request you to go ahead with your talk on how long should we wait in the management of atopic dermatitis. Thank you.
Am I audible?
Yes, sir.
Yes.
Yeah, so I'll start sharing my screen now. Okay. Okay. Good afternoon, everybody. I have been enjoying the sessions so far. I have been very intense and very, very, very learning. To be frank, it has been fantastic. So let me start by thanking Dr. Shyam Verma and the organizing committee for having given me an opportunity to speak. I hope I am audible. Now, why are we here? And why we and why me? See, it's simple. We all signed up to become physicians and dermatologists because we have a deep interest in improving the quality of life of fellow human beings. That is the very purpose, the core, why we are in this field. And as dermatologists, we know that the skin diseases have a huge impact in the QALYs and DALYs, that is the disability adjusted life years and the quality adjusted life years of our patients. And even among dermatological conditions, atopic dermatitis is a horrendous condition which robs the lifetime of a person. Just imagine the daily itching, the sleeplessness, the depression, the anxiety, the lack of happiness, the inability to interact normally, difficulty in learning, difficulty in working. The myriad implications of atopic dermatitis are some things which rob our entire lifetime. So without wasting much time, let me go on. Of course, I did introduce myself, and I know that you are all a group of fellow dermatologists who are very much interested in this topic. My disclosures are, of course, I am a member of the advisory committee and a speaker for many of the biologic companies, especially in the Middle East, Sanofi, Novartis, AbbVie, Eli Lilly, Galderma, and Leo Pharma. Of course, this particular presentation is solely mine, and it has no sponsorship for Sanofi. Let me start my story.
Sir, is there an issue?
Yeah, looks like, I don't know. Let me see. Okay, my video playing, I don't know why. In the trial run, it was running very well. So okay. All right. My story today is about a 27-year-old lady who presented to me with extreme itching and had spent her entire lifetime scratching and was extremely depressed. She had been my patient right from childhood and had reached a stage. Hello?
Dr. Srikumar, you can just close your presentation and open it again. I think it will work.
Is it? Okay.
All right. Meanwhile, Dr. Sri Kumar is trying to find a way to connect his presentation again to the screen. I move on to the next quiz that we have. Next question we have for the audience, and it is related to the previous talk, which was covered by Professor Yachek so wonderfully on hidradenitis suppurativa. Most of the terms that was used by him were there in the presentation. In the quiz, most of the terms that are used in the quiz were there in his presentation. So again, just to reiterate for those who joined us a little late, how to answer: fill up this response column first with your name, city, and then with your correct answer. It may be a one-word answer, it may be a multiple choice, like in this case, an alphabet, and then press the submit button. So this is the question: which of the following is not used to measure severity of hidradenitis suppurativa? So you have 15 seconds. Sartorius score, HSPGA score, HISCR, and Hurley stages. Okay. So time is up. The correct answer is HISCR, which is hidradenitis suppurativa clinical response. It is not a severity index. It is a measure of clinical responses in hidradenitis suppurativa. It is defined as relative to the baseline if there are more than 50% reduction in total number of inflammatory nodules, no increase in abscess count, and no increase in draining fistula count. In most of the modern studies, this is the parameter that is mostly used. So, the fastest and the correct answer was given by, let me just check, now panel. Yes, so the fastest and the correct answer was given by, oh, so many, oh God. Okay, so we have, yes, it's Dr. Tejansu Dalal from Ahmedabad. Dr. Tejansu Dalal from Ahmedabad, congratulations. Very soon, someone from Lupin will connect with you and deliver your special gift at your clinic. Thank you.
Thank you, Sumit. Thank you. Today we are having with us Mr. Sibal, because as you all know that we are having this DAS E webinar courtesy Lupin, and when it comes to Lupin, they are one of the upcoming firms as far as dermatology is concerned. We have been having them for various other medical fields, but when it comes to Lupin in dermatology, they are gearing up, and we have Mr. Rajiv Sibal with us. Mr. Sibal, we have been meeting you in various posts and various pharma companies in dermatology, and this time round, you are taking the leadership to a new height with coming out with Lupin and helping us in educational endeavors of ours. So we would like to hear from you what Lupin has been doing for dermatology in particular. Over to you, Mr. Sibal.
Thanks, Dr. Batra. Thanks for such a nice introduction. So first of all, good afternoon to all the respected dermatologists. I hope you and your loved ones are safe and taking necessary precautions to fight COVID-19. Today, the world is experiencing an unprecedented crisis, and we at Lupin salute your selfless effort and commitment in fighting this pandemic and protecting the society. Despite the nation experiencing lockdown, every Lupinite has ensured consistent continuity shoulder to shoulder with COVID-19 warriors who are fighting against all the odds. To ensure doctors have necessary safety gear and work in safe environment, Lupin continues to extend all the support to you and the entire medical fraternity in the fight against COVID-19. Lupin also has been at the forefront of fostering scientific outlook and advancing academic awareness, and so we are proud to associate with the 7th DAS E Summit, one of the most awaited conference for the dermatologist community in India. It's my pleasure to be part of the summit, which is also graced by the presence of eminent leading dermatologists, Dr. Batra, who is the organizing secretary, Dr. R.P. Gupta, organizing president, Dr. Shyam Verma and Dr. Archana Singhal, scientific chairpersons. This is the first E-Summit of DAS and has been very successful. Let me share some numbers with you. In the morning when this program had started, we had presence of 1,500 dermatologists, and as of now, we have 3,000 dermatologists who are logged in. So you can understand the advantage of technology, that how far you can reach and how it can benefit more and more.
The next slide, can you do it?
Pardon?
Please go ahead, sir.
Lupin's pursuit for excellence in the field of medicine.
Okay, thank you, Dr. Sibyl. I guess that we are having a lot of technical troubles, and it usually occurs when the data connection is not good at various places. I guess now we have Dr. Sri Kumar Gotru from Dubai with us. He has sorted out the problem. Dr. Sri Kumar, you are ready with your presentation?
I think I'm ready. My video and audio did not play because on the trial run day it was very, very smooth.
No problem.
Somehow today,
Please go ahead. Please go ahead.
I'll try. Just a minute.
Sure.
I'm not able to get this one.
You can continue with your presentation.
Yeah.
Even if the video is not working.
Okay. I'm actually trying to get the presentation. I'm not able to meet. I do not know what is happening. Shreya, I need a little help, ma. Can you?
Okay, Mr. Gotru. If still you need some more time, we can have you at the end of the day then, after our two panels.
That's fine, sir.
Okay. So,
as far as this symposium is concerned.
Yes. Finally, we have Mr. Rajiv Sibyl with us. Yes.
I hope I was audible.
Yes. There was some technical glitch, but thank you. We were able to hear you loud and clear. And thank you again, courtesy Lupin. We are having this eDAS Summit and hope to have you in our future endeavors, educational endeavors also. Thank you for joining us today, Mr. Sibyl.
Thank you, all the organizing secretaries, president of DAS, and thank you, Dr. Batra.
Yeah, thank you. Over to you, Dr. Bedkuru. I guess we have to call this a session and we move on to the next one. Dr. Bedkuru. Okay. Yes.
So now I invite for our next session Dr. Suresh Talwar, Post National IADVL President and Senior Consultant Dermatologist from Lucknow, along with
I am in.
Dr. Suzanne Pulimod, Professor and Head of Department of Dermatology, CMC, Vellore, to chair the session on urticaria panel discussion and to introduce our moderators and panelists for the same.
All my photos going to appear? Video to
Please, yes, Dr. Talwar sir, we can hear you. Please go ahead.
Unmute to किया हुआ है?
Yes, sir, we can hear you. Dr. Talwar, yes, please go ahead.
आपने उधर से था stop by. Hello.
Dr. Talwar sir, please go ahead.
Can you hear me?
Yes,
sir.
Loud and clear.
Can you see my photograph? No.
Yes, sir. Please go ahead.
Can you see my photograph?
Yes, sir. Please go ahead.
Loading. Welcome to this urticaria session. I, along with my co-chairperson, Dr. Susan, welcome you all. There are many gaps in the treatment of urticaria, and I'm sure this discussion on urticaria is going to clear many, especially the new drug like Bilastine which have come. And I'll invite the moderator for the session, Dr. Rishi Prashar. There are galaxy of speakers for this panel discussion. Over to Dr. Rishi Prashar. And I'll request Dr. Susan to sum it up at the end.
I won't be there at the end.
So then I'll be there. In case any queries are there, you'll be there to handle. I'll be there in the end. Till end.
Over to the panelists and to the moderator. Please take on the session.
Dr. Rishi Prashar to join.
Hello, can you hear me?
Yes, sir.
Yes, yes.
The video is not switching on. Somebody has switched off my video. Right. Just a moment. Can you see me now? Right.
Yes, sir.
Yeah, yeah.
Yes, yes.
I'm going to be sharing my screen and
Hello.
I think, can you see my screen now?
No.
We can see your photograph.
No. Can you see now? Yeah. Can you see it now?
Yes. Yes, sir.
Yes.
Yeah, I would, I thank all of you for joining in today morning for the 7th DAS E-Summit. And it is indeed my pleasure. I think my screen is gone, at least for me. At least for me, it is not visible. Damn be the blue jeans. I can only see Dr. Kaushik Lahiri. Can you see me now or no?
We can
Hello?
see you,
No.
but your screen is
My screen
We
is
can
gone.
see you.
Your screen is not visible. You are visible, Rishi.
Is it okay now?
Yeah,
Yeah.
now it's
yeah.
fine.
Yeah, my thanks to Dr. Rohit Batra, Dr. Shyam Verma, the elegant lady, Dr. Singhal, Dr. R.P. Gupta, my friend, philosopher and guide, and today being the Guru Purnima, my teacher, Dr. C.R. Srinivas, whom I hold in high esteem, and he's been much more than a friend, philosopher and guide to me. Today I'll be talking about tips and tricks, and are you all ready, my panelists? Right, so it's going to be a jovial session. I'll be quick here. No long composition-like questions. I'll start with a nice poem. For urticaria, you are the butter to my bread and the bread to my life. So I think all the cases which are not fungal in my clinic are urticaria cases, and if these two diseases disappear, I'll be a pauper. The job of a moderator is pretty easy. He's like a conductor in an orchestra, wave the stick until the music stops, and then turn around and bow down like this, and the job is over. I am a forgetful person, so I'm putting everything in the front. We bid for Delhi 2023. I'm looking forward to your support in advance. Thank you in advance. So coming on to the main meat of the topic, the classification. Do you, as panelists, feel that every 2 years of change in the classification is helping the confusion, or is it adding to the confusion? Anyone? I can't see my panelist here. Right.
No, we are here, all of us. Don't worry.
You are here, but
Yes, Rishi, we are all here.
yeah, you are all there. Right. So,
Yeah. So don't worry.
you please tell me that are you happy with the classification of urticaria, or were you happy with the previous one? Because we'll start with the basics. Without basics, we don't know how to tips
Rishi,
and tricks. Yes.
Rishi, if I'm allowed to break the ice, actually, like you, I'm an even more forgetful person, and I don't even remember all the intricacy, what exactly different so-called task forces are telling us, types and subtypes, all these things. But what we learned, that is the acute urticaria and chronic urticaria. So that is absolutely goes fine with me, and definitely I go with that. So I don't think it really helped me in my daily practice.
Right. Anybody else with any other way? Do you feel we are confusing cholinergic urticaria with heat urticaria, or whatever we call as delayed pressure urticaria is something else, then we move ahead.
See, Rishi, all these subtypes of urticaria are very important to delineate. When the patient comes to us experts, it's our duty to, categorize the patient into a subtype of urticaria. And many a times there are 2 or 3 factors coexisting. Like the patient may be having chronic spontaneous urticaria, patient may also be having a dermographism or cholinergic urticaria, or the combination of 2 physical urticarias. So we have to make a diagnosis based on whatever comes to us. Once we have made the diagnosis, then only we can proceed. I can't listen.
Unmute yourself. Rishi, unmute yourself.
If I may,
Unmute, please.
Rishi, you'll have to unmute yourself.
Now,
You mean Dr. Susain?
Rishi, unmute.
I have done everything possible.
Yes, now it's okay.
You are unmuted now. We can listen.
Unmuted now. Now coming on very quickly, sorry about this thing. When you take the history of a patient of urticaria, how is your history taking different for a child? How is it different for an adult, for a pregnant lactating mother or an elderly, somebody having fits or something else? Means any other points, tips and tricks in history taking very quickly, because we don't have time for 50 minutes to take history.
Can I
like
come
your
on that?
doctors
Can I come on
abroad.
that, Rishi?
Yes.
Can I
yes.
come on that?
Hello,
Dr.
sir.
Srinivas here.
Yeah, please.
Yeah. See, basically, these persons with urticaria, they are bursting to tell what they want to tell. So you must let them have a go. Let them tell everything, and from them you catch whatever points that you require. If you are trying to put them and channelize them and be asking them, tell me what is the duration.
Unmute.
Unmute, sir. This is the problem.
See, probably in
Okay.
elderly, I would
think
be more
so.
interested in drug history.
Yes.
Dr.
Go on.
Srinivas,
Any
please
other
unmute
panelist?
yourself.
Any other
Yeah.
panelist?
So
Any other
let's start
panelist?
from the pediatric age group. See, Dr. Srinivas rightly said that we should
the-
let our
was I
patient
clear?
speak first. Once
Right.
our patient starts speaking, we get to have the clues. That's number one. Number two, you mentioned about the different age groups. So in the pediatric age group, we will be
Dr.
more
Mukesh, we'll
concerned.
have to be very, very quick in this. I'll have to be
Yeah,
a
I'm going very
rapid
fast.
fire kind of a
Don't worry,
person.
I'm going very fast. So when it's a pediatric age group, we should be asking about the chances of infection, especially the respiratory tract infections. We have to look at the drug intake and we have to look at the food. These are the three common causes in the children. When it comes to adults, then the scenario changes. Generally, the food is not the cause, so infections may still be there, and we ask accordingly. In the elderly, as Dinesh mentioned, we have to ask about the drug intake, we have to ask about the comorbidities, and these are the basics.
Do you think the role of diet is there, or is it the pseudo allergens that we are bothered about in urticaria?
Yeah, so in adults, it is more of pseudo allergens.
Yeah.
In pediatric age group, it is diet as well as pseudo allergens.
Right.
if I may, sir, quickly.
Yeah, please, quickly.
Yeah. The main thing when we see a patient with urticaria is actually like our maze puzzle. In other words, from the center of the maze going out is always difficult, whereas the reverse is easy. So to keep it short, you have interleukins, you have histamine, and you have bradykinin. So our main aim is to look at the patient and decide, are we dealing with a patient systemic illness, and is the interleukin at play? Are we dealing with urticaria and angioedema with itching? Is this histamine at play? Or are we dealing with a scenario where there's a pure angioedema without urticaria and pain is an issue, and are we dealing with bradykinin? Once we come in the reverse direction, it becomes easy.
This is very nice, but in the clinic, sir, we have to be very, very quick and ask. I agree with you on this. In history taking, I always ask about the menstrual cycle, the menstrual this thing. In other things, there are certain. How many of you believe that traditional beliefs about urticaria affect the patients? This was a paper from Journal of Pakistan Association. So I was very, very perplexed. Why does the friendly country want to see India, the South India part of it? So this was an interesting article that, people believe certain kinds of diets and other things are, increasing their urticaria or some kind of festival or the season or something else. So do you also face the same problem in whatever geographical area you are in?
Very true.
From
Very true.
south,
I'm from South, so basically I don't see diet being a major role in chronic urticaria. Acute urticaria,
No,
yes.
no, no. I'm talking about the traditional cultural beliefs, the Ramdevs, who have put it in our this thing. How difficult does it? I'm talking about tips and tricks, remember. I'm not going to take a theory class here. The tips and tricks in your practice, does this interfere with does it irritate you when you're taking a history, when the patient comes up with half a dozen of nonsense?
It doesn't irritate,
Rishi,
but you have learned to live
if
with it.
Rishi, other than these, there is another aspect that is not exactly a traditional belief or Ramdev type of thing, but almost similar. The patient of urticaria, this chronic urticaria, will always come with a report of allergy tests. And
Right.
they will tell you, doctor, my previous doctor, and almost always a homeopath or GP, has told me to avoid these 108 food items. So what do you think?
Yeah. So it is not an
I would
allergy. We have to tell them.
It's more easily said than done. They don't accept.
Yeah. There are high levels of depression and anxiety. Do you think depression causes urticaria or urticaria causes depression? Did the egg come first or the hen came first, according to you?
It depends on what you serve first.
No.
No, but generally, yes, anxiety. I've seen quite a good number of exam-going students having increased things during exams in urticaria.
Yeah,
Then there is
rightly
something.
said. So it can be the cause also, it can be the effect also of urticaria. If somebody is having
Right.
bad urticaria during examination days, it is going to worsen actually.
So today is Guru
So it is a
Purnima, so
vice
God,
versa.
During this
we'll
COVID era, we are definitely witnessing an increased like a frequency of urticaria in person who are there homebound or who have lost their job, and those patients
Right.
they are coming to us with increased urticaria during this.
Any one of us, we take a history of, any kind of gastric irritation in our patients. Do we keep it as a part of our questioning, when a patient walks in, or do we ignore this?
Should not
The
be ignored.
Helicobacter pylori factor.
Even otherwise also you find that many of them are under great deal of stress. Stress causes hyperacidity, and hyperacidity again causes more stress. So by looking at them, you can tell they will have a constipated look and one sort of look that will tell you that this person's are under stress. And if you ask them, they will tell you they have hyperacidity. And
So there is a kind of visual analog scale that you have in seeing a patient of urticaria the moment he enters your clinic.
very true.
I agree with you. How many of us we agree with this chart, that inducible urticarias are all under 1 hour, contact urticarias within 2 hours, spontaneous urticaria plus delayed pressure urticaria this is a very simplistic thing, and urticarial vasculitis is more than 24 hours, the wheel lasts. Does it always happen like this?
This is not a right wheel.
Right.
This is not a right wheel because spontaneous urticaria is not just due to histamine. It can be due to other factors which are released from the mast cells, and they are responsible for the late phase reaction. So that urticaria, the spontaneous urticaria, which is again spontaneous, can last much longer and much longer than urticarial vasculitis. So just because something lasts longer, it does not necessarily mean that it is urticarial vasculitis. It can still be because of the late phase reaction due to the substances liberated from mast cells.
The whole idea of my questioning here is to play the devil's advocate. Sometimes I see something very simplistic, almost bordering idiotic. I'm going to put it that this is given in the textbook, and year after year, the improvements in the same wrongness is, propagated, and all the juniors keep on reading. If
Can
a
I make a
patient comes
comment
to,
on this, Rishi?
yeah, very quickly,
Can I make a comment?
because we have to go to the real
it's
meat
very
of the theory. Yeah.
Okay. So, many a times, urticaria lesion lasting more than 24 hours, I used to biopsy. And Dr.
Right.
Asha Kuba will give me a call and discuss with me and tell me, this is urticaria like rash, it is not vasculitis, so you call it urticaria.
Right. So what do you do then?
Very true.
Okay. Once he's come to urticarial vasculitis, you either take a biopsy, either get an ANA done, or you do a rheumatoid factor. If the biopsy is showing neutrophils, what will you use, Dr. Mukesh?
Yeah. So if the biopsy is showing neutrophils, the preferred line of treatment besides antihistamines becomes dapsone, sulfasalazine. Sulfasalazine I prefer because dapsone I am not comfortable because of the many legal issues with dapsone, so I use sulfasalazine.
But we use so much of dapsone in leprosy.
Even colchicine also I use.
Colchicine.
Right. What about ANA? If ANA is positive?
Then I go for
If ANA is positive and there are other symptoms pertaining to the connective tissue disorder, I will investigate. Otherwise, I'll tell the patient that you have to be under watch. We will repeat it after 3 months or 6 months.
I think we should go in for HCQS, as Dr. Srinivas said, the favorite drug of Donald Trump, which we sent. And lastly, the rheumatoid factor, if it is positive, what do we do for arterial vasculitis? Let us get it over with as we are going along. Nothing.
Rheumatoid factor poses a very tough problem because if you are going to use NSAIDs, they are going to further aggravate the urticaria. So again, you should go in for HCQS or maybe methotrexate and see if we can minimize the use of the NSAIDs because NSAIDs you well know can aggravate the urticaria.
Right. So this is a misdiagnosis chart. Some of the conditions that we think is urticaria, we are very frustrated. It doesn't work. We should keep this kind of a chart or maybe a bigger chart than this, that bullous pemphigoid, sweet syndrome, fixed drug eruption, subcutaneous LE should all be considered, when we are dealing with it. We'll move forward. If the patient comes and asks you, how long is my urticaria going to last? What is your answer? Very quickly, each one of the panelists. 3 seconds.
I think probably around 6 weeks. Chronic, I say that it could be weeks, months, or years.
We are not asking you the definition. You are a senior doctor.
I'm just telling you, I tell them what I tell them. I'm not defining it. I just tell them if it's chronic, I tell them it's weeks, months, years, or even decades.
Right. Anybody else?
See, if we go into the historical aspect of these studies which
No, we can't. Our discussion will get over. The time will run over. Please, I have 3 seconds. What do you tell your patient?
Urticaria may last for months or years together.
I normally equate them and compare them. It is like a diabetes. It is going to persist with you and you need to take a treatment. The only difference is it is not having any the side effect as the diabetes is having.
But I have a difference of opinion with you straight away.
Rishi, my observation is that most urticaria subside.
One by one. One by one.
You give the name of the person, that person can talk. You can
I can't see anybody, sir.
You know that
who is Pereira Rathi? Is Sanjay Rathi. Right. His name is written as Pereira
Sanjay Rathi.
Yeah, he's my son only. I'm using his laptop.
Okay, humor is done. Thank you very much. Your son is great. Okay, so when we are dealing with the time frame, Dr. Srinivas was saying, so that your patient doesn't run away. Talking about the diabetes kind of a situation, your patient might run away, How do you give him, a bad news coated, sugar coated? Anybody? These are the tips and tricks.
Shall I try?
Yes. Try your tricks.
Like you tell them that almost every person improves. You have seen some improving in a period of 6 months, in some 1 year, some 2-3 years. And if there are 100 patients, the average will come to about 2 years. It is not for 2 years for you. It may go off earlier. It may go off this thing.
In the last few years, last at least a decade, we have a cabal. Cabal is a group of people who decide how to run things. They always say a gentle reminder. They're pushing us towards, like a funneling us towards certain drugs. And like 10 commandments, they call us again after 2 years and they say 2 more commandments were there. Why don't you reduce this? So do you agree with the word guidelines, or is it a simple oversimplification of a complex disease like urticaria? Comment, Dr. Srinivas.
Yeah, basically, I think we should not have these guidelines. These guidelines are misguiding us. Each person of urticaria is an interesting patient, should be treated on the merits of what history we can find out, understand, and treat by this. Following this guideline that you are going to give one antihistamine, not going to work, go on increasing, go on doing it. That means you are not going to think that there could be other options, there could be other drugs which can be used in place of antihistamines. All the other drugs which have been mentioned here during our discussion, hydroxychloroquine, dapsone, Sazo, all those things are out. Or montelukast,
So-
H2, all those are out by this.
let us cause a fight amongst
can I say a word or
ourselves.
two?
Yeah.
Rishi,
Let
can
us
I say
cause
a
a
word or two?
fight in this. How many of you agree with guidelines and how many of you don't agree with guidelines?
I disagree.
You want me to answer?
Everyone should answer one by one.
Okay. So
Can I
let's
just
not
have a
talk of
word?
these guidelines. There are other guidelines also. There are American guidelines. There are Indian guidelines. They are more
I will talk
inclusive.
about that. I will talk about that. Don't worry.
This is a very basic guideline. I don't think we can follow it like that.
This is the IACI guideline, the Gallen
We
guideline,
don't
the
follow
WOW
the IACI guideline. We follow
All
the
right,
Indian guideline.
all right. Now come.
Rishi, there is
Yes.
absolutely no rule of thumb. I think we should all apply our clinical knowledge and
But,
experience regarding this. And what you have mentioned there, I think cyclosporin these days in this COVID era, it is little dicey to use.
I will talk about that also. When you go to the IACI guidelines, the Gallen guidelines, these are the two kinds of cards which are given, the basic cards. No odometer, nothing about 21st century. You're sitting in a hall of 2,000 people and they ask you to raise your hand. Red means no, green means yes. I have no idea how the votes are counted. And then the word is very, very, bombastic, world guidelines. And we see that certain drugs seem to be favored, like omalizumab and fexofenadine. Though in Europe you had Bilastine, which was available from 2009. 3 of these IACI guidelines that I attended, they never mentioned the word Bilastine in that. And certain, drugs are told, that you will not use any first generation antihistamines because it is totally taboo and some kind of, there is a unwritten rule. If you say first generation, that means you're out of the modern era. These are the guidelines you can see for children. I'm just showing you deliberately. Even in children, they have written, if you see the second line, up to 4 times the standard dose, and underneath it is written with a star off label. Means what kind of parents are we that we will go off label with our own children? Do you agree with this updosing concept? Even in adults as well as in juniors.
Even if you've seen the second line, if the child is more than 12 years, they don't even updose. They want to go straight away to omalizumab. That's very unfair. Actually.
Do we smell a rat? Anybody? Dr. Srinivas,
There is an army
Dr.
of rats,
Dinesh?
not rats.
If I may
Yes.
say
my
a few
name.
words of mine. These guidelines are useful and definitely not to be totally discarded, but at the same time, I agree with the panelists that they should not be followed in toto.
Are they
main
not
thing is-
pushing us towards a direction? And this is where
I
the
agree,
tips
sir,
and
I
tricks of.
agree.
Right.
I agree.
Right.
Rishi,
Yes.
Yes, the
my
insurance
titles are
company.
C. R. Srinivas. C is for cat, R is for rat.
So,
I
it is
I
the
always
insurance
smell it.
which
Right.
demand many of these criteria in
Right.
our part of the world. Unless you demonstrate, for example, the first line failure, second line failure,
Your
you
part of the
are
world
not
is something
eligible
different. With all due apologies, you don't want
Yeah.
your hands and feet to be cut, right? Right.
Can I make a small comment here again?
Right. Yes. Very
Very
quickly,
few
Dr.
doctors
Mukesh,
are
we
using
are.
omalizumab, but all the doctors are treating urticaria.
Right.
It's
Very
treatable.
true.
Right.
It's a perfect
That's
statement.
true. Perfect statement. These are the American guidelines. Luckily, they have still kept the first generation antihistamines. They are slightly more flexible than the cabal in Europe.
As of
And
now, Trump is more sensible than Europeans.
yeah, it seems like that. And urticaria guidelines, these are the controversies. This is a lovely, thing to read on net, if anybody does. So guidelines, I believe, are making the doctors dumb. What is your view about this? Because we are talking about tips and tricks. We are not talking theory here. So guidelines are there to make us dumb, and we are talking about tips and tricks. If you never go, you never will. So now starting with the common antihistamine drugs. How many of you believe that there is a role of first generation antihistamines? And in what? Dinesh Kumar.
I generally
Quickly.
I do believe there is a role, and I use it quite a like in cases where I find worrying or the stress to be a factor. So I do use it. Yeah, I don't rush first generation.
Do you feel guilty that you are using it? Do you get a fit or some kind of, hyperhidrosis in your
I'm never
palms?
guilty using a first generation. Absolutely no.
Do you feel that you are no longer an intellectual or you've not joined the pseudo-intellectuals by
Absolutely no, sir. The only thing is I just take
Right.
appropriate history like glaucoma and wheezing, asthma and things like that. And if I'm
Right.
fine, prostate
Anybody,
disease, I just go ahead with it.
anybody else uses first generation?
Yeah. We all use.
Hydroxyzin definitely I
None of us
use,
use.
and in case of
Dr. Mukesh?
patient, it
Yeah,
Hydroxyzin.
hydroxyzin is used sometimes, and at the same time, injection Avil is your treatment in acute urticaria.
But you were instrumental in bringing the Indian guidelines to the fore, and you have not really mentioned anything. Means mentioning the first generation means you are no longer intelligent, isn't
You
it?
don't have the slide on the Indian guidelines. In the Indian guidelines,
I will, it is not there. Right. So now coming on to the second generation, I feel that levocetirizine has been edged out by fexofenadine, and fexofenadine has been overtly active all these years in telling us three lies. One is that it does not induce sleep. Two is that you can drive the car without having any kind of a problem. And three is that, compared to any other antihistamine, it is not at all sedative. Now I'll tell you a few things about this. On doing a PET scan, it was found that only bilastine showed all activity there. The comparison of fexofenadine 60 milligrams versus other antihistamines were done, whereas the selling of this drug is at 120 and 180, and they tell to updose it even up to 4 times. And the last thing is, compared to bilastine, even the research done, Dr. Mukesh had shown me a slide yesterday that, the fexofenadine. Dr. Mukesh, can you tell me that Grattan slide so that people know?
That study, that is the sleep cycle study, where the
Yes.
REM sleep was affected, was comparison of fexofenadine 60 milligram with chlorpheniramine 6 milligram. The regular dose of chlorpheniramine maleate is 4 milligram, but there it was 6 milligram.
Can I interject, Mukesh?
Sure.
Yeah. Actually, this sleep thing and sedation, Rishi, is absolutely subjective. I myself, if I take cetirizine 2 or 3 times daily, I don't feel sleepy. But you remember that estimazole or even loratadine, I used to feel sleepy. And there are many patients who, it depends on the person concerned. So definitely fexofenadine is not at all non-sedative. We all know that.
So, but for
again,
20 long years, the only thing that the innovator molecule said was they downplayed everything else. And the funny part is that chlorpheniramine is also sold by the same company.
That is how they sell. Like when loratadine was first time came into picture, you remember the fighter pilots photograph were there all over the international journal.
No. I'm talking about at least they gave up on this. These people still continue. Anyway, we'll move to the next slide. How many of you combine H1 and H2 antihistamines? Very quickly, yes or no?
In two situations.
Yes.
In two situations. One is dermographism. The other is when the patient has GI symptoms also.
Right. Dr. Srinivas,
So to reduce the flare
Even otherwise, on my own body and on the patient, we have conducted studies. We found that the urticarial wheel suppression following histamine prick test is much more when it is combined.
It seems that H2 helps in the wheel suppression. The redness goes down with H2, not exactly the urticaria. The flare goes down. So in today's day and age, when we do not have the Zyntec available anymore, it causes cancer according to experts. What is the one that you substitute it with?
Famotidine we can go for.
Famotidine 40 milligram twice a day also can be given in some people for the wheel testing. Now coming on to
Can I
the...
interrupt 1 minute?
Yes, please.
I'll just take 10 seconds. See,
Don't
we're
say
talking about
interrupt.
this one.
Yes.
Okay. Basically, capillary reaction is guided by H1, and arterial and venular dilatation is controlled by H2.
So that is controlled by the H2. So it has a role. Now the counseling part. What are the tips and tricks in counseling the patient? Very quickly. I put the slide. I'll remove it very quickly. What do you tell the patient the moment he comes to your clinic? Then I'm starting with the main thing.
First thing you tell them is relax.
Yeah.
You are going to get well. It is going to go away. Please tell me. Then you can start. So you just cool them down because they, as I told you, they are highly excited. They want to burst. They think that they are very unique in getting this. Then you can tell them that even I had it or my wife had it over the counseling. All those sort of things help.
Right. So we have to tell them it is not a contagious disease, sign of cancer, and it will resolve if it is not systemic, and it is not an allergic problem. So all these costly allergy tests which are done, and telling somebody, as Dr. Kaushik said, 108 kinds of foodstuffs are banned, we should avoid this.
So
now we are going like, yeah.
No, in counseling, I also say that these drugs, even if taken on a long term, they are harmless because many people discontinue drugs because they think when you take months or years together, it can lead to problems. So I say
This is an important point. Yes, this is an important point. Now coming on to seeing certain tests.
I do tell my patients.
Right.
Okay, I do tell my patients that the medicine is actually preventive and not something curative, and that they are supposed to take the medicine even when they don't have the problem. That's a very important point because many people take the tablet as a reactive issue to their urticarial wheel, and I think the tablet.
I will tell that in Tamil how I tell. We can understand that. வந்தாலும் வராட்டாலும் வராம இருக்கிறதுக்காக செல்போன்ல அலாரம் வச்சு அந்த டைம்ல மருந்து எடுத்துக்கங்க.
Can I have a translation in Bengali?
I think I understood.
No. Let us move forward. Let us move.
So put an alarm in your clock. Whenever the alarm sounds, you take the medicine.
Exactly. Right. Irrespective of whether you get or not. Vandalum varatam.
So there was a new talk.
Very easy to understand, sir.
Yeah. There was
really,
a new
Mukesh,
thing.
I didn't know that you understand.
Mukesh will understand. Don't worry. He is brilliant. That is why he is our panelist here. So all of you are brilliant. Otherwise, the moderator won't have had such great panelists otherwise. TRP, D-dimers, fibrinogen and ESR are predictive markers for the responses to urticaria. How many of you get a D-dimer test done?
It is being done now by the COVID.
Right. Otherwise, we are not getting it done. But the good part about this is that if there is elevation in these parameters, this shows more active disease, low quality of index of life, lack of response to the standard doses of levocetirizine. And
there's one more thing. When the D-dimer level is high, then perhaps we are looking at the other pathways and anticoagulant therapies.
Right. Now I'm coming to the meat of the talk very quickly. What do you use for if there is, I'm going to take COVID and children later on, pregnancy, very quickly. Any one of you can take. Dr. Kaushik.
Chlorpheniramine maleate is actually given, but
no. Do you use chlorpheniramine now for pregnancy?
What?
For pregnancy, if there is urticaria during pregnancy, do you use chlorpheniramine?
No, I don't use.
I'm asking you. I'm asking you the treatment very quickly.
Actually, I give some topicals and I tell the patient not to take.
If the patient is over 3 months, patient is over 3 months pregnant.
Cleared by
anybody else would like to take a shot at it?
Levocetirizine, I think it's a category B drug.
Cetirizine.
Category B drug, levocetirizine.
And what about topically, you can give them this Caladryl, topical antihistamine.
Yeah, another thing which I believe
I used to avoid Caladryl because it has the topical antihistaminic in it. So why not liquid only Calaminol or
plain calamine? Yeah, agreed.
Because antihistamine action also works. That also we had done test on our own cells.
So sometimes that
with Caladryl we get the suppression much better. Yes. And people complain about the sensitization. The gynecologists have been using it left, right, and center for the 50 years. And to date, I am able to see one single case of allergy to Caladryl.
So these are the kind of remember most of them are category B or C. That's it.
This is what I want out of this whole panel discussion, a little bit of exothermic reaction, some heat generated, showing your thumb to
Galadriel
the
cools down.
guidelines.
Galadriel also has
And
got slight soothing action.
yeah, all right. Do you believe there is any role of thyroxine in a hypothyroid patient? If they come to you, will his urticaria become better? Yes,
It
no.
only suggests an autoimmune possibility of
I am asking yes, no. No. The answer to this is no. For elderly, do you take any care, any kind of preferred antihistamines? One or two names? Juniors are watching. I
Bilastine,
want this list.
fexofenadine.
Right.
Bilastine, fexofenadine.
Cardiac patients?
Same.
Same. Hepatic?
Cetirizine is safe.
Same.
Cetirizine
Right.
is safe.
Even
In
cetirizine
renal,
is safe.
in renal patients?
Same.
Again, bilastine and fexofenadine.
Bilastine has come out.
Actually, we are
Okay, if
using
a patient
Bilastine
has-
much more than we are. Yeah, these days we are
If-
using Bilastine much
if a-
more than we are using Cetirizine.
If a patient has epilepsy, what do you use?
We would generally try to avoid first generation.
I think there also
Yeah, you
bilastine
go for a
would be
non-sedative antihistamine, less sedative.
non-sedative. Yes.
Or we say less
What-
sedative. Let us not say non-sedative. And also some are
less
very, very
sedative.
sedative. Some of these non-sedative are very sedative to some people. So it is
Yeah.
better to tell them as less sedative.
So we know that NSAIDs cause a lot of urticaria, at least. What painkillers to use if a patient has arthritis or any other thing? What painkillers?
Paracetamol, dextromethorphan, and maybe neucoxia.
I think tramadol would do very well in these cases.
The tramadol is the
Fluperatin.
same, actually, I was talking.
Fluperatin is
It's
another
not-
thing
it's
that does
not
not work by
ever-
the same pathway. It does not work by the COX route, but it's got less analgesic and more of antipyretic action. But fluperatin is another thing which you can consider.
Right. Now coming on to the COVID situation, anybody with anosmia having some amount of urticarial rashes nowadays, we should think about COVID. Would we like to use immunosuppressants in these cases? These drugs which I have written, cyclosporin, azoran, mycophenolate, methotrexate, corticosteroids. Dr. Kaushik?
Actually, boss, that's what I was telling, that until and unless the patient is in a moribund condition, for COVID, cyclosporin is not to be given, and it is a drug when the patient is admitted and in ICU. But for us to treat a patient with COVID and urticaria, it is not a medicine to be used. But I'll go ahead with the conventional therapy and not go for any immunomodulators. The recent one is the legalizumab. That is also.
I'll be coming to that. I'll be coming to the this thing. So only maybe omalizumab we are safe. Other drugs we should be very, very careful.
What
And,
about steroids? Would you use steroids?
No, sir. Steroids are also, the dosage of steroid has to be very, very low in this.
Low dose.
All these
Up to 20
medicines.
milligram of prednisolone can be used.
Yeah. Now Blue Jeans has again frozen up. I don't know.
No, we can
They
see
had
it.
been praising. No. I know
But
it
it has
is
been
frozen
going on
up.
very well up till now.
I know this is the evil eye cast on my talk. I've been trying to push buttons, and again, can anybody pause?
Sir, please go forward. Press the forward button. Forward. Not up, down, forward.
Forward ही दबाया यार.
The way forward.
Beautiful blue jeans.
Remind me of a David
पंजाबी
Bowie
में
song.
गाली देके फिर बोलो चलेगा.
Sir, you know I don't do all this.
You don't.
Some of the other panelists can do it, I don't. All right, coming on to this. Do we treat our children like mini adults? The management guidelines of chronic urticaria you saw, and this ridiculous piece of chart that you saw, that above 12 years only omalizumab, and you can standard updose it up to 4 times. Below, very quickly they have written it is off label. How do you manage children?
Children respond to antihistamines well. They tolerate antihistamines well.
Why?
So, see, their pharmacokinetic of antihistamines is faster. So, it gets eliminated faster. And
They even tolerate sedative antihistamines quite well.
Yes.
Cetirizine
One
they
thing I'll
tolerate.
be looking in children is history of atopy also. I would
So-
be wary of taking atopy.
Right. Atopy is one more factor. Do we
You can
believe
add
that these,
Montelukast to that.
right, these kind of guidelines which are there, slowly and steadily, they are pushing us to a point where we can use only a limited number of drugs, which we can count on our pinky finger. So, if we use first generation, then we are, guilty of experimenting on the child, and there'll be talk about the cognitive impairment, the school performance going down, the concentration going down, the NREM, REM sleep going down. So do we agree to this kind of a chart is what I want. I want some controversy here, frankly.
These are more of a robotic treatment, Like we don't need a doctor for this. A person
Right.
comes, a person with a typewriter will be there. They will ask the question. You're getting still.
Exactly.
Double it. 4 times, not over. Now go for omalizumab. Tak. You don't need a doctor for this. These
So
are more of a robotic
Alexa would be a better doctor than us in this. So right.
And
Now
one more
these
thing, if
are
you're not controlling it well,
Excuse
you
me,
might
can
they
I
write
just,
very rampantly.
there
Yes,
are
who's
5
that?
more
I think
minutes. Excuse
Mine
me,
for
5
a
more
very
minutes to wrap up
No,
this session.
these were the medicines we are going about CIndU, chronic inducible urticaria. What do you use for dermographic urticaria? Quickly. I don't want the audience to say you did not cover anything.
H1 and H2.
H1 and H2.
Right.
Yeah.
What about the cold urticaria?
Same works.
Bilastine is preferred because it has some IL-6
Bilastine and
activity.
desloratadine. Delayed pressure
Yes.
urticaria.
Sulfasalazine.
do you combine these two together?
Which one?
Do you combine bilastine and desloratadine together in a same patient?
No. Either one of them. Either one of them.
That's what.
Delayed pressure urticaria, it seems cetirizine or levocetirizine are the only one which work.
Sulfasalazine.
Yes.
Sulfasalazine also works. Thank you, Mukesh. And in aquagenic urticaria.
Excuse me, can I just interrupt?
Yes.
We have just 5 more minutes. Can we wrap up the session?
Madam, we heard this twice. Thank you, madam.
Yeah, I got a
Right.
message.
So, aquagenic urticaria. Is there any role of bleaching powder in bath in aquagenic urticaria?
We try all that, it doesn't work.
It doesn't work. Right. Anything you use for stress-induced, Dr. Srinivas?
Stress induced, as I told you, we go for H2 blockers in some of them,
Right.
and then we go for this thing, Spectrum. What is that?
I go for doxepin.
No,
Doxepin.
Doxepin has got both
I give a lot
H1
of
and H2 action, and it has got
Right.
far better, more of H1 action than other antihistamines.
Doxepin has been thrown out, Doxepin cream also used to come, that also has been removed.
Doxepin has
And,
not been thrown out, it is
Cream
available.
doesn't work, but the tablets do
wonder, and
work.
it's still there in Goodman and Business.
So these are certain bad news, that alcohol can cause segmental urticaria and even urticaria and masturbation, sexual intercourse causing inducible urticaria. I was just wondering which kind of inducible urticaria could
The pressure.
sexual
Pressure
intercourse.
I think
urticaria.
it's a pressure.
Delayed pressure or frictional?
No, I have
Right.
seen pressure.
More of a
pressure and
dermographism.
frictional urticaria.
See,
Yes,
one of the very
fictitious.
common thing about urticaria people miss is the scalp pruritus, itching
Right.
on the head. Urticaria
Right.
is a very common cause for itching of the head. And people,
Now-
that person will go on scratching and he'll go on getting dermographism and he will getting more itching.
Now we come to the easiest Viva question. If I was a student nowadays and somebody asked me what do you use for urticaria, I would only use one word, omalizumab. This is how much it has been pushed by everyone. Omalizumab for cholinergic urticaria, omalizumab for refractory urticaria, heat urticaria, for delayed pressure urticaria, omalizumab. Where are we? Again it is stuck. Rohit, help me.
Rohit
I think you wind up now. 5 minutes
Same,
go
sir.
here, Rishi.
Just please
Ho
press
gaya?
forward. Yeah, ho gaya, sir.
Omalizumab for pregnant women, omalizumab. Do we agree that omalizumab is the be all end all? See this headline, that normal antihistamines may no longer be required. Do you agree with this kind of a thing?
I think it's wishful thinking in the near future.
Wishful thinking. So we feel that it is a tail wagging the dog rather than dog wagging the tail. Means it's the pharma which is helping them. Right. Half my time has gone only in pushing this
Pushing
blue
out.
jeans forward. No, blue jeans. It's the bane of everyone.
Your jeans were slipping down and you're trying to pull it up.
I don't see it that way. One vote less for you as a secretary. Rohit, it is not,
Yes, sir.
no, it is not moving at all.
Sir,
He has
you
unmuted everybody. You can hear many voices.
Is somebody?
How many votes for Rohit Batra?
Sir, please,
Rohit will get all.
All the votes.
sir,
Rohit,
just hope you are not
problem
on
is-
the screen.
yeah.
You have to be on the blue
yeah,
jeans. Yes.
yeah, please. So I'm moving forward. The newer treatments are Legalizumab for children. It is written half a dozen unpronounceable names, Dupilumab, and they would like us to believe all this. These are the. How many of us use IVIG? Very quickly. Yes or no?
No.
No. Rituximab?
No.
No. Right.
No.
All the TNF alphas. How about autoimmune urticaria? Do we agree the word autoimmune urticaria is there? Is it so much as 40%? Do we agree with the statement of all urticaria?
Yeah,
I agree.
maybe.
Yes.
Maybe.
Only
30
thing
to
is,
40%
the
is
criteria
okay,
for
yeah.
calling as autoimmune urticaria is more than 24 hours and this thing. As I told right at the beginning that many of these are late phase reactions. So
Right.
while we are doing that, we should consider regular type of urticaria because of late phase reaction, which can last well before over 24 hours, and then autoimmune urticaria. So we should give phase for that. The 24-hour criteria is not right.
Right.
Because even
right.
in late phase reaction, you are going to get histopathology of vasculitis.
Sir, very quickly, if we are using oral corticosteroids, how long and how should we taper it?
Shall I take it?
Yes.
Yeah.
Anybody?
You start off with a moderate type of dose, preferably one with an anti-inflammatory action.
How many days?
Start off with daily, then go to alternate days, then go to twice a week. Along with that, maintain antihistamine.
Do you agree that we have to use it for maximum of 5 to 7 days and then suddenly not taper it down if it is 10 to 20 milligram a day and just finish it abruptly? Dr. Girdhar.
No,
Yeah. As a short course, I will be giving it for 5 to 7 days and stop it straight away.
Straight away. All right. How many of you use
Within 7 days, you
cyclosporin?
don't need to taper it.
How many of you use cyclosporin in children, and what is the practical difficulty that you have? Children.
I do use.
Why is it safe in children?
Yeah, because their intestine is smaller. So gut being smaller, it gets excreted very fast. So it's much
and-
safer to use in pediatric age group.
Can
for
we have
atopy or for urticaria? In
Even in
children,
urticaria?
in urticaria you use, huh?
Right. How many of us are using phototherapy in urticaria?
I
It has
do
been
have the facility,
recommended,
but I don't
studies
use
have
it.
been done, but we hardly use it. I have used it in case of solar urticaria.
What about mycophenolate mofetil, sir?
No, I have not used.
No.
Not used. Warfarin?
No.
No.
So these are all names, this is a huge list of armamentaria, and we see that we are not using tacrolimus. Anybody oral?
No. Thought
Not
many
used.
times, but never used it.
Yeah,
I
same.
use
I also
methotrexate
thought many
sometimes.
times because when cyclosporin is working, tacrolimus also should work. It is also going to stop the calcineurin inhibitors. It also acts through the T cells the same way. If that is working, this should work. It has less
It
side
should
effects. Every reason we should use, but we have not. Probably nobody is promoting it to us.
Not promoting it to us is a problem.
Nephrologist
How many of us use histoglobulin injections?
No.
No.
It used to be a very popular, a poor man's biologic, reduces the
25
amount
years
of.
back, I have seen.
Did you
25
use,
years
Dr.
back, I have
Kaushik?
seen. No, I don't.
Right. So it is no longer used.
Okay,
And
can I just interrupt again as chairperson?
The time is over.
Yes,
Given
ma'am.
the responsibility of sticking to time.
Yeah.
So
Yes,
just
ma'am.
one more minute and can we
Right.
wrap it up?
So this is
Thank you very
urticaria
much
with
for the-
oral mini pulse therapy, cyclosporin, dapsone, tacrolimus, colchicine, UVB light, mycophenolate, hydroxychloroquine, histoglobulin. I've already asked. Anyone using Azoran, azathioprine?
No.
No.
Autologous
I
serum
don't
therapy?
use it, but I know some people who use it and they find it useful. But the
Right.
studies don't.
Autologous serum therapy?
No.
Who are
Anybody
you mentioned?
Anybody joining the Chinese in the bloodletting therapy as if corona wasn't bad enough? Bloodletting therapy is there. Is there any use of, it has been found that vitamin D is low in chronic urticaria. Is there any use of vitamin D treatment?
It's low in everything.
Low in everything. That's what.
I wanted this. When you fill up
Do
the
the
visa
test
form
and
for
impress the
USA.
patient.
No. When you fill up the visa form for USA, the question asks is, are you a terrorist? Have you ever planted a bomb against America? This is how they ask. We should have a no as an answer from the expert. Right. And what about obese people
बहुत पढ़ाई किया
who
है
are there? What about the obese people, Do you ask them to become thin and you will have a less metabolic syndrome and urticaria will improve? Can it happen
I
like
don't
that?
always make them depressed. Obese people, they are always happy and funny. So I don't make them always depressed unless it is absolutely indicated.
But metabolic syndrome is associated with urticaria. You won't do anything as a good doctor, Dr. Kaushik, or?
Yeah, definitely I do. But what I'm telling, I don't make them always depressed. So
Right.
when nothing
Maybe we
was
can find metformin as an indication for urticaria.
Very
With
small
this,
point
they
on
will become
obesity.
thin,
yes.
it will not disappear.
Dr. Mukesh, you have the last.
Yeah. See, desflurane gets deposited in the fat tissues, so it's less effective in obese people.
Right. This is Martin Church. He taught us this. Right. Thank you very much. With this, I come to the end. Thank you, madam, for giving us a chance. And I know we went here or there, but this was a long topic. And I wanted my experts to say things which they believe from the heart. All these viva questions that were there, bloodletting therapy and all these theoretical things, I'm very happy they were honest enough to agree that most of us, we don't use it. And these are only meant for failing the students, whenever you're angry with them. With this, I come to an end. And I again call you all to Delhi and
Did we pass
we
or
all
fail?
enjoy and party. Thank you very much.
Did we pass or fail?
You passed with flying colors. I probably failed as a moderator.
No, sir. ये बहुत पढ़ाई
Right.
करके आए आप. Okay. Bye. Thank you so much.
Bye.
Thank you for giving us
Thank
the
you.
chance.
Thank you very
Rishi,
much.
sir, and thank you everybody.
Thank you so much.
Thank you,
Thank you.
everyone.
Bye-bye.
Thank you.
Bye.
Yeah.
Bye.
Thank you.
Panelists and Dr. Susan and Dr. Suresh Tarwal sir for chairing this session. Before moving on to the next session, very quickly I would like to display the next question on the screen. And for asking the next question, we have a very the gentleman of dermatology, Dr. Neeraj Pandey sir, who's our senior quiz master. He is the current president of IADVL UP UK State Branch. He is a senior consultant dermatologist at Derma Clinic Skin Laser and Hair Research Center, Clinic and Research Center, and he's also the secretary of SARC AAD family. Over to you, sir.
Thank you. Thanks for the introduction, Sumit. Can I get to the question, please? Yeah, thank you. So the question is, and what is the price of the question, Dr. Rohit and Dr. Sumit?
A pulse oximeter.
Nothing. Okay. So the question is, which of the following is not used to demonstrate, elicit cholinergic urticaria? Is it option A, exercise for 15 to 20 minutes? Is it B, hot water bath? Is it C, intradermal injection of botulinum toxin A? Or is it D, intradermal injection of nicotinic acid? आपका समय शुरू होता है अब. Your time starts now. The clock is ticking.
Okay. So,
Okay.
could you give the answer, sir?
Yeah, we are ready to display the answer, and the answer is Can the answer be on the screen?
दोबारा पोस्ट किया उनको ढूंढ के दोनों
So the answer is intradermal injection of botulinum toxin A. And in fact, there has been reports by which intradermal injection of botulinum toxin A has been used or accidentally treated cholinergic urticaria by inhibiting the release of acetylcholine. And we again have had multiple answers, over 150 answers in 10 seconds. And the first one to correctly answer is Dr. Shekhar Nima from Pune, our friend from Pune, who's also on the faculty for the next panel. Congratulations, Dr. Shekhar Nima, sir. You will be contacted by the Lupin guys to deliver you a pulse oximeter. Thank you. Thank you, Dr. Neeraj, sir. We'll again call you for the last question of the day. Thank you.
Thank you very much.
We now invite Dr. Ramesh Bhatt, past IADVL National President and Head of Department, Father Muller Medical College, Mangalore, along with Dr. Gurvinder Banga, Senior Consultant from Gurugram, to chair our concluding panel discussion on psoriasis as they introduce the moderators and the panelists.
I have just received a call from Dr. Bhatt that he is not well, so he won't be joining us. Dr. Banga, sir, please continue.
Thank you. And first of all, it's a really nice venture and a nice setup. Having a good feel of a conference all the way since morning. My thanks to Dr. Gupta, Dr. Shyam Verma, Dr. Archana Singhal, and Dr. Rohit Batra for giving me this opportunity. Next discussion is use of biologicals in psoriasis and psoriatic arthritis. For this, moderator is Dr. Muralidhar Rajagopalan. He is Senior Consultant Dermatologist at Apollo Hospitals, Chennai. And with him, as panelist, will be joining Dr. Brajesh Nair, Department of Dermatology, Military Hospital, Jaipur. Dr. Bela Shah, Professor and HOD, Department of Dermatology, BJ Medical College, Ahmedabad. Then Dr. Sunil Dogra, Professor, Department of Dermatology at PGIM, Chandigarh. Dr. Lieutenant Colonel Shekhar Nima, Department of Dermatology at AFMC, Pune. And finally, Dr. Neeraj Jain, he is Senior Consultant and Vice Chairman, Rheumatology and Clinical Immunology at Sir Gangaram Hospital, New Delhi. So, I'll be handing over to Dr. Muralidhar Rajagopalan, sir. Please continue.
Please unmute Dr. Murli. Please unmute. Dr. Murli, please unmute.
There is a button on top which you need to press.
It's on the top.
Dr. Murli, you have a mic. Just unmute it. Find a sign of a mic.
Yeah, can you hear me now?
Yes.
Yeah. Okay. Yeah. Thank you. Thank you very much, Dr. Gurvinder. And I'm just. Yeah, I hope you can see the slides.
Yes.
Yes, I can. Okay. I'm not able to see the gallery. I don't know. I've done something wrong, but that doesn't matter. I know who my panelists are. First of all, I am not going to thank Das for involving me, because Das is family and you don't thank your family for getting involved. So, Dr. Shyam, Dr. Archana, Dr. Rohit, it's so good to be with all of you again. And good afternoon. And the toughest topic has been kept for the last. So the way we are going to handle this, I have a good panel I'll just introduce the panel to you in a moment. So the way we're going to introduce this topic is going to be so the way we are going to do this is we have questions, and the questions are very well and easily directed towards particular people, and I will be calling out now. Panelists, please remember that I am not able to see you on my screen. I'm not able to see the questions either. I guess somebody will be sending me the questions. Anyway, this is yeah, great. I can see all my panelists. So I welcome first Dr. Neeraj Jain, because he's a rheumatologist and it's always been a pleasure to work with him.
Thank you.
Every DAS that I have met with, Dr. Neeraj and me have been on the same panel. It's been great.
Yeah.
I welcome
you so much.
Dr. Bela Shah from Ahmedabad. I welcome Brijesh, who's worked with me on psoriasis for many years.
Thank you.
I welcome Dr. Sunil Dogra, who's from PGI, and we've also worked together. And Dr. Shekhar Nima, whom I know right from the time he was doing his MD at AFMC, is one of the most promising young dermatologists. Dr. Shekhar, please unmute your mic.
Sir, thank you, sir. Thank you, sir.
Okay, great. So now the schematic is going to be that we talk about biologics in psoriasis and psoriatic arthritis. This can take, I have conducted master classes which have taken a whole day and some which have taken 3 days. So we're going to compress the key learning points into 1.5 hours, and we'll try to keep it crisp, and therefore I will call the required panelists to ask the question so that we don't have a problem. Second, please keep your answers to around 45 seconds, because that's how I've timed the questions. Some are less than 15 to 20 seconds, and at the end of it, all I want is that the audience should get a good take-home message. So that's what I want. So now we will not go into definitions. What is a biologic? Who knows? I mean, we all know about all this. We will not go into very basic knowledge. We will not go into any molecular stuff. Please be crisp. And I thank once again my panelists for helping us all understand. Now, I want to ask, anybody can just answer this. Is there anyone in my panel who feels biologics are a new drug?
I don't think so. I don't think so. They have been here for some time now.
Yeah. Now, it will be interesting to know that etanercept, which is one of the first biologics which came in psoriasis, is celebrating its 20th anniversary next week. So I think at least all the millennials amongst the dermatologists in India should know everything, if not more, about biologics than the panel sitting here, and me, of course. Because 20 years of biologic is not an old drug, it's not a new drug, it's a very old medication. Now, what percentage, I would like to ask all the panelists one by one, just tell the percentage. What percentage of your patients have used biologics? I'll start with Brijesh because he's on top of the panel there.
Exact statistics I will not be able to give, but roughly 5% to 10%.
Yeah, rough is enough. Rough is enough. Dr. Bela?
1 out of 10.
Dr.
2 to 5%.
2 to 5. Dr. Shekhar?
It's a 5% would be a rough.
Right. Dr. Sunil Dogra? I'm not able to see Dr. Sunil. Okay, Dr. Sunil is not here, I think. Okay, Dr. Neeraj, the rheumatology. Dr. Neeraj, rheumatology?
Yeah, actually, I don't see psoriasis as such, but if you ask psoriatic arthritis, it is definitely around between 2 to 5%, not more than that. Psoriatic arthritis.
Psoriatic, I'm sorry, I should have clarified psoriatic arthritis. So you see, if you look at it, I mean, we have some of the top dermatologists and one of the top rheumatologists of the country. The penetration of usage of biologics in psoriasis and psoriatic arthritis is somewhere around 3 to 5% in India today. So it's not like, we already said it's not a new drug, it's an old drug. In spite of that, the penetration or usage in our patients is pretty low. Now, compared to conventional drugs, do you think that biologics are a better option? I will go to Dr. Shekhar now.
Absolutely, sir. No doubt, sir. With less organ toxicity, they are the drugs to go.
Okay. What is now, Dr. Bela? What is the only problem you face in using biologics in India?
So apart from the cost, and people are not really ready to accept that these are the drugs which can be utilized even sitting in a private hospital or a private clinic, because whatever patients,
please.
There is a lot of mind block in the. I think the dermatologist, by and large, they are refractory to accept that biologics are really good drugs and they can be really utilized. That's what I feel.
I'm so glad you brought this out. There is a refractory mentality in the dermatologists. And in fact, it is the dermatologists who need a lot more education, and which is why 20 years down the line, every conference, there is a session on biologics. So, but cost is a major factor.
It is there.
Now, I will go to Dr. Brijesh because he's from the armed forces. Dr. Brijesh, do you feel cost is a factor for you?
Fortunately for us, cost is not as much as a factor, but I wouldn't say that the budgets are limitless as far as biologics is concerned. We have to still be prudent in the existing armed forces scenario to select your right patient. And one point which I wanted to make, one difficulty which I face is patients interrupt therapy in between, even with biologicals, even when they are free. The problem
I'm coming to that. I'm coming
back month after month can be an issue for some patients.
So now you see there are two issues over here. One is everybody said that it's around 3 to 5%. Second, we find that while Dr. Bela Shah and all feel that using biologics, there is a refractoriness in the dermatologist's mind, and cost seems to be an issue. Brijesh, on the other hand, doesn't have a problem regarding cost, but still feels that he's not using more biologics than probably he could, because he needs to choose his patients well. So I will go to Dr. Shekhar. What is it that makes you choose a conventional over a biologic?
Sorry. So we choose conventional because from the cost effectiveness point of view, does not make sense to start biologic as a first line agent, sir. Even in our scenario, it does not really make sense. So we choose conventional, and when patient fails conventional, then only we shift to biologics, sir. So that the cost still remains a major concern, sir. Even in insurance setups, sir.
Okay, fine. Excellent. So we have these issues clear. Whenever Dr. Sunil Dogra joins us, somebody please let me know. Now, I'm going to, this all case-based questions, and these are all cases for which I have seen. A patient has psoriasis with a body surface area involvement of 15%, with lesions on the face and body, no joint involvement. What is going to be your approach? Dr. Bela?
I will go for IL-17 because I have seen PASI 90 and PASI 100 at week 6 and week 4 also with IL-17 inhibitors. So I'll prefer to use this drug because it is very much visible on the face. So I'll offer the option of this therapy to my patient as a first line drug because it is on the visible area, and if it is a female, then I will
Okay,
really
so now
concentrate
this
on
is a
that.
question. Now this is a question which I want to ask Dr. Brijesh and Dr. Shekhar and Dr. Sunil Dogra, who is, if he has joined, because I can't see him there. Do you agree that if the BSA body surface area is 15% with lesions on the face and body, you will go straight away as first line therapy for an IL-17. Now, from now onwards, we are going to assume that cost is not a inhibiting factor for you. All right?
Yeah,
Because
for
otherwise
the-
cost is going to stymie us completely.
I'll still start this patient on methotrexate because methotrexate does work reasonably fast enough. And although the bad guidelines does permit that PSA more than 10%, it goes into the severe category. But if I don't get a fast enough response and the patient's quality of life is less, and particularly on the face, if I do not get a fast enough response, I will not interrupt the methotrexate. I will add on an IL-17 inhibitor on top. Achieve control, and then maybe at a later date and time withdraw the IL-17.
So we will
and carry on
talk.
methotrexate.
So, Dr. Brijesh, I will give you time to talk about this mix and match approach that you have. Okay? Once we get the initial case studies through. Now, this is for Dr. Shekhar Nima or Dr. Sunil Dogra, whoever is there. An adult young doctor has psoriasis with a BSA of 3% on the face only. What will be your approach?
Sir, I will use topical steroids first, and topical steroids with.
There is some interruption going.
Steroid. Sir, I'll start with topical steroids, sir. Face responds, usually face responds very well to topical steroids, sir, and tacrolimus. So I will go for topical steroid. If patient does not respond to topical steroid, then maybe switch to biologics, sir. But first would be topical steroid, yes.
Topical steroid. Would you, Dr. Brijesh and Dr. Bela, simple question to both of you, yes or no? Young adult doctor, psoriasis only on the face, will you use a topical steroid, yes or no?
We will do. I will use a mid-potent steroid, maybe fluticasone and mometasone initially, and step down to later topical disonide.
Okay, Dr.
But
Bela?
I will also be inclined to start a systemic therapy along with this because this young doctor has to have a human interface on a day-to-day basis. So I would like to have a quicker response. So along with topicals, I will start systemics, and later maybe I will interrupt the system.
Dr. Bela?
I'll prefer to use moisturizers and vitamin D3 analogs than using topical steroids on face.
Oh, okay, none of you want to use calcineurin inhibitor?
Yeah, tacrolimus or pimecrolimus, yes.
Definitely. When we start off with steroids, but in the end, we maintain with tacrolimus or Elidel.
Okay, now Dr. Brijesh, since you're on, question directly to you is that this is a high impact site. As a doctor, a person has psoriasis on the face, it's going to be difficult to practice.
Fine.
So in a high impact site, if the person, now when we say this is a doctor, and I've already told you that we are not bothered about the cost, are you still going to offer the patient a topical steroid?
I will start with the systemic therapy along with the topical steroids. That's what I stated. And a conventional.
What systemic therapy? What systemic therapy?
Methotrexate or acitretin should be good options. And later, if the response is not adequate or quick enough, definitely biologicals will step in.
So, is there anybody who believes that high impact site on the face in a young person, a biologic should not be the first of biologic should not be the first option? This is entirely the whole discussion today is going to be practice oriented.
Sir, I mean,
I will still try to give a run for the conventionals before switching on over to biologicals. Of course, the concept of the mild, moderate, severe thing is out. It is basically that concept has been pretty much debunked by the experts. I think last year when they actually classified the patients into something more
Yeah, this
practical.
was published
Yeah.
in JAD, and
JAD.
we don't talk about mild, moderate, severe anymore. And this paper was published by the IPC. I was part of that. I agree with you, but my simple point is that when the cost is not an issue and it is on the face of, it's a high impact site. This is what I'm trying to emphasize upon.
One more thing we can factor in here is that he's a doctor, he's a professional. So you can lay out all the options in front of him and make him choose. Does he want to go in for a biological? I think that will be a more practical thing in terms
So
in
this
case of
is
a professional.
now I'm not selling biologics, but do you agree that there's a little shift in your position now?
Absolutely. After the
Okay,
JAD
great.
guidelines, we are
Because
justified.
this is all we need to know, that when a patient comes to us, we need to lay out the options for them, especially if it's a high impact site, and allow them to decide. There may be a lot of factors which they have, which they are concerned about, to help them to decide.
Yeah. Even if a person is from a poor socioeconomic strata, I know private practitioners who lay out all the options and they are somehow able to cough up the economic impact, cough up the money because they want a clear skin. So laying it out and shared decision making is absolutely the number one thing in psoriasis right now.
Sir, I have a point here. Sir, here in these cases, for pemphigus, it works really well, sir. Even from people from poor socioeconomic strata, rituximab, it's very easy choice, sir. But biologic for psoriasis is not an easy choice, so because you know that you are going to tell them that you need to continue the drug, sir.
Yeah, definitely.
Correct. Okay, now see, we have, if all of us look at what we have been doing so far, we've kind of changed the guidelines, because we've changed the way we are actually going to give the therapy. So I will just ask Dr. Shekhar to be very brief. Do you follow any guidelines for starting a patient on a biologic? Please think of your responses that all of you agreed upon earlier. And then
Not
we'll go to
really,
the
sir.
root
Not
causes.
really, sir. We don't stick to any biologics, sir, because any guideline per se, like NPF guideline, because our scenario is totally different. I mean, the cost and availability is a major issue, and plus the availability of the biologic itself. We just have 3 biologics available and 2 biosimilars. That's it, sir.
Right.
And when we read these guidelines, they have the biologic, the list is endless, sir. So we have just either TNF alpha or interleukin 17. We hardly have any choice, sir, here.
Right. So, would I be wrong, Dr. Bela? Would I be wrong if I say that the guidelines were made by the NICE and the NHS and the American Academy, keeping into effect the fact that over here the state provides the drug, and for achieving cost effectiveness, the guidelines came in?
Our patients have to buy by themselves, and these drugs are
No,
not.
my question is, the question is that do you think that I am correct in saying that guidelines that are there by the NHS and NICE and AAD are more because of the cost effectiveness, because the state is buying the drug for the patients? It's not the same in India.
Yes, sir.
Right. So which means we need to evolve our own guidelines and decide on a case-to-case basis. Yeah, Dr. Brijesh, please.
Yeah. In USA, it is mainly the insurance,
Right.
and in Europe, it is mostly the government-run services. And even if you have to get, if you have a biosimilar, I mean, like Denmark, I believe, has chosen a biosimilar over a biological as a default option because of the cost factor. And once they implement that into the guidelines, You have to
Right.
use the biosimilar. You will never be, the institution just cannot start a original. So
You're
yes, insurance,
100% right. I agree with you. So these are policy decisions in order to help the government save money.
absolutely.
But when it comes to dealing with the patient, we'll have to take a decision. And as Brijesh pointed out earlier, we have to lay out all the options and help the patient to make a decision. The most difficult thing is the decision to act. The rest is merely tenacity. The fears are paper tigers. You can do anything you decide to do. Amelia Earhart. Now, who's Amelia Earhart?
She is the famous pilot, the one
Exactly. She
who I
was the
think
first
disappeared. I guess.
the first lone woman pilot who did the transatlantic solo flight.
And I think she vanished
She
in the
died.
thin air.
She died at the end of it. But this is what she wrote. Okay? So this is important. You have to decide to act. So now I'll go to each one of you. Just one word only, please. What is your preferred biologic and why? First, Dr. Bela. I think she already mentioned IL-17 secukinumab.
Yeah, yeah.
Okay. Dr. Brijesh.
In psoriasis, it is an IL-17 inhibitor, secukinumab being the default option. In psoriatic arthritis, I know I'm impinging on the rheumatologist territory. It will be a TNF blocker first choice.
Yes.
Okay, Dr. Shekhar.
Secukinumab, sir, for psoriasis.
Okay, now look, we are not selling secukinumab, but could either Brijesh or Shekhar tell me in half a minute why secukinumab?
Sir, it is firstly it is subcutaneous.
Three or four major.
Ease of usage, sir. Ease of usage first, sir. It is subcutaneous. Secondly, faster. It's a very fast response, sir. I mean, you can a primary failure is almost never seen, so you can assure the patient that at 4 weeks he will achieve PASI 50, 4 to 5 weeks, and by 8 to 10 weeks he may clear or he will achieve reasonably good response, sir. And if you see the maintenance therapy, sir, it is just once a week. I think like adalimumab is once in a fortnight. This is once a month. And then the cost factor, it is much better than infliximab. If you compare the cost wise, it is much better than infliximab itself.
Okay, thank you. Dr. Neeraj, I'm sorry you had to be silent for this much time. In your case, when a patient comes to you with psoriatic arthritis, which would be your preferred biologic and why? Because I think in rheumatology, the decision making is slightly different. Correct me if I'm wrong.
Yeah, actually, to be very frank, till date, till 2019, we were following the 2015 EULAR recommendation for psoriatic arthritis. I will just stick to psoriatic arthritis, not infringe on psoriasis actually.
Yes.
And recently, late 2019, we had these EULAR recommendations. So we had some overarching principles and recommendations. So it is till 2019, it was that you have to give anti-TNF first. If anti-TNF fails, you switch to another anti-TNF, and then you think of IL-17 inhibitor. But now they have changed. Now you have an option of either using anti-TNF or using an IL-17 inhibitor, but there is a clear-cut indication if patient has psoriatic arthritis with skin manifestation which is still predominant, then you prefer secukinumab rather than anti-TNF. If it is arthritis which is more dominant, then you can take a call between anti-TNF or secukinumab. In personal experience, the anti-TNF was doing so good till date, but since the availability of secukinumab, we have been using a lot of secukinumab, and there are two clear indications in psoriatic arthritis. If patient has enthesitis, there is no role of conventional DMARDs. You have to use biologic. If patient has axial involvement of psoriatic arthritis, you have to use a biologic, clear cut. Because we have 4 spectrum in psoriatic arthritis. You have polyarthritis, you have oligoarthritis, you have enthesitis, and axial arthritis. Polyarthritis, oligoarthritis, you start with conventional DMARD, then you switch to biologic, right? But if you have enthesitis and axial, then you have to take a call straight away with biologics. So this is all biologic DMARD.
I'm so grateful you brought in these issues. One simple question I'll ask you is that depending on what type of arthritis is there, whether it is axial or non-axial, will the choice of a biologic change?
Yeah, definitely. If axial arthritis is there, you can you have to use either you can use anti-TNF or IL-17. It is fine. Peripheral
Right.
arthritis, the indication is same. What I meant was that if you have an axial arthritis, you have to use a biologic. There is no role of conventional DMARDs. But if you have a
Exactly. Yes.
peripheral arthritis or an axial, it's the same actually.
Okay, great. That is wonderful input from your side, because I think all of us dermatologists also need to know when to refer to the rheumatologist or when to loop in the rheumatologist and work as a team.
Yeah, and I can add here in 2019 now
Yeah.
they have added that if a biologic DMARD failed, then you can straight away switch to a targeted synthetic DMARD, which is JAK inhibitor, tofacitinib.
Right.
So I
Right.
think maybe you can go
Unfortunately,
later.
no, I'm not going to go into tofacitinib because I realize that, there are already 34 slides, so it will be difficult to go into that. Now, I would just like Dr. Brijesh to tell me very briefly, when you said that you will lay out everything to the patient,
Dr. Murli, Dr.
what
Sunil
will you
Dogra has
tell the
also
patient?
joined. Dr. Murli,
Excellent.
Dr. Dogra has also joined.
Yes. Dr. Sunil, welcome. Unfortunately, we started the meeting already, but we will catch up with you. Okay? Welcome to the group. Dr. Brijesh was telling us that he will lay out all the options to his patient. Now, Dr. Brijesh, how will you counsel the patient when you lay this out? What will you tell the patient?
First
See,
of
all
all,
these
that
questions, all these issues are clearly directed towards our practice.
First of all, psoriasis is not curable and contagious. Second thing,
Right.
this is a disease which is bound to aggravate in the colder climates. I
Right.
tell them that even if I start a biologic, my endeavor will be to bring you back into the conventional therapy and step down at a later date. I'll also
Correct.
tell him that all the investigation profile which is required.
Correct.
Plus, the most
Right.
important thing which I have in my handout, which I explain to them, is the hygiene practices. I mean, COVID
Right.
practices is a good thing. Now it is very easy to convert the patient into the hygiene practices expected of a biological recipient. So
Right.
these are some of the factors which I tell them, and I do not dwell into the secondary loss of response and all that, and make them into a negative frame of mind. These are some of the factors which I discuss with all my patients. It takes around 30 minutes
What about
my first counseling
Dr.
is around 30
Brijesh?
minutes. Yeah.
Dr. Brijesh, do you discuss biologic failure, the need for switching a biologic with your patients on day one?
No, I do
Because
not.
you're going to spend a lot of money.
No, I do not do that because somehow it affects them in a negative fashion.
Right.
And one more thing which I very, very specifically ask them, and of late I'm asking them more, is do you
Yeah.
have any joint pains, a back stiffness, any difficulty
Yeah.
in bending down in the morning, early morning stiffness? I am specific and ask this to even the mildest psoriasis patient. Because the severity of skin
Right.
psoriasis is absolutely no indicator as to the extent of joint involvement. And many people have very, very severe problem and they do not actually reveal it to us till the time they are specifically asked.
So you look for enthesitis?
Yes.
I make them stand towards with the back against the wall and look at the heels and look at the symmetry. Yeah.
Okay, now I'll go to Dr. Sunil Dogra because I want to bring him into the discussion fast. Dr. Sunil, welcome.
Yes, thank you.
Dr. Brijesh has laid down broadly the counseling principles that he will use for patients on biologics. What about vaccinations? Because that was one area which he didn't touch upon. What would your advice be on vaccinations?
Yes, before starting patient on biologics, what we practice here is influenza vaccine. That is what advised by pulmonologist also. And then apart from that, we do screening for viral hepatitis. I think that is covered by, must have been covered by Brijesh. But influenza vaccine, we do advise to patient before we start them on biologics.
Okay, influenza, yes, but what about things like Tdap and pneumovac? Do you give that also? Do you complete the complete adult immunization schedules?
Pneumovac, yes, in elderly patients, but not in all patients we are advising.
What about Tdap?
Not in routine, no, not in practice here.
Okay, so at least influenza vaccine is a must, right?
Yes, yes.
And when we talk about influenza vaccine, do you prefer to give it as a single shot in the lifetime, or would you repeat it every year?
We repeat annually in patients who are
Yeah.
on maintenance biologics.
If they are not on maintenance biologics, would you repeat it?
Yes, more so in patients who are on systemic therapies throughout the year, who are having
Yeah.
comorbidities, there we do give.
Great. Thanks very much for that very specific answer. And so, why psoriasis occurs? How do you choose a biologic? How it works? How long it will work? Which ones are available? The costs, the retention of PASI improvement, expected side effects, short term and long term, share registry data and authentic websites, how to follow up and what to look for during treatment. These are some of the broad things we've covered in both Dr. Brijesh and Dr. Sunil's disposition. Now I'll go to Dr. Bela. Could you please tell us briefly what is your pre-biologic workup? You said you want to prefer secukinumab. Fair enough. You give secukinumab. But before that, how will you work up? Dr. Sunil has spoken about vaccines, so please don't go into that.
Right.
Just tell us the list. Just give us the list. That's enough.
CBC with ESR, X-ray chest, ECG, echo,
Yeah.
Hep B, C, HIV. We do screen, and we also get our quantiferon gold testing done. We prefer to go for the MT, and few patients I subject them to for the quantiferon gold test as well. Most of the
You
time we
prefer to
just
go. You prefer to go for MANTO test.
yeah, and many patients I have ordered even quantiferon gold test, but basically we go for
Okay,
MT.
okay. We are going to hold you on that, right? Give me a
Sure.
minute.
Yeah.
Now,
Can I
as far
add?
as I'm coming to you. 1 second. Is that Dr. Banga? No.
I
Okay,
think
fine.
Brijesh
No,
wants to
myself.
make a point.
Dr.
No.
Brijesh,
I'm coming to you, Brijesh. Brijesh, I'm just coming to you. 1 minute, please. Dr. Bela, you said you will do HBsAg. Will you do HBsAg alone, or will you look for any other hepatitis markers?
Hep C also.
Any other hepatitis markers?
So we don't go for any other markers than Hep B and Hep C. Not for the if the patient is
Okay, doctor. Okay, I leave the question to Dr. Brijesh because obviously there is
um,
something that's been left out here.
I'll, in addition to what Dr. Bela has told, HBsAg and anti-HC, I'll also go for the anti-HBC, IgG and IgM because
All right.
that is an important
Anything
thing which
else?
has to be added. And
Exactly, I agree.
I do MONTU test and IGRA, both of them in every case in which I am planning to initiate a biologic. And if
All
there
right.
is a discordance, that if the MONTU is positive, the IGRA is negative, or the IGRA is positive, MONTU is negative. Even in that case, I'll err towards the thing that this person is carrying latent TB, because we know that 40% of the Indian population does carry latent TB, and I put them on
Okay.
prophylactic ATT. I put them on
Okay.
prophylactic ATT.
Okay, Dr.
And
Sunil.
after 1 month, initiate biologic.
No,
Yes.
we're going to come to tuberculosis. Don't worry. Dr.
Fine.
Sunil, what do you feel about hepatitis B core total antibody? Do you do
Yes,
that?
yes, we are doing
Because
that.
it will not produce antibodies. It won't
Yes,
produce the hepatitis IgM or IgG, but the core total antibody will be present. And once you give the biologic, it is going to get reactivated.
we are doing here in PGI, both in
Yes.
pemphigus patients and psoriasis also.
I'm glad you
Pemphigus were
brought that
to be
out.
given rituximab. Yes,
Yes,
that
I'm
is
glad you brought it out because
yes,
if it is present, we need to pre-treat. It is
yes,
not just tuberculosis we're worried about. We are more worried actually about
core
hepatitis.
yes.
Now, I'll be with you, Dr. Sunil. What is your take on doing a MANTU in a patient of psoriasis who has already been on treatment with the
There are
conventional therapy?
yes. There are two aspects. One is that Mantoux may be false negative in patients who is on immunosuppressive therapy, and secondly, patients who have unstable psoriasis and some form of pustular psoriasis. There
You
we can
cannot
get
do a Mantoux.
we can get false positive Mantoux also. So I also go with Dr. Brajesh and do IGRA and Mantoux in all the patients.
Right.
And but the practical experience is in most of the patients where we end up having IGRA positivity, pulmonologists don't take it too seriously if the chest X-ray is fine.
Right.
And in case there is past history of tuberculosis, then they do advise prophylaxis.
No, the issue here is I mean, I wanted to keep tuberculosis for the end, but let's deal with this right here. The issue is that IGRA only detects latent tuberculosis, and therefore the prophylaxis is given. Pulmonologists don't accept IGRA for diagnosing active tuberculosis.
Yes.
That's right.
But when we are going to start a patient on a biologic, if the IGRA is positive and his chest X-ray is normal, it means there is a latent tuberculosis.
Yes.
Now, what is the type of tuberculosis we see in patients on biologics? Dr. Bela?
It can be disseminated also if you don't really pre-walk up them properly.
It is actually, is it disseminated also, or is it pulmonary primarily and disseminated?
Yeah,
What
pulmonary
is it?
primarily and then disseminated also.
Sir, we
Anyone
also
who
face
has a
the
different... Yeah,
sir, we also
Sridhar?
face the similar. We also face the similar problem. What Dogra sir has said that when the IGRA is positive and we send the patient for pulmonology opinion, they say that the chest is clear, the X-ray is clear, and the HRCT is clear. They don't initiate treatment. But nowadays we have started treatment for LTBI on our own without, and if the chest
No,
X-ray is
there
clear,
are...
HRCT is clear, we have started treatment for LTBI. Sir.
It is better.
Okay. Let me just move this forward. There is no controversy about the fact that IGRA is only for LTBI, and if LTBI is there before you start the biologics, you need to start the prophylaxis. We have to be very clear about this. Okay. So we are not using LTBI. We are not using quantiferon TB or IGRA test in order to diagnose active tuberculosis. I don't see any logic in taking a pulmonologist's opinion on that, because he's going to use that to diagnose active tuberculosis.
Yes, sir. We were doing that initially, sir. Now we have stopped taking opinion of pulmonology.
I think that's best. Too many cooks spoil the broth.
Absolutely.
That's the whole problem.
Yes.
So I just summarized this over here. So I won't go too much into this because I want to move further. I only want to ask everybody over here, anybody can just take it up. One person take it up. Is there any absolute contraindications for giving a biologic, whether it is an IL-17 blocker or a TNF blocker? Because today these are the only two available officially in India.
Hypersensitivity reaction, sir. I mean anaphylaxis or something. Anaphylaxis to infliximab. So that's a big no, sir.
Active tuberculosis.
Number one.
Active infection.
Number two. Then?
Demyelinating diseases.
Yeah, demyelination
for anti-TNFs.
For anti-TNFs.
Active malignancy and history of malignancy over the last previous 5 years.
5 years.
5 years. So the malignancy should have been declared cured within 5 years prior to taking the biologic. This is irrespective of whether it is IL-17 or TNF blocker. So there are some specific for IL-17, some specific for TNF blockers. So my question to Dr. Sunil is, because he's joined in late, we're going to give him a little bit of extra questions, okay? Dr. Sunil, do you see a change, because you're in a very big institution and many of the cases are referred to you? Now, do you see a change in the way psoriasis patients present to you over the last 15 years?
The
Short
changes
answer.
Change is from patient's perspective. They want their disease to be now more clear, and they are willing for systemic therapy even moderate to severe disease when body
Right.
surface area is 5 to 10%. Whereas
Right.
perhaps around 15 years back, we used to treat severe psoriasis with body surface area more than 20-30%. And the even milder form of psoriasis, the atypical variants have increased. Many a time you
Right.
suspect eczemas or something else, but it is
Yeah.
psoriasis. So,
Right.
and unstable forms of psoriasis has perhaps become relatively more common because
More
patients are subjected to many alternative therapy, complementary therapies, and they
Right.
make disease unstable or atypical.
Excellent. Anybody who disagrees?
We also see more cases of palmoplantar psoriasis also. Better
Exactly.
diagnosed nowadays.
Exactly.
Palmoplantar.
And do you see, Madam, at the being with you, do you see an increased frequency of bad psoriasis in your
Yeah, severe
OPD?
psoriasis. Yeah, severe psoriasis.
You're seeing
Much
more. Because
And
Sunil already
unstable also.
mentioned some.
Unstable
You
also.
you see, yeah, that he mentioned. So we
So
are
there is
seeing
a
a change. Yeah, Dr. Shekhar.
there is a very interesting hypothesis written in Rooks. It says that the in prevalence of psoriasis is increasing because somehow it is related with survival. I mean, I don't know how true it is, but it is there in the textbook, sir.
Yeah,
That the prevalence
yeah,
is also
Maybe the multitude of emerging infections across the globe. This might be actually. This is in line
we
with what
can
you
now
spoke, Dr.
see
Muralidhar,
if
during your oration.
I know if we have time, we'll
Genetic
discuss
drift.
this because I had discussed it at length during the oration, but I think
It will be
I
a bit
think
too
the
abstract.
audience fell asleep. So, but we'll discuss this if we have time, okay? Because this is a
Fine.
phenomenally interesting aspect in what is happening in psoriasis.
The patients
Now,
are more conscious. The patients are more conscious of their self-image with this selfie
right,
social media era. So their threshold
okay,
for accepting biologicals will actually be lesser in due course of time. I think at
okay.
least
My
I perceive
question
that.
is now.
Yeah.
My question is to Dr. Shekhar. Unfortunately, I'm going to push things fast a bit so that we complete the discussion. Dr. Shekhar, do you see any change in the way psoriasis patients respond to biologics over the last 10 years of practice?
Sir, I can't really say. I
It's
mean,
a simple yes or no.
initially we used to use only etanercept and infliximab, and now we are using mostly secukinumab. So, I mean, the response it's very difficult to say yes or no to
Okay,
this.
fine. I'll just shift the question to Brijesh because I think he knows what I'm asking.
Again, I have not seen much of a difference. I mean, the only thing is
Okay,
that
okay.
the
Let me
TNF
be okay.
inhibitors.
Let me put the
Okay,
question.
the one
Let me
thing,
put the question.
the one thing which I can comment upon is TNF inhibitors. Whenever they used to give a durable response, those responses used to be longer lasting. The
Right.
secukinumab, over a period of time, the effect seems to be weaning off,
Exactly. This is what I wanted
wearing off.
somebody to bring up.
Swift
You see, the
action, but
disease
waning.
itself, the disease itself is changing, even not only in presentation but also in terms of response. So while the patient responds to therapy, my patients used to respond phenomenally well to therapy 5 years ago to a drug like secukinumab. I find that now within 6 months the disease is back with a bang. And this is something which there are reasons we can sit and discuss it for a very long time, but we need to be aware that the disease pattern and response to drugs is changing, and that is what is driving the development of new drugs. It is not just that pharma companies are forcing a new drug down your throat and paying people to market them. It doesn't work like that. It's
So one
because there
query
is
here.
a fundamental change. Yeah, Brijesh.
One query here. Do you feel that the secukinumab effect wears off faster in a patient who has already experienced TNF inhibitors, a previous biologic?
Yes. My answer would be yes. But
Yes.
I would prefer to find out yes or no from Sunil and Dr. Shekhar.
Yes, and there are studies, many studies, in fact, that in case you give anti-L17 after anti-TNFs,
Yeah.
in comparison to biological naive patient, the response is not that good. So
Yeah.
there are large studies available. Yes.
So if you choose to use a biologic, start using an IL-17 blocker is what we are trying to say, right?
Pretty much.
Dr. Sunil?
Yeah,
Pretty
yes,
much.
yes. If the skin is the main involvement and not the joints.
Okay, my question is to Dr. Shekhar. A patient with
Murthy?
extensive, yeah,
Dr. Muralidhar sir, we are into last
yes,
minutes. Please try to wind up soon.
okay, fine. We'll skip this metabolic syndrome and all that. Now, this is an important thing. A young woman to be married has extensive psoriasis. What is your advice? I will ask Dr. Bela. Simple advice. How will you advise a young woman who has extensive psoriasis? She is going to get married in 3 months. What drug will you give her? I told you cost is not an issue.
So definitely I'll try with IL-17 because I've seen the results are much
Fair enough.
faster.
You'll use an IL-17. No,
Yeah,
because the chairman has asked me to make it faster. I will make it faster. So you will use an IL-17. Fair enough.
yeah.
Will an IL-17 make any difference to implantation or to conception? Because you're
I
going to
think
have to advise her on that.
yes, we'll have to advise against getting pregnant immediately after marriage because this comes with a lot of maintenance therapy, and I
Right.
think she will have to go on with us for at least another 6 months to 1 year. So I will
Okay.
really tell her to observe the
Okay,
contraception
I'll
has
just shift the question to Dr. Brijesh directly now. Dr. Brijesh, will you tell her that if you are planning pregnancy, shift to a TNF blocker?
I will prefer an IL-17 inhibitor again with the similar advice that Dr. Bela Shah gave. Although
No, no.
I know
She wants
I
no.
know
Let
what
us
you're
no.
yeah
Let
I
us
know
let
what
us
you're
say she wants to have a child.
I know what you are hinting at. There is some studies which says that there is an implantation, diminished
Exactly.
implantation thing with IL-17 inhibitors. But still, I will follow the SLE principle here. I'll ask her to be patient, counsel her, and start an IL-17 inhibitor and tell her to first of all get the disease under control, and then let's plan a pregnancy. Although technically, yes, TNF inhibitors might be the better bet. And here, one more thing is, since the patient is desirous of pregnancy, etanercept also pops up into the scenario because it is a comparatively
Okay, if you had all
safer
the
TNF
biologics,
inhibitor.
if you had all the biologics available made for psoriasis with you in India today, which one drug would you give this lady?
If all the biologicals were available,
If they were all available,
Certolizumab
exactly. You will give certolizumab pegol because it does not cross the placental barrier. Okay, this is for Dr. Neeraj. There's a golfer who has extensive psoriasis on the body and extensive nail involvement. Now, what would you look for if he came to you?
Yeah, definitely, because if you have a nail involvement, it's a poor prognostic marker in psoriasis, or what we call psoriatic. Maybe he can develop dactylitis. So you have to suggest
Right.
him a biologic, definite biologic. Biologic can be depending on a shared disease, and either it can be anti-TNF or a IL-17 inhibitor. So I would personally suggest him IL-17 inhibitor because
Right.
his psoriasis is also very extensive, so it will be a better choice.
And why did I say that he's a golfer?
Because he must be an active golfer, and then if he is having a nail involvement, it's maybe a cosmetic issue for him. That may be the reason. I don't know.
More the grip, sir.
So,
The grip.
Yeah,
a
that can.
golfer
Yeah,
won't
that
be
is
able
a.
to.
That is.
No, see, these are patients who actually come to me,
This is a very
and
high
this
impact.
particular
Yeah, it's a poor
industrialist
prognostic.
actually,
Yeah.
he very poor prognosis. He's a golfer, and the thing is, he couldn't swing the club, the golf club,
Yeah.
because
Maybe he must
you
be
have
having a
to
lot of
twist.
enthesitis as well.
He had
Enthesitis.
he had enthesitis. He had
Yes.
ankylosing spondylitis type of arthropathy, which was very early, but we put him on infliximab at that time.
Yeah,
That's
agree.
what I did because I didn't feel that secukinumab will do the job. So I put him on infliximab,
Because
and he's doing very well.
if you ask me, the best debulking agent is still infliximab IV. It's we call it as a magic drug. If we extrapolate data from other rheumatological conditions like ankylosing spondylitis, rheumatoid arthritis, for us infliximab is still the wonder drug. We call it as a magic bullet.
Maybe the one molecule which I would like to have in India is ixekizumab. I mean, maybe the alternate
It's coming.
molecule
It's coming. It's coming.
which might
It's coming.
which might compete in efficacy with the
With
infliximab. Might be
Now I'm
efficacy.
going to stay with Dr. Neeraj Jain. Dr. Neeraj, if a patient comes to you, how often do you see psoriatic arthritis without psoriasis patches?
Yeah, this is very quite often actually. We get patients with predominantly musculoskeletal manifestations and having a silent psoriasis actually. So then we have a choice after we diagnose and evaluate. Then we have a choice of either anti-TNF. But if you ask me, I am very clear now. If you have a psoriatic arthritis, if it is labeled as psoriasis with arthritis or psoriatic arthritis, whatever you label him, I will use an IL-17 inhibitor first. That's
No,
clear
my
now.
question to you is very simple. Actually, what I am aiming at is, you see, if there are no psoriasis patches, there's no nail involvement, nothing is there, will you give a steroid to this patient?
No. We are very clear. We use very low dose steroid for a short time in psoriasis, history of psoriasis, because we are very scared of layer of skin diseases with steroids.
Okay, excellent. This
In addition, in that particular scenario, it is always a good idea to check the scalp because scalp psoriasis is associated with arthritis. And
there was a question, but I skipped that.
The patient will not mention
Not tell,
anything.
definitely.
Dandruff.
You have to look at the scalp, you have to look at the gluteal cleft
Genitalia.
also.
Hidden
These
sites.
are two areas. These are hidden sites. I just want to move fast, and so I skipped that question. Now, this was asked before, but somebody mentioned something. Any one person, Dr. Sunil, just take it up. How long do you advise your patients to take a biologic?
We tell our patient that if we start biologics, it will be at least 6 months that you would have to take when there is a financial considerations. But in the beginning of the meeting, we said there are no financial considerations. Ambani is sponsoring this talk. All right. Then we continue maybe at least 6 months to 1 year, and then we do shift them to oral systemic therapies like maybe apremilast or low dose methotrexate if the disease is not very severe. And some patients are able to afford, though it is offline to give them prolonged duration of biologics, but that also we have practiced. Like instead of 1 month, we have given them once in 8 weeks also secukinumab, and the remission is maintained. So it varies from patient to patient. But we can continue for up to 1 year, 2 year also.
Right. Now, I have a few questions which I would like to take up, which the audience has sent, because it would be unfair to the audience otherwise. All of us talked about tuberculosis. How many of you saw tuberculosis in your patients who took biologics?
Since I err on this discordance principle that even if one of the tests come out to be positive and I give prophylactic ATT in all my cases, I have not seen a single case. Touch wood.
One case of tubercular lymphadenitis.
One case of tubercular lymphadenitis. Dr. Sunil?
One case of TB lymphadenitis on adalimumab. And one case of pulmonary TB with infliximab.
Dr. Bela?
I have not seen yet any tuberculosis.
Now, I have seen 2 patients of tuberculosis who were receiving infliximab, and that was also lymphadenopathic tuberculosis. Now, Dr. Neeraj?
Yeah, we have seen.
Do you see tuberculosis?
We have seen 3 cases of. We have seen 3 cases of mediastinal tuberculosis. We have seen a lot of mastocytitis. 2 cases of mastocytitis with infliximab, and 2 cases of genitourinary tuberculosis as well with infliximab. 1 case of prostatic abscess with infliximab.
Okay, Dr. Neeraj, I'll just stay with you in that case. Do you really think that the incidence of tuberculosis in patients who are receiving biologics is higher than in the general population?
No, it's almost same. If you see the duration of the illness and the duration of therapy,
Dr. Neeraj, you can be strung up along with me. for saying that.
Yeah, I
But
don't think
please
there
say
is.
it.
Yeah, because what we are following is that we are doing a very strict pre-biologic workup like MON2, quantiferin
Yeah.
gold, XHS. If either of it is positive, we go for a CT scan of the chest and abdomen. Because what
Yeah.
we think is that if we are offering a good 1 lakh, 2 lakhs therapy, there is no harm on doing a CT scan chest and abdomen. So
Yeah.
strictly, we have a data of around 600 plus patients of biologic in the last 10 years, and only
Right.
touchwood 8 or 10 patients had some issues, and 3 or 4 had tuberculosis. So I don't think if you
And
do a good biologic
and
workup.
and one interesting factor I'd like to give you is that in the last 3 months, India has recorded 150,000 cases of tuberculosis. They
Okay,
were not on
amazing.
biologicals.
Yeah,
So the
definitely.
incidence of tuberculosis is much less,
Less.
contrary to public expectation, and there is a whole, I would say, there is a cacophony of noise against this and about this, but it's not so great. The last
Yep.
question is going to be biologics in the COVID era. I would like to take Dr. Sunil's experience, because he's in a hospital which is seeing COVID. Dr. Sunil, what is your take on biologics in the COVID era?
Okay, as far as the recommendations goes by most of the societies and our practical experience also, we are not stopping biologics in all the patients because of COVID. Only in patients who have respiratory symptoms and who
Yeah.
are on biologics going on for last say few months or years, we are continuing it. But we are taking a decision in patients who are elderly, say more than 60, who
Yeah.
have comorbidities, who
Yeah.
have symptoms pertaining to respiratory tract, and who live in an
Yeah.
area where there is increased risk of COVID exposure, say who are working in the hospital or who have family members working in the COVID area. So in those
Yeah.
patients, we are taking a call to stop biologics for some time. Otherwise,
So in high risk areas, you are
yes,
considering
yes.
temporary withdrawal.
And
Right.
patients who are elderly and who have comorbidities. Otherwise, we are not stopping or considering to stop in all the patients.
Great.
Thank
I'm
you.
very happy you gave. Anybody else has to add something to that question on
I will.
COVID? Because
Yeah.
there are a couple of questions I've got
And the
on
patients
COVID.
who have malignancies these days.
Yeah.
Yeah.
I will add a
Because,
few lines to it. Actually, I agree with Dogra sir. Only thing is
yeah,
that we are avoiding rituximab in other rheumatological spectrum diseases. And if patient is
that's
on
true.
IV infliximab and something like IV medication, we have switched them to subcutaneous drugs. For ankylosing
Yeah.
spondylitis, patient is on infliximab, we have shifted them to adalimumab or even the IL-17 inhibitor. So, but we have not
IL-17.
stopped that, because if you stop, the disease flares up and they are more in trouble actually then.
Yes.
Okay,
Dr.
fine. I
Murli, we have
think we
overshot
are
by around
running
12
short of
minutes.
time.
Yes,
We
sir.
are
I'm
we are
already
running
overshot by
short
12
of time.
minutes, sir. Please.
No, I think we are running short of time. So don't you think it will be right for me to close it here, because you can keep going on?
Definitely.
So
Definitely.
I would request Dr. Gurvinder to give me the guidance on whether to go on or cut it here.
Sir, this is a very huge topic and we can go on for hours together. But we are
Definitely.
already overshot by around 15 minutes. So I think we should now
I am
wind
sorry
up.
that I overshot, sir. We tried to keep it as crisp as possible. I would like to thank Dr. Archana, Dr. Sham, Dr. R.P. Gupta, who I have great personal respect for, and of course my good friend Dr. Rohit Batra for making this possible. I'd like to thank the chairpersons, Dr. Gurinder Banga, Dr. Ramesh Bhatt in absentia, for agreeing to chair this session, and my excellent team of panelists who put up with me and gave very precise and crisp answers. I have a lot of questions, but most of the questions were covered in the discussion itself. So I am very hopeful that the audience who are here, I don't know how many are left, only Rohit can tell me that the audience are here, how much take-home points have they got, because we try to keep
There are
it
still
as practical as
1600
possible.
viewers at this moment. We had total of 3800, and right now
So
also
I chased away
1600
half.
viewers.
So we chased away.
And sir, and one point I wanted to make here. This is the first time I have seen you actually use a PowerPoint for a panel, sir. Dr. Muralidhar.
Oh, I've
I
been
don't know.
using
I
it
don't
quite
know.
commonly.
For a panel.
Yeah, we've been doing a lot of it. It's fun.
Extempore, basically.
Yeah. No, because it is Das, and I felt it will be difficult to control time. I thought, let me label the questions and the case scenarios. I'll hand over
No, it was great.
the mic.
Plus the
I'll
It
hand
was
over
great,
the
Murali
mic.
sir. Great.
Plus
Thank
the
you, Dr.
I'll
audible
hand
audio.
over the mic to the chairpersons and
Thank you,
Dr.
sir.
Rohit and Dr. R.E.P. Gupta. I thank my panel sincerely. They're
Thank you so
wonderful
much.
people.
Thanks to all panelists.
Thank you, sir. Thank you, sir.
Thank you.
Thanks a lot, Dr. Murli, Rajgopalan sir, and all the esteemed panelists. For the last question of the day for audience, I would like to ask a question on this topic itself, biologics, and you know by now how to fill in the answers. So let's go on to the question. Pridrelizumab, guselkumab, and risankizumab are drugs approved in past 2 years for psoriasis. They are new drugs. Name the specific target of these antibodies. Okay. Your time ends now. Okay. So the answer is P19 subunit of IL-23. So those who have given the complete answer would be considered during that 10-second period. While we are trying to access our database of people who have answered correctly, I would like to call upon our next speaker. Yes. So Dr. Sri Kumar Goturu is a seasoned consultant dermatologist in practice for past 20 years in Dubai. He has a special interest in allergy and immunological dermatological diseases, and he has a very interesting topic to talk upon, that is the pressing importance of time in management of atopic dermatitis. Over to you, Dr. Sri Kumar.
Thank you very much, sir. Thank you for this second opportunity. In fact, I do hope the slides transit properly. As a warning, I have 2 sets of slides prepared right now. One with my video and audio. If that works well, I will continue with that. Otherwise, I will shift to my basic deck. So let me start sharing my screen. My journey as a dermatologist has had many moments of harsh reality. One that stays in my mind is the of an 8-year-old who underwent a bone marrow transplantation. Unfortunately, her transplant did not take, and she had to undergo a second transplant. Doctor, please don't do a skin biopsy for me. This is what she told me. I don't have much time to live. These words echo in my mind even today. But fortunately, down these years, we have had so many new developments, and with the advent of new biologics, we now are in a position to make a huge difference in the lives of our young ladies who have spent and itching, spending sleepless nights and wasting her time over this, and the difference we could make with the new biologics today. At the age of 27, she's Am I audible? Yes,
You
sir.
are audible. You are audible, but the slide
After-
has stopped again. I
Or
think
the
there is
newly
some problem
available-
with your connection, Dr. Gotru.
Despite being apprehensive about it being a lifelong injection, I was told that it would take my system 16 weeks to see a 70% relief, but it took me 6 months, she said. She had redness of the eyes, which was treated by an ophthalmologist. My eye pressures became normal as my need for The amazing thing was she suddenly met her dream guy and got married. One request during this amazing transformation was interesting. She said, "Doctor, can I take the injection every 10 days instead of 2 weeks during my marriage and honeymoon?" It seemed a minor flare had emerged just a day or two before her bi-weekly injection was due. I remembered Professor Emma Gutman discussing the trials with dupilumab when I met her at Mount Sinai Hospital, and the fact that weekly injections had been part of the study with results which were slightly superior, though not showing statistical advantages over bi-weekly injections. Moments like these are transformative, and we are blessed to be in an era where we are able to touch people's lives more frequently. I do have a practice with a large number of psoriatic patients too on biologics, and the incredible speed, faster than cyclosporin, with which even an erythrodermic patient can be revived is exhilarating. We have been running a psoriasis support group and are starting an immune-mediated inflammatory disorders center at Amber Clinics in Dubai, UAE. The greatest pleasure is the life-changing care we are able to deliver. Traditional management strategies involve using moisturizers and emollients, avoiding triggers, using topical corticosteroids creams, and sometimes calcineurin inhibitors. Sedative antihistamines are commonly used, which impair the cognitive ability of a person. The amount of time lost in being productive in various ages of life is incredible indeed. A look at the treatment options available at present reveal topical, phototherapy, and systemic options. Except the topical treatments which are licensed, most of the other treatments except the new biologic dupilumab are not licensed. In moderate to severe atopic eczema, there may be a need to use systemic therapies. The conventional systemic therapies, most of which are not licensed except cyclosporin in a few parts of the world, have a lot of precautions and warnings attached to them. Compared to that, dupilumab has only a hypersensitivity warning and conjunctivitis listed in it. Looking at the unmet needs in our management of atopic eczema, the 4 most important points which come to mind are a mode of action which specifically targets key drivers of the persistent systemic inflammation in atopic dermatitis, a need for a medication which can be used systemically, reduces the need for time-consuming applications of creams and lotions, which is easy and convenient to administer, and which is highly effective and can reduce not only the signs and symptoms, but makes a huge difference in the quality of life of the patient. And of course, if safety is thrown in, what more do we need? Atopic dermatitis is a very common condition. The incidence and prevalence are far more than psoriasis. In fact, even in adults, a prevalence of between 2 to 10% has been recognized. If you look at the number of patients who require systemic therapy, it's quite huge indeed. In adults with moderate to severe atopic dermatitis, the underlying chronic persistent inflammation is not adequately controlled in spite of treatment in nearly 30 to 50% of the year. If you look at this curve, you can see the number of flares are so frequent that nearly half the lifetime of a patient is lost. The challenge of long-term control is so frustrating. The disease burden of atopic dermatitis not only involves the frequent and intense itching, but also sleep disturbances, both in terms of falling asleep and frequent awakening, impairment of work productivity, absenteeism and presenteeism, mental health disorders including anxiety and depression, frequent and persistent signs and symptoms because of frequent flares, a massive impairment on the quality of life, and comorbidities including other atopic disorders. A really good assessment not only involves assessing the clinical signs, but also patient-reported symptoms, the impact on the quality of life, and long-term disease control. Ipilimumab is a fully human monoclonal antibody of the IgG class, which targets the alpha receptor of interleukin-4, thereby blocking IL-4 and IL-13. It is the first biologic which is licensed for atopic dermatitis. New insights into the pathogenesis of atopic dermatitis have been very exciting indeed. We all know that there is an impairment in the barrier function of the skin. Of course, there is a genetic predisposition and a huge genetic heterogeneity. And of course, we know that there is an aberrant inflammatory immune response in the skin. But the central role played by the type 2 cytokines are being recognized very well of late. And we know that with the advent of a new monoclonal antibody like Ipilimumab, it is possible for us to target very specifically the cytokines involved in this chronic inflammatory process. The type 2 inflammatory response involved in atopic dermatitis is quite unique. Phase 3 trials have demonstrated improvement in the EASI scores from baselines by week 52, a 60% reduction in the pruritus intensity, and an 80% improvement in quality of life measures in atopic dermatitis patients treated with Ipilimumab. This is the Corona study demonstrating the nearly 80% mean percentage improvement in the EASI score from baseline to week 52, demonstrating a 60% mean average improvement in the numerical rating scale of itching by week 52. And of course, a 80% of patients showing a clinically meaningful improvement in their quality of life, which is sustained by week 52. As per label itself, there is no organotoxicity seen with Ipilimumab, and there is no need for any investigations either before starting or while the treatment is going on, unless clinically indicated. In fact, in patients with concomitant asthma, there's a significant improvement of both the atopic dermatitis and asthma in patients on Ipilimumab. The only issues seem to be minor injection site reactions and eye reactions. Anti-drug antibody formation with Ipilimumab is extremely rare, and neutralizing antibodies even rarer. The impact of this is that long-term sustained improvement is easily achieved. Novel insights into the pathophysiology of atopic dermatitis have resulted in an evolving therapeutic landscape with a number of new therapies in development. Ipilimumab was the first of these to be licensed. New therapies are directed at addressing specific type 2 immunomodulation, specific cytokine targeting, broader targeting of several sign axes. These treatments, coupled with biomarkers, will further inform us on the atopic dermatitis phenotype in various atopic dermatitis subtypes. Of course, currently Ipilimumab is approved for adults above 18, also for adolescents 12 years and above in the United Arab Emirates. But in the USA, a recent approval has been obtained for children above the age of 6 too. If you look at the pathophysiology of atopic dermatitis and the way Ipilimumab acts on the type 2 inflammatory response, you can see that it works not only on the acute eczematous skin but also on the normal skin. Also in the chronic lichenified areas, you can see the improvement in the lichenification, which I thought would never occur. Of course, even the normal skin is less likely to be prone to infections with dupilumab. My bibliography, of course, transforming atopic dermatitis is very much on the agenda of dermatologists throughout the world, and these are exciting times indeed. With the advent of new knowledge and with the explosion of new molecules, both topical and systemic, the time we will be saving in management and the time we save for our patients is going to be incredible indeed.
Well, let me conclude by saying that the DALIs and the QALYs, the disability linked life years and the quality of life are very important, and we know that the quality of life is extremely impaired in patients with atopic eczema. In fact, there have been comparisons to psoriasis, there have been comparisons to even coronary artery disease. So the most important thing about atopic dermatitis is that the patients keep itching, they spend sleepless nights, they have poor interpersonal relationship, there are family issues, there are issues with sex, marriage, work, you name it. And not only that, the amount of time it robs from the patient with happiness, with smiles. See, you can't keep on putting moisturizers and creams and taking antihistamines. It's high time that we give a much better treatment. And I must say that we are in an era when there is an explosion of new treatments. Dupilumab is, of course, the first and only biologic approved as of now. I have quite a number of patients on it, but believe me, a huge number of agents are coming up. And many of them aim at improving the quality of life drastically, saving the life of the patient. Saving life is, time is a very, very, very important aspect of our treatment. Just imagine the amount of time we spend counseling, the amount of time spent on avoiding this, avoiding that, trying to find a trigger. The time saved by the new treatments are in fact the very essence why we are here today. In fact, as dermatologists, isn't it our duty to give the best possible result for our patients? And now we are in an era where we can do it. And therefore, we need have no further hesitation in adapting to these new technologies. With that, I will rest. Thank you very much. I hope the presentation was audible. I wasn't too sure. I had a lot of technical glitches. Thank you very much.
The presentation was indeed wonderful, sir. We are thankful to you and also to the technology gods to let that happen, and we could witness such a wonderful work which you've done. Thank you. Thank you so much, sir.
May I ask one question?
Yes, ma'am, please.
Yes.
What is the age of the youngest patient that you have used dupilumab?
In Dubai, we cannot use it off-label. So as of now, 12 years and above is the time when we can use it. So I have a patient who is 13 years old on dupilumab. I have a lot of patients who are adults on dupilumab. It produces life-changing results. I am tempted to use 6 and above because FDA has given approval for 6 and above, but we are as yet awaiting the approval from the DHA here. Only we are hoping that in about 3 months' time, we will get an approval for 6 years and above. But as of now, if I use it in anybody below 12, I am at risk. The courts might take it up.
Yeah, thank you so much for an excellent lecture. Thank you.
I have a question. May I ask, please?
Yes.
Please, sir.
Dr. Sri Kumar, thank you for that disposition on dupilumab. My question to you is, for how long do you expect an atopic to be on dupilumab once you start the drug?
That's a common question most of our patients ask, sir. In the counseling, we tell them, look, we are starting dupilumab for you because your cumulative life quality index is terrible. See, they have spent an entire lifetime putting creams and avoiding things. And therefore, once they start this medication, we tell them, look, you can expect within 16 weeks a significant improvement, even up to 70% improvement. Of course, atopic dermatitis is a lifelong illness, and there is no way we can actually stop the medication. There have been trials where we have tried to actually prolong the duration instead of every 2 weeks, giving it every month. In fact, in the trials, every week was compared to every 2 weeks. Therefore, there are situations where every week is better than every 2 weeks. But unfortunately, the statistical difference between the two wasn't great. Therefore, FDA ended up giving an approval for every 2 weeks. But a short answer for that is atopic dermatitis is a lifelong condition. They need to be treated lifelong.
Does it make any difference to the comorbid conditions of atopic dermatitis, dupilumab?
That's a very interesting question, sir. In fact, most of the patients who are on dupilumab experience a huge improvement in their other type 2, that is Th2 mediated issues like asthma, hay fever, eosinophilic esophagitis, even chronic sinusitis with polyposis. There have been studies which have shown that the improvement in both the dermatitis and asthma is significant. One of the things is that if you have a patient who has an atopic dermatitis and a comorbid asthma, and he is on treatment for asthma and he is prone for status attacks and all that, we should make sure that we communicate to the patient that dupilumab, even though it improves their dermatitis, doesn't mean that they can stop their other treatments for asthma. In fact, we need to liaise with a pulmonologist and to slowly taper those medications once a good control with dupilumab has been achieved.
Thank you, sir.
Okay, so with that, we come to the end of the day first, of the first Sunday of DAS, 7th DAS Summit. Just to announce the 5th question, the first and the correct entry was sent by Dr. Parmeshwar Biradar from Davangere. Congratulations, Dr. Parmeshwar. You would be contacted by the Lupin team and they would hand over the gift to you. And I hope to see you all next Sunday at same time, 9 a.m. onwards, for the second day of the DAS Summit, 7th DAS Summit. See you all. Thank you. Bye.
Thank you very much. It was a wonderful opportunity.
Presentation sounded really.
Oh, yeah. The technology is good.
Recording has stopped.
How to stop the share? And see the cursor.